Welcome to the first hearing of the Select Committee on Birth Trauma. This inquiry is examining the experience and prevalence of birth trauma across the state. The inquiry will address the growing concerns surrounding the rates of birth trauma and consider what legislative, policy or other reforms can be enacted to prevent birth trauma. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians on the land on which we are meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the land and waters of New South Wales. I also acknowledge and pay my respects to Aboriginal and Torres Strait Islander people joining us today. Thank you for attending today's hearing. Owing to the nature of this inquiry, I would like to warn those in attendance and listening to this recording that evidence presented today may contain sensitive content or themes. If you feel distressed as a result of the inquiry's sensitive content and themes, please contact one of the resources available on the committee's website. Before we commence, I would like to mention that the committee has received over 4,000 submissions. The committee would like to thank all individuals who have contributed to the inquiry. Sharing your story will help inform the committee's understanding of the issues. Given the large number of submissions received, the committee is prioritising the processing of individual submissions received from individuals based in New South Wales. The committee will then move on to other submissions received from individuals based in other states. Interstate submissions will be accepted by the committee and likely be confidential due to resourcing constraints. Today we will be hearing from a number of stakeholders, including New South Wales Health, birth trauma and maternity organisations, expert bodies on obstetrics, gynaecology and midwifery, as well as legal experts and representative organisations and associations. While we have many witnesses with us in person, some will be appearing via video conference today. I thank everyone for making the time to give evidence at this important inquiry. Before we commence, I would like to make some brief comments about the procedures for today's hearing. Today's hearing is being broadcast live via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available. In accordance with the broadcasting guidelines, the House has authorised the filming, broadcasting and photography of committee proceedings by representatives of media organisations from any position in the room and by any member of the public from any position in the audience. Any person filming or photographing proceedings must take responsibility for the proper use of that material. This is detailed in the broadcasting resolution, a copy of which is available from the Secretariat. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the hearing. I therefore urge witnesses to be careful about comments you may make to the media or to others after you complete your evidence. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it is important that witnesses focus on the issues raised by the inquiry terms of reference and avoid naming individuals, hospitals, medical facilities or workplaces unnecessarily. All witnesses have a right to procedural fairness according to the Procedural Fairness Resolution adopted by the House in 2018. If witnesses are unable to answer a question today and want more time to respond, they can take a question on notice. Written answers to questions taken on notice are to be provided within 21 days. If witnesses wish to hand up documents, they should do so through the committee staff. In terms of the audibility of today's hearing, I remind both committee members and witnesses to speak into the microphone. As we have a number of witnesses in person via teleconference, it may be helpful to identify who questions are directed to and who is speaking. Finally, could everybody please turn off mobile phones to silent for the duration of the hearing. I now welcome Dr. Jared Watts, who is joining us via teleconference. Dr. Jared, could you please state your name and position title and swear either an oath or affirmation? So, Dr. Watts, do you have either the oath or affirmation available?
I do apologise, I just lost internet for a few seconds. So is that for me to read now, sorry?
Yes, please, if that's fine.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Dr. Watts. Would you like to start by making a short opening statement?
Sure. So RANZCOG would like to thank the New South Wales Select Committee for your review of our previously provided submission and the opportunity to further present to the committee today. In regard to birth trauma, RANZCOG acknowledges the physical and emotional trauma that many women and their families have experienced during birth. As a result, and leaders in women's health, we've undertaken a number of projects in this area with the aim to both prevent and assist women who have experienced this pain. We welcome the New South Wales Government and Members of Parliament's passion and drive now to assist in this process, which we hope will see result in additional funding and research, as well as policy and legislative changes, and we will see a difference that extends out to all women and families in Australia. Ranscog believes that the solution requires continuing to listen to women, further research, and a multidisciplinary team effort to address this trauma. Just like for birth, there won't be one option or one solution that fits all, but will require multiple approaches to ensure, as the WHO states, that every woman has a positive birth experience. Whether this is a home birth, a maternal requested caesarean section, or an unplanned emergency instrumental assisted birth. Ranscog has ensured this women-centred and multidisciplinary approach is now our core business. We have a network of independent consumers who are paid by the college to review all our policies and guidelines and to meet and interact with our board. We ensure our guidelines are also multidisciplinary, with our terms of reference ensuring midwifery representation on writing and review committees for each obstetric guideline and other disciplines as needed. As the term of reference for this review committee also notes, we also agree there are added challenges for our First Nation, rural and culturally and linguistically diverse women, as well as transgender and gender diverse people. We have therefore undertaken work in this area with the OGET project for rural multidisciplinary training, working with AIDA to ensure all our trainees have a deep and detailed understanding of cultural safety, an online program for LGBTQI+ care for all members, and webinars in gender diversity. In addition, we've listened to patients that are often given conflicting information in antenatal care, and we're proud to be working with Monash University and the Australian College of Midwives to develop living guidelines for antenatal care, and to have our Vice President, Dr. Nisha Knott, with the Australian College of Midwives Vice President, Dr. Zoe Bradfield, as co-chairs. We would welcome the opportunity to expand these programs with health service providers, other professional colleges and government departments to immediately start addressing birth trauma, as well as work on longer-term changes. As in our submission, we do note concerns with the term obstetric violence. While we understand this is an international term, we acknowledge that language is important and can often hinder a solution. Just like the term normal birth has undergone significant recent change, including by the WHO, we feel the term does not correctly define the issue and does not assist in a solution. We outline the reasons in our submissions and willing to explore today as the committee desires. Finally, obstetrics is a challenging area of medicine, and it can be said that as a society we've neglected research into women's health, and we're now seeing the consequences. The technology we have has limited specificity, and pregnancies go to low to high risk within seconds and without warning. We have the conflict between legislation regarding consent and providing care, the difficulties of working in high stress and often emergency situations where minutes can literally mean life and death. Therefore, we welcome the committee's review into these challenging areas and their assistance by developing recommendations to ensure every woman has a safe outcome and a positive birth experience.
Thank you, Dr. Watts. The committee has passed a resolution that we will be splitting questions in a free flow format. So I'm now looking at the committee to see who is keen to ask some first questions. Thank you, Deputy Chair, Honourable Susan Carter.
Thank you, Dr. Watts, and thank you for the submission that you provided. I note in the submission that Ranscog says that obstetric specialist care models have the lowest birth trauma rates. What barriers exist to stop all women being able to receive this type of care if it has the lowest birth trauma rates?
So with the research that has come from a survey by the Australian birth trauma issue that's showing that private obstetric care, which is obviously, a very intense sort of program. And so, we would like to sort of see that, this continuing care of, a single model, whether that's midwifery, whether that is obstetrician, would definitely be, but it's going to need to have policy changes, increased infrastructure resources, because at the moment, we all can walk into a big tertiary hospital where there are multiple women stating, waiting to see an antenatal care, and they may see, we may be seeing women only once in their pregnancy, and they may see a different provider each time. So I think that, it would be something that would be fantastic to be able to have this with everyone who's going to need to have changes in resources to be able to do that.
Can you clarify what sort of changes in resources would be required?
Absolutely. So at the moment, sort of with the number of antenatal care appointments that are required, we do have these big models of large antenatal clinics, and so therefore we would need to have the resources that there is a team or a dedicated person that sees the same person each time. So we'd be looking at MBS item numbers that can be accessed by private providers to be able to provide individualized care. There would need to be even from infrastructure rooms, the amount of rooms in some hospitals to be able to provide these more longer consultations. And we've also looked at, the number of appointments that need to be, provided for each individual patient to be able to provide that one-on-one care.
Thank you.
Yeah, the Honourable Sarah Mitchell.
Thank you, Chair. Thank you, Dr. Watts. Sarah Mitchell here. I just wanted to ask a question in relation to your submission where you talk about making some more education resources available for patients, particularly around things like evidence-based birth plans. And that was a bit of a theme that has been recurring in the submissions around what information is provided before pregnancy, and I guess what are realistic expectations of what can maybe happen during labour and giving birth. Could you talk a little bit about how you see that process working now, particularly around those prenatal care and information, and maybe how we could suggest that be improved?
Absolutely. So this sort of came out of that we, at our most recent annual scientific meeting of RANZCOG, which was our largest one ever attended, we had a whole session on birth trauma, and we had the consumers come to speak to us, and they were sort of speaking to about, the amount of information that they received before. So when they were actually needing to make those decisions in labour, and sometimes, it can be required, to make quick decisions, that they had that information beforehand. And so for us, what it would be is, it's not a very nice thing, to be talking about to women who are already maybe a little bit concerned, but actually discussing with them, what is a forceps, what is a vacuum, what happens in an emergency cesarean section. And in my job, I do a lot of counselling afterwards of what women, and they just don't, we haven't told them beforehand what could actually happen in an emergency situation, and they become, traumatized by it. And I can understand why they're so concerned. An example just can be, one of my patients, like, why did there be so many people in the room when I need to have a vacuum? Because, the paediatric team came in as well. And we thought the paediatric team coming into the room so they could resus the baby in front of the mother, so the mother sees the baby, right, would be the best thing to do. But obviously she didn't realise that they were coming in for that reason. And when we explained this to her afterwards, she's like, well, oh, that actually makes sense. But, we're not sort of giving women the information, so they're becoming stressed at the time. And, to sometimes explain why, sometimes, we have to use a forceps over a vacuum or vice versa, so when you need to do that in the room, it's not just sort of trying to give them in 2 minutes we need to do that. But, they have they're empowered beforehand, so they don't have that traumatic experience at the time.
Thank you.
Can I jump in? Just thank you very much, Dr. Watts. Just in following on from education, I'm interested if you have any research around the Cole community and also Aboriginal and Torres Strait Islander and the information that's provided and what more needs to be provided to tailor to meet those community needs.
Absolutely. So with Aboriginal and First Nations women, I think that antenatal care needs to be provided by the appropriate person, and hopefully we can recruit Aboriginal health workers and Aboriginal midwives that can give this in a culturally appropriate way. So this might be looking at gender. I work primarily in Aboriginal health, and we make sure that there is the way in it's given without certain males in the room can be quite important. We have RANZCOG is actually looking at information leaflets at the moment, because we have in review of them by our consumers, they are all Caucasian women, and so we've actually redesigning the forms to show Aboriginal women, because Aboriginal women sort of said to me, well, this doesn't apply to me, it's a Caucasian woman. So we're changing our resources to actually demonstrate Aboriginal women. We're changing the language of them, because obviously the words that are used are very different, and then making sure that they are appropriate languages as well, because we know that we have so many languages in the Aboriginal culture. I think these ideas extend over into the culturally and linguistically diverse as well, to make sure that they're represented in the in the posters and the information as people that they see the photos of people of their culture and everything, and also to make sure that the language is in their appropriate in their language, and they have access to and they know where to receive that information.
Dr. Amanda Conn.
I have two questions, if I may.
Of course.
The first one's about technology. Dr. Watts, the submission talks about consideration of better and more updated technology in the context that CTG monitoring might be overcalling fetal distress and leading to more interventions. There's also other submissions from other bodies that talk about the CTG monitoring actually being really restrictive and stopping people from freely moving around during birth, and that being part of the trauma. I'd be interested to know more or understand more about where the research is at and what promising or emerging technologies might exist to replace CTG monitoring.
Absolutely. So a little bit of background, the CTG machine, it is the best that we have that, detects a fetal heart rate. And, as a world of obstetrics, we've tried to improve over the number of years using artificial intelligence and sort of different ways of actually monitoring baby's heart rate. But we do know that it overcalls it. But unfortunately, we don't know when it overcalls until, there is evidence that we probably do a few more cesarean sections because we don't actually, the machine is not good at saying, look, this is definitely a baby in distress, but it's the best we've actually got, and we could never go back to not actually using it. So I think there's two aspects. So one is that to make it more appropriate for women in labour. And we have now sort of these the midwives are experts on them, and they like a sort of more of a Bluetooth thing that can actually stick onto the skin, and so therefore they're able to move around. They're able to actually some of them are waterproof, so they can actually get into the water. These are quite expensive, and once again, I work primarily in rural areas, and to have access to these quite expensive technology is really hard on small hospitals. And so having the availability for every woman to have this sort of available technology, so the CTGs can be still allow them to move around and get into positions that they feel comfortable with. The second one is, it's not the most accurate. How can we actually do it? I do know that there are groups that are looking at more direct ways of measuring fetal areas. Obviously, they're not releasing exactly information because it's sort of tech thing, but we appears to be mainly measuring the lactate. So if we do worry that a CTG is showing that a baby's showing signs of distress based on the CTG, we can sometimes take a little sample of blood just from the skin on their head, and we measure the lactate or the pH, and we believe that there is evidence out there that companies are working on technology that can maybe do this continuously, and then hopefully with the development of this we can just be so much more accurate, and we can say, look, this is a baby that's in distress. There's there's more evidence for it. We can then have our interventions based on who actually needs it, and we don't overcall it, because it's hard if we want to make sure that you deliver that baby safely, and if it overcalls, it is an issue.
Thank you. My second question is there's a number of other stakeholders who've raised concerns that the rate of various interventions has increased while perinatal mortality hasn't decreased. And I was hoping for your opinion or comment on why that might be the case.
Absolutely. So look, there's some things. So once, if you look at the Australian Institute of the Research, we see that vacuums and forceps actually stayed the same. So if you look at sort of the 2012 right through the most recent one, vacuums and forceps have stayed around about 7%. I think there's only about a 0.2 difference. So that is an instrument that I did notice in some submissions talked about increasing, but overall the rate has actually stayed the same. But yes, cesarean sections have increased. I think that there's multiple reasons actually here. One is we do actually have the average age of women having their first baby, and that is the time your first first birth is the most likely time to potentially have a cesarean section. If you're I hate this term, but an older mother, then they're more likely to have a cesarean section. And so we are sort of seeing that with fertility advances, we are having women who are able to fall pregnant with more medical conditions and at a later stage in their life as well. So there is sort of then this evidence that there are more interventions because people are older and more have more health conditions at the same time. So look, I think that you could then say that look, our outcomes are quite stable, and that's quite good. So if our patients are on average getting older and have more health conditions, and yet our outcomes are still stable, then yes, maybe our intervention rates have gone up. There's also a demand in society to have good outcomes in everything, and so there is, and this is one of the things that we are very stressed on, that obstetricians have this idea that under this pressure that we don't want a bad outcome because of the harm to that mother, the harm to that family, the harm to things. So we may actually be a little bit more cautious because of this, and whether this committee can actually make some recommendations in that area, and so that it allows women to have that idea, to have their birth plans that are them-centred, but then also provide protection for the doctor, the midwives, that that if things do go for people that have non-standard management care, that there's not the fear of a long drawn-out process with APRA and medical legal aspects as well.
Thanks.
Thank you. The Honourable Emily Savall.
Thanks, Chair. Thanks, Dr. Watts, for appearing today. I just wanted to ask, given your experience, whether you could describe what your experience is of women that have described birth trauma, and if there are circumstances it's more likely to occur.
Absolutely. So once again, just in my role, you spend a lot of time counselling women afterwards, and it is sort of quite there's so many different multi aspects to it. I think the one that is that is the limited information, so they don't actually have the opportunity to know what is actually happening at the time. And then I think the second thing is that we don't actually go in and spend time with women afterwards at an early enough stage that then they sort of start to think about sort of what actually happened and did they actually cause it. And they start to think over and over again. So look, I think that birth trauma is going to be managed by a few different ways. The first one would be just empowering them with information in the antenatal period, so therefore they can make the informed choices. And if things do not go the way that they wished, that they understand why and they're able to journey through that process with it. Then the options of, once it actually happens, that we have we have clinics set up that women can actually meet the team, within sort of, they can meet them in hospital, meet them only 2 weeks later, so they can go through the process again and process the information. Because what happens now is standard is that we normally meet these women at 6 to 8 weeks down the track after they've had a less than desirable, what an outcome that they actually wished. And they've had 6 weeks of thinking about this, lack of sleep, it affects their bonding with their child, their bonding with their family, and we've really failed to sort of, explain to them what actually happened. And so many times at that 6 to 8 week point where they just go, why didn't I find that out straight away? But, the way that, we don't have access to, psychologists and opportunities to set up these clinics to actually counsel these women straight away, so they don't carry on this burden for 6 weeks, and sometimes they don't even get into these clinics because we don't have enough of them. That it's not until the next pregnancies that we actually have those issues as well. I think the other one is that we need to have these multidisciplinary teams, and so often that some research that a survey that I was looking at from the trauma thing was looking at that midwifery group practice, which is, it's an incredible program, but a lot of women actually do have birth trauma come out of them from their interactions with doctors. And when you actually see what it actually is they're in this room, they're having an amazing delivery and everything's going really right, but then just last minute, the cord goes, it's a rare thing, but the cord goes tight or gets compressed. And all of a sudden there's this, all that the midwife, calls in the obstetrics team, and for the very first time they're meeting the obstetricians when they're to be frank, their legs are in the air, they've never met these people before, they're doing things to them that they don't really understand. And we really need to sort of change this to patient-centred care, like this idea of obstetrician-led care, midwifery-led care, it's sort of, we need to come back to patient-centred care and have multidisciplinary teams, because, we're all needed at different times. And the last thing we actually want to see is, traumatising women when we meet them for the first time, when we are performing a procedure in an emergency situation. So I think that's sort of the two big things that I see is, that counselling, so they don't beforehand with information as soon as they have an outcome that wasn't what they desired, and then that they know all the members of their team, and so that, they're not meeting for them first time in a traumatic situation.
Thanks, Dr. Watts.
The Honourable Greg Donnelly.
Thank you, Chair, and thank you for appearing today. Can I just take you've got before you submission on page 2, where you spend some time dealing with definitional matters around obstetric violence and obstetric trauma. And I'm just trying to reconcile some quite strong language in there about expressed concerns about the terms, respectively, and what's been, if I could use this word carefully, some concession by yourself that there is work to be done to mitigate against the potentiality of this occurring. Can you please explain why RANZCOG's taking such a strong line on its concerns around the definitions?
Absolutely. So we do appreciate that it's in the international literature. It's a term that's used by many organisations. But then we sort of see issues with the actual term for sort of, I think, three main reasons. We feel that they may hinder the actual, getting to the solution for what these women are actually experiencing. And so to sort of just speak those in detail, the first one would be that the word obstetric, even though if you do look into the Latin, the Greek, can't remember which one it is, but it does refer to being with birth. We have seen in some of the submissions that it looks to be appearing towards obstetricians, and we know from the birth study, that was by the University of Sydney, that a lot of the this sort of things, obstetrics violence, has actually come from everyone that could be involved in the women's care, from the doctors, the midwives, the patient care assistants when they're bringing in their meals. We've had cases where they've come in and deliver their meals when they're sort of unexposed and they feel traumatized by that experience. So to sort of say that this is the whole team needs to actually focus on this, is not just obstetrics. The other one then is, and I've discussed it with many of my senior midwifery colleagues, and also they've discussed on one of their birth trauma forums that I've attended, like if we use the word obstetrics, it means that the obstetricians are the ones with the solution. But they've actually also said, look, if we actually say that, use a term that sort of involves everyone, then, it's all of us need to come together to solve this issue that, if you look at the University of Sydney's data, 1 in 10 women are actually experiencing. So we sort of need to define it as a term that, encompass the actual issue. The next one is that there is also, the words, the violence, if you look at we spoke about it, the intent, and I like that one of the submissions is, so no one goes to work to cause trauma. And I think that, when obstetricians hear this thing about obstetric violence, we find that, that can't be us. We spend 6 years at med school, 6 years to 9 years of ONG. We're trying to do the best for our women. And people turn off when you hear this obstetric violence, because it's such a term that we find so, that can't be us. And so if we need to come to the party and actually work out a solution for this, we need to use language that it engages the doctors. There's also some international literature I've seen about, that neglect in labour. So, that's not going to be obstetric violence if you're left alone or you're not given food. So that's another thing that, violence is sort of seems to be an active process, but we need to look at, are we making sure women have the support while they're in labour? So there's a whole thing. So look, there is some views in such as mistreatment in labour, mistreatment in birth, that sort of does appear to be sort of define the issue as well, but sort of, and also bring in all the obstetricians, bring in all the parties together so we can come together to work out a solution for what these women experience and to hopefully resolve it.
You've referred to the University of Sydney study, but no doubt, Doctor, you're aware of the study which is generally referred to as the Keedle et al. Study 2022 around the birth experience study, which has received publicity in this inquiry, and also we've had the opportunity to look at the paper that had been produced around the study and a summary of it. Are there any comments you would like to make about that study?
I do apologise that I've read many things today. Could you just expand which study that is? I'm so sorry.
It's
I think
study
it is
from
the Western Sydney one that he was
The
referring
best
to.
study,
It is
yeah,
best-
the best study.
capital
Best
B,
study, yes,
capital E,
one from
capital
university.
S, little t study,
Yes.
the birth experience study.
Yes, absolutely. So look, this study, I think, we definitely congratulate the authors. This is the biggest study that, has actually had a look into it. And, I think that any patient that is experiencing this trauma, we should be worried about. I think that we do need further research. This was sort of a survey-based study where, it was through social media and things that the patients were actually recruited, and, working mostly in in rural and remote areas myself, that, to try and, to make sure that we actually access those Aboriginal women out in those remote communities, we do actually need further research rather than sort of, surveys that are based on social media. So I think it's absolutely the best we've got. I would say that, based on surveys, we probably need further research that is sort of based on, look, here's 1,000 women, let's have actually ask them, let's go into detail about what they've actually experienced in birth, and so we can come to some of the solutions as well. So,
are you actually criticising the methodology of that piece of work?
I'm not criticising because it's the best we've actually got, but, we'd sort of say to look at the percentages and everything like that. It was based on, recruitment through social media, people that went to see the video. And so, we sort of, it could be underestimating the birth traumas and things like that as well. We would say, this is the best we've actually got this survey, and but we would call for more research in this area to see, what the actual rates are and what the actual causes of this problem are as well.
Sorry, the Honourable Anthony D'Adam.
Thank you, Dr. Watts. I wonder, have you actually read the submission from Western Sydney University that's part of this inquiry? Have you had that?
Yes, I have.
Yes,
yeah.
Okay. I don't know whether you've got the submission in front of you, but there's a graph on page 16 that deals with types of birth across models of care in New South Wales, and this question's probably an extension of the question that was asked by Dr. Amanda Conn earlier, but it paints a pretty concerning picture about private obstetricians in terms of the probability around the likelihood of having caesarean section. And it seems that from this data that you're more likely to have a caesarean section rather than a vaginal birth. I wanted to give you an opportunity to perhaps offer some comments about that and whether you think that's an accurate picture in terms of the role of private obstetricians.
Sure, absolutely. So look, I'm not a private obstetrician. I work purely in public. But we do know that, the private hospitals do have a higher rate of caesarean sections. And quite often there is, if you do look, there is the maternal requested caesarean section that do come from a lot of these patients. Patients, previously trying to get a maternal requested caesarean section maternal elected caesarean section in a public hospital was something that didn't exist until more recently. And RANZCOG has recently just released a paper about this only in the last couple of weeks, or a guideline, sorry. And so a lot of people would actually go to the private system where if they wanted to have a caesarean section, for maternal request reasons, they would actually do that. So we do actually see a higher rate, and there is, evidence that would be coming also from patient request. We also do know that patients that use this service with private health insurance are older, and so therefore we do know that the risk of a caesarean section is also higher for older mothers, and there's some physiological reasons for that, and so they would be sort of potential reasons that we are also seeing a higher rate of caesarean sections in the private sector as two of the main reasons.
Is there any questions from the Honourable Mark Banasiak?
Yeah, I was just probably going to ask one, Chair. Thank you, Ms. Dr. Watts. In your submission, you talked about some recommendations, and one of them is financial support for patients to travel to larger metro centres who are seeking non-standard birth plans. Can you just provide a bit more clarity as to what you mean by non-standard birth plans? Are you talking about unassisted births, or is there a more clearer definition you could give us?
For sure. So non-standard birth plans would be a decision that a patient has made to have to have a desire of a birth that would be seen as outside of the clinical recommendations. So, and that can sort of change hospital to hospital. So an example I'm just going to use that would be most hospitals would be attempting a vaginal delivery after 2 caesarean sections. So this would be sort of, we classify as a non-standard birth plan, because most hospitals would actually sort of say that the risk associated with that would be high. We would recommend an elective section if you've had 2 before. So this would be someone who would have a non-standard birth plan. I've seen other recommendations from other groups have sort of said, adapt in the Queensland, and Queensland does have a very good guideline actually based on this, on non-standard management plan. So this recommendation would be that quite often patients can't, if they do want to have a non-standard birth plan in a small town, there might not be the resources if things do actually go wrong. So, these might have lower levels of blood resources. They may not have as many staff around. So women want to have a birth plan that sort of is outside of what we would say was the standard guidelines, that there is funding for them to go to a larger centre like a tertiary hospital where there's more doctors around, there's more midwives around, there's the ability to have intensive care. So therefore they can still have the birth plan that they desire, but there's also the backup to actually, provide assistance if things do not go correctly. And the other thing is that we know about the second victim. So, when things do go wrong, that there is also the midwives and the doctors are actually affected. In small country towns, that can be a bit of an issue because everyone sort of knows everyone. And so we would want to that would be one of our recommendations, that there would be funding. So women that want to have these birth plans are outside what we would say is clinical guidelines, that they can have them in larger service centres where it's safer.
So just a follow-up question, how prevalent is that in our rural and remote areas? I'm just looking at some stats on the National Trauma Maternity Indicators, and it's seemingly like we have a high percentage of women in remote and very remote areas actually having unassisted births and very conventional births. So how prevalent is this non-standard birth plans in our remote areas?
I can't comment directly on New South Wales. I don't work in New South Wales, but I would say that there's definitely a few cases. I can't actually give you numbers. Sorry, I can give you personal. In the hospitals that I work in, we would have 1 or 2 per week with women that would want to have non-standard birth plans. That we would go through the process of getting them to sign the paperwork and look at how we can make that birth what they want and as safe as they want, as safe as can be.
So there's no sort of recording of this data anywhere that you could draw committee members to at all?
I do not know for New South Wales, I'm sorry.
Yeah. Okay.
Thank you. Dr. Watts, we've talked a little bit this morning about some of the increased risks of having a caesarean section. Obviously, caesarean section is quite important to this inquiry because many of the submissions talk about there being an increased rate of birth trauma when there is a caesarean section. And you've talked about some of the factors such as age and people giving birth at an older age as one of the reasons why we're seeing an increase in that rate in C-sections. But some of the submissions also look at the rate of C-sections in Australia compared to other countries around the world. And Australia is much higher than most other countries. Why do we have such a high rate specifically in Australia? What other factors are relating into that other than older births and stuff, which I'm assuming would be worldwide?
If we're looking at sort of obviously the high versus low resource countries, then there is caesarean sections are safer, and so therefore we do sort of see in the high resource countries a high rate of caesarean section because we have a lower threshold to do them for fetal reasons. So I work, for example, quite a fair bit in Africa, and we have there's a much lower caesarean section rate because we know the risks of caesarean sections are so high just for the maternal reasons. So that's sort of just with the high and low resource countries. With high resources, we do have a system that we are the idea of access to, I think, to the models of care that we do actually have, that we could actually look at individualising care to see what patients actually want, to see whether we could actually reduce it as well. I'm not sure of any other reasons, sorry, besides those ones that we've just stated before.
Okay, yeah, because the other countries that were compared to was the US, UK, European countries had lower caesarean rates than Australia. So, it's interesting because I'm assuming that they are also higher resourced, but yet they still have a lower caesarean rate. But it might go back to what you were saying about some of those conversations with women about what they want in their own birthing plans. You talk in your submission about consent, and in fact you say that consent is the bedrock. And it seems that this is a point of agreement across every submission that we've received, everyone's talked about consent and the need for consent. How can we improve in this area? What is not happening? Why are some people feeling like that consent isn't there? And what needs to be in place to make women feel like I actually gave consent to this?
Absolutely. So the first thing would be to realise that the time critical nature of some decisions that need to be made in obstetrics. So therefore we need to take the information that we give to women back to the antenatal care. And that can be through the birth education, it can be the one-on-one sessions, and we sort of have made that recommendation there that, MBS item numbers are looked at to see that there is enough time to actually make sure that you develop a plan with the women beforehand to discuss their actual individual circumstances and come up with a plan. So two sort of things there. One is the woman actually then has enough information that when she is put forward, we need to do either an instrumental delivery or cesarean section, she's being given that information, a few weeks beforehand. But also because then the primary care provider gets to know what that woman wants. And that's why, whether it's, we agree that, continuing care from a single provider is the main person, whether that's a private obstetrician, a GP obstetrician who's looked after the woman potentially for the last 15, 20 years of her life, or the midwifery one as well. That is because you get to know what the patient actually wants as well, because you've discussed this in the antenatal care. And so therefore we then get the consent can be made because there's enough information, because you've had that half an hour discussion in the antenatal care. I think that the other one then would be that we do need further training, and of everyone involved in antenatal care on how to actually gain consent. And the Law Society of New South Wales submission there, it sort of spoke about, not only just looking at the Rogers versus Whittaker, but actually how to do consent in that quick situation. And we must have other areas that we can actually look into to learn how to do that, and sort of a program that can be funded to, that birth trauma care for all providers would be very important.
Thank you. You also said in your submission that you'd like legislative support and protection for providers who support women to elect non-standard care pathways. And I've read some quite concerning submissions about what's happened to healthcare providers when they have tried to support those non-standard care pathways, and the difficulty they've had to do that. What can you talk us about through some of the policies and the procedures in the hospitals that's making it difficult for obstetricians to actually support women in making these choices?
Absolutely. So I think that there's two aspects to this. So the first one is, if we do support women in these choices that may be seen as, they're patient-centred, but they may not be seen as what is the best evidence base. But, we need to be looking at what the patient actually wants. That if something does actually go wrong, that there is protection to that, the obstetrician, the midwife, the care providers has that protection, because I can, there's story after story that I can tell of my colleagues that when people can be angry after things go wrong, and even if there is the consent, they can actually still be complaints placed into authority bodies, and this can be a drawn out process for sometimes a couple of years, and they can still be found to not had no wrong was actually done. But there's 2 years of worrying, of concerns, of having to report to employer that you have an APRA notification over you when you're going for new jobs. And so therefore people are quite worried about their jobs and their reputation, and it's so easy now to have these care sites where patients will put opinions. So therefore, if we are going to support women to have a non-standard management plan, that if things do go wrong, that we have the legislative support to say that, we counselled you correctly, this is the decision you made. We will, if you can change your mind, we're there to support you at any time, but there's protection for the obstetricians and midwives to be able to provide that care for the patient. So that's the first part. The second one, as you spoke about, was then about, hospitals. And I think hospitals are also in the same situation, that, that they need the protection when things go actually wrong, that, people can't point the finger and say, well, that patient was outside the guidelines and you let her do that. We should be saying, well, we empowered the woman to actually do that. So we need to have those changes from above, those legislative changes that, that the consent process, how can we do this so the consent actually stands up? So we need that education of the health service providers and clinicians as well, so both sides of it.
Thank you. And I just want to go back to something you were saying before, and also what's in your submission around the term of obstetric violence and how using that term can sort of create some sort of division. From my understanding from some of the submissions that do use that term, that they're referring to obstetrics rather than obstetricians. I guess my first question is, are you feeling that the public will be confused between the difference between obstetrics and obstetricians? And the second part, I suppose in your submission you sort of talked about it sounds as though it's deliberate. From all the submissions I've read so far, they've been talking more about it being avoidable rather than it being deliberate. What sort of terminology do we need to use around this avoidable concerns that are happening in obstetrics and as you say, across the field? Because it is quite different to the much broader term of birth trauma.
Absolutely. So for the first part of the question, in the world of, midwifery and obstetrics, we're trying to move away from the word obstetrics, because it is quite often seen by the public as referring to the obstetrician, and we know that we're part of a team, that there's the midwives and everything as well. So we are actually trying to use the word maternity, and I know in a lot of the services we're changing from obstetrics to maternity, like our maternal mortality, instead of now obstetrics is now maternity mortality. So we're trying to use that way, because we do appreciate that refers to anything to do with birth, but we don't believe that's the way the public appears it, and so we want to be seen as a team, so we're using the word maternity. So we think in the same context here that this word obstetric violence is referring to obstetricians. In the second part of your question, it definitely, reading the submissions as well, I think, this birth trauma and obstetric violence was definitely used back and forth and sometimes, crossed over in the same paragraphs. And there is that confusion about what the actual difference is. And I think that, to trying to define what actually also what happens just by birth, like, birth, a third degree, a fourth degree tear, that is birth trauma that may not have actually been anything to do with the clinician involved compared to the actual aspect of, not covering a patient up after an examination, or the patients perceive that you didn't gain proper consent, because it's always the patient's opinion that we should be mostly cared about, even if we feel the consent was attained. Is what did the patient perceive it? So those things are more towards that, and we prefer the terms such as instead of the obstetric violence, another term that sort of is not so, that actually brings obstetricians to the party as well, that we realise is an issue that we need to actually fix.
Thank you. And so you would look at words like harm, like to sort of, I guess, to we recognise, you might have a tear and that might be quite traumatic, but it might be unavoidable. But then what we're also hearing a lot about here, and I guess what's of most interest to this committee, is what is avoidable, because within the Parliament system, there's probably not much we can do about unavoidable instances, but where there are things that are avoidable, and that can come back to funding or legislative changes, policy changes, all those sorts of spaces, how do we differentiate that from birth trauma, which is much broader?
I think that other terms, potentially not using the word, violence definitely needs to be. We definitely need to differentiate them out, and I'm trying to remember the word that we actually that we sort of portrayed in, discussed in our document as well. So mismanagement, I think, some of the other terms like that, there's actually can be put forward as to differentiate between birth trauma and something that was, avoidable, for sure.
Thank you. The Honourable Emily Savall has another question.
Thanks, Chair. Dr. Watts, I just wanted to take you back. Earlier we were talking about some of the time-critical nature of interventions that may be required, and that may be also perceived to be traumatic, and whether you could sort of expand on that about what those occasions are when interventions that may be traumatic are required to ensure the best possible outcome. So, for argument's sake, you're called in the middle of the night to assist a woman you've never met before, who's had a non-standard care pathway, who may be in need of some intervention.
Absolutely. So examples sort of that we would in that
Yeah.
situation, is that sort of, So I think the sort of, the three sort of things that cases that I think about is, and trying to get consent, like an abruption. So this is when the placenta actually comes away from the womb. It can be extremely painful for the woman. It can need to, it is both life-threatening for the baby and for the mother because of potential bleeding. And sort of when you come into this situation, which, unfortunately, most obstetricians have done a few times in their career, you've got this woman who's in absolute agony. It's happened quite suddenly, and you need to get her consent for a cesarean section to very much likely try and save the baby's life and potentially hers as well. And it is such a difficult situation because, how can you get consent from someone who's in such severe pain and also, is frightened because everyone's going to be rushing around them because we all know how time critical this is as well. And, that's sort of one. The other ones are, I've seen the women being, where a woman's come in and she's in labour and all of a sudden her waters are broken, the cord rushes out and instantaneously that poor woman is turned on upside down. The midwife has to place her hand in the baby's head through the vagina and push that baby's head back off the umbilical cord. And this has to happen so quickly. And it's, sometimes they don't have analgesia. And in these situations, you have to act so quickly. I think that, the solutions are, this one is that, the education beforehand, and it is hard because you don't want to scare women, in your antenatal classes and tell them about every complication because, you wouldn't want to have a child if you heard about every complication that could actually potentially happen. But, I think, so, the big ones we probably need to actually speak about. So if they do occur, they may actually do. I really think the birth support people are really important to get them involved because, they will, getting them involved because if they can sort of reassure their partner, obviously consent is, you can't obtain consent from them, but, trying to get them involved. And I really think that's quite important as well. And then the other one is to try and manage the trauma afterwards. And so that is, seeing the patient straight away after the delivery to see things. But, there is really good evidence that, the first 24, 48 hours after delivery, women are tired, they're in pain, they've got opioids on board. And so this counselling that we do in the first 48 hours, some women may not, a few women don't remember it when I've, gone back a few days again. So I think it is that acute thing we still need to do because there might be women, but then also see them early again, like in 1 or 2 weeks, so they don't have that, I think I spoke about before, they don't have that night after night to of worrying about did they do the wrong thing, did they make the wrong decision, and we can actually then still see them at the more traditional 6 to 8 weeks as well to see if when we sort of see women after any delivery to talk about contraception and breastfeeding and how's the perineum healing and things as well. So I think that's sort of it's a difficult situation, but that's how I sort of would see a potential solution. Well, one solution, probably many we could come up with.
Thank you. Thanks, James.
I've got one more question. Ranscog is supportive of continuous maternity care from a known provider. Can you talk about some of the benefits of continuity of care and how you believe it will actually reduce birth trauma and improve outcomes?
Absolutely. So I think that the benefits of this is that you get to, the provider gets to know you. And we definitely feel that, there's so many different models in this one, and it should be patient-centered to, whether they choose midwifery, their GP obstetrician, their private obstetrician. They get to know you throughout the entire pregnancy, and so they can actually realise when things are looking different because they, will know what you were like last time. We've got, their ability to pick up mental health conditions more readily and quickly if they've seen you before. They will get to know your medical history a lot more detailed rather than seeing a different provider every antenatal appointment. And then in labour, they'll actually had so many conversations with you that they'll know what you actually wish to have in that birth plan, what you wish to have in birth. And so they're able to actually, to try and help you to do that. They'll know your past history in very much detail because they've seen you for the last, 40 or less weeks as well. And so then they'll know your past medical history. They can, when things happen in labour, they can know things like the medications you're on, what are your past medical history as well. And so therefore, I think we've got the psychological support, detecting mental health. They know what you actually want from spending so much time with you. And then there's just a familiar face as well. So when things go wrong, and I see it, you watch the patients and they keep that face on that midwife that they might actually know in that traumatic situation. And, if, I quite say to my patient, like in the emergency, just watch me. And if if my face is still okay, you keep going. Because I also see patients used to do this in midwives. They, in an emergency situation, they focus on that person they know, they trust, and that makes the process a whole lot better. If that's their GP, if that's their obstetrician, if that's their midwife, I think it's a really important thing that we should look at.
Wonderful.
Can I just ask one question following on from that? Thank you very much. One of the challenges we have with health is that it is partially funded at a Commonwealth level and also at a state level. You did refer to I think it was the medical provider numbers and a few other things, and we just touched briefly then about the continuity of care. Has any work been done to engage the Commonwealth in, I suppose, stepping up to the table of providing better support and funding, particularly for GPs and also obstetricians that are outside a state system, or when they obviously come to hospital and state funded?
Absolutely. So RANZCOG has, meets with both federal and state counterparts and has met with all the state ones, I believe, in the last 12 months. And this is an issue, especially in particular for our GP obstetricians, due to the access item numbers. And I see, the midwives have also sort of made submissions about this as well. That definitely, the RANZCOG is looking. It also looks into the, the gynecological numbers too, because we do know that, looking at ultrasounds and things like that, women's ultrasounds for women, so item numbers for like a female pelvic ultrasound is less refunded than male ones as well. And so this is definitely things that RANZCOG is looking at and is actually making submissions to the federal government to try and, we need to have women's healthcare equal, as in any other, male gender's health as well. And so definitely think that RANZCOG looking in both gynecologically and obstetrics with the federal government.
Thank you. Thank you for attending today's hearing, Dr. Watts. We really appreciate your time, and I know you've called in from overseas, so thank you so much for that. The committee members may have additional questions for you after the hearing, and the committee has resolved that the answers to these questions be returned within 21 days. I don't think you took any questions on notice today, but if there was any, that they will be included in that as well. And the Secretariat will contact you in relation to these questions. Thank you very much.
Thank you so much.
The committee will now stop for a short morning tea break. Thank you. Sally Cusack, the National Secretary of Maternity Choices Australia, and Ms Asia Rigby, who is joining us online. Could each witness please state their name and position title and swear either an oath or affirmation? And I'll start with Ms Cusack.
My name is Sally Cusack. I'm the Company Secretary of Maternity Choices Australia Limited. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Ms Asia Rigby? Oh, sorry, Ms Rigby, you're on mute, I think.
Hi, my name is Asia Rigby, Advocacy Manager for Maternity Choices Australia. I solemnly, sincerely and truly declare and affirm that the evidence given now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would either of you like to start by making a short statement, just of a couple of minutes?
Thank you to the Chair, Committee and public servants for the opportunity to give evidence today about MCA's experience over more than 30 years attempting with little success to improve maternity services to become evidence-based and respectful of women's rights. Once a woman decides to proceed with a pregnancy, no one else involved is literally risking their current and future health prospects to ensure the safest arrival for the baby. Yet our maternity care system dismisses women's hopes and expectations for their births as fanciful and a distant second place to the system's perception of safety. This is at odds with all evidence surrounding safety in birth, including our National Maternity Strategy, which includes emotional safety. It is a given that women want a live baby, but if that's the main focus of maternity care, we will continue to see birth trauma. In fact, Australian maternity practices are very similar to the UK's, where a systemic review showed only 9 to 12% of practices are based on grade A evidence and 50% based on some evidence. Contrary to public belief, it's possible for birth to unfold smoothly with minimal physical and emotional harm if the woman is in an environment where she feels safe. Extensive World Health Organization research conducted around the developed and developing world has led to the findings that approximately 87% of women can give birth without medical intervention. It's estimated that fewer than 5% of New South Wales women, though, have an intervention-free birth. Even though research has shown most women want to birth this way, intervention-free or physiological birth isn't collated or reported on in perinatal data sets. In less than 100 years, our economic system has drawn the fields of medicine, law and technology into the care given to women in the perinatal period, which has led to almost complete erasure of the physiological process that has taken over millions of years to develop. We have seen a particular explosion in interventions in just the last 20 years, which could be forgiven if we'd seen a corresponding reduction in stillbirths. Sadly, as heard earlier, we've seen no reduction in stillbirths in this same period. Instead, we're seeing rising rates of physical and emotional trauma, where we're now in the position that 1 in 3 women report having experienced birth trauma, 1 in 4 developing postnatal depression, and 1 in 10 with PTSD. And nearly 1 in 5 babies are admitted to special care nursery or NICU. The C-section rate is now 38%, and 23% of those babies born this way end up in special care nursery or NICU. The NICUs and special care nurseries are highly lucrative to the wider system, and the way guidelines are written mean occasionally healthy babies are separated from mum, admitted, and even pick up hospital-acquired complications and infections they otherwise wouldn't have gotten. Women don't feel empowered to speak up with the fear and more frequent reports of vexatious reporting to children's services for declining recommended maternity care, which is a woman's right regardless of the outcome. We would like more transparency on these figures and associated funding for interdepartmental referral. The third Australian Atlas of Unwarranted Clinical Variation showed maternity services have the highest rates of procedures being performed for no medical reason or maternal request. This was found to be particularly true of low-risk women who experienced 12-fold variations. Much of this could be attributed to the fact that C-sections are more likely to happen in birth suites where an operating theatre is available. In New South Wales, we have only a handful of standalone birth centres. No one in this room, and actually only one completely standalone, no one in this room actually believes 60% of women want or need to be cut open in order to get a live baby. Globally respected US obstetrician from Harvard, Dr. Neil Shah, points out higher rates do not equal better outcomes. He states in particular that American women today are 50% more likely to die in childbirth than their mothers. While our outcomes aren't tracking as badly, our intervention rates are headed in the same direction. If women are having all this pain relief and interventions, why is there still so much birth trauma? Trauma is compounded when it is not acknowledged by providers or, in our experience as professional consumer representatives, minimised or worse, gaslit into believing it was necessary. It is vital that women hear the measures that providers, their employers, their professional bodies, regulators and government are taking to correct the issues, that they have truly heard the women, and that the massive ruptures of that disrespectful violence has had on them, their babies and their families, all at this precious transformational period that can never be relived. I'll hand over to Asia to go through some brief but hard stats and a case for ministerial interventions for system reform.
So what role should the medical system play in maternity care? If we're willing to accept the WHO's findings that only 13% of women need medical care and the assumption that we're intervening with over 95% of births, we're seeing a massive overservicing that's very skewed towards an obstetric model, therefore directly inverse of what women want and need. Incidentally, most of the 95% of women who are treated with a drug called Syntocin or Sintometrine, which is often used interchangeably, or when a hospital just doesn't order Syntocin at all, it increases women's risk of postnatal depression by 36%. The product insert, by the way, advises not to breastfeed for 12 hours after use. Ironically, 87% of maternity tasks are carried out by midwives, but unfortunately most of them are strangers to the women that they serve. The Queensland Human Rights Commissioner has pointed out our current fee-for-service funding model is a perverse incentive to overservice women for financial gain. The Independent Hospital Pricing Authority states that $1,000 per birth would be saved with funding that is allocated to the woman, known as bundle funding, rather than the intervention, known as activity-based funding. Queensland Health is currently investigating allocating funding over each of the 4 trimesters rather than per intervention. And I also might just note the National Maternity Strategy recommends that women receive care from a known provider up to 12 months postnatally. So in fact, if we could, have the whole 12 months, that would be great too. So when 8% of women have access to a known midwife, they're serviced by 3% of the midwifery workforce. If we had MGP targets in service agreements, we'd have 80% of women being cared for by 30% of the midwifery workforce. So I ask you, do we have a midwifery workforce shortage, or is it manufactured from management failures based on lobby groups' best interests and political donations? As you can see by the tabled New South Wales MP brief co-signed by 45 other community organisations sent to all MPs about 2 years ago, a known midwife saves 22% per birth, or $5,208. That's $450 million that the New South Wales government could save in unwarranted intervention by offering each woman a known midwife over a stranger midwife. The WHO states that the most abuse and mistreatment occurs 15 minutes before birth, so we do not want to endorse models of care that only provide pre- and postnatal continuity. A known midwife in labour and birth is primary prevention. No other model of care offers continuity across the whole period, even GP obstetrics, because no GPO is going to sit there for 12 hours holding the woman's hand in labour. They're far too highly paid and highly skilled. So we have far more obstetricians than are required for the 13% expert modelling suggests. Even if we double that number, we find it fascinating that private obstetrics is the only medical specialty where women can get a GP referral without clinical indication, and that no New South Wales health services promote women that they can self-refer to their local birth service in their preferred model of care and place of birth, also so they can capture the stats on who is missing out on what they're actually after, in hope that the services start to meet women where they're at and what their needs are. It's a great display of the power imbalance. We insist on a system that's centred around the needs of mothers and babies, not industry. Most women want a birth without intervention, but they also want the support of people who are experts in birthing physiology that they get to know throughout this time. So give women the midwives that they know and trust, and if they want to have a doctor, they should be allowed to have a doctor too. However, we should not continue bullying women into mandatory 36-week obstetric review appointments because time and time again, women say that they're feeling quite coerced in these appointments. And let's also let women have the care for prenatal, early labour, birth and postnatally in homes and close to home. Even if they have risk factors, even if we're offering them a small amount of funding to go to a larger tertiary centre if they're wanting to have a vaginal birth after 2 caesareans, for example. The system needs to acknowledge that harm is done and understand the role that standard fragmented care has played. When not in relationship-based care, disrespect, misunderstandings are more likely to happen and women fall through the gaps. Various contributing factors reports for stillbirth also state that of unexpected stillbirths, 55% were from substandard hospital care. The system needs to accept the standard hospital birth environment is contraindicated for physiological birth and inhibits oxytocin, derailing the birth process, not just for women, but the staff who work there every single day. For example, the walls are painted, light colours. It's just inappropriate for normal physiology of labour. And causes further unwarranted intervention and creating more emergencies to then have to manage. In all of our years of advocacy and working for improving birth services across the country, we've found our ability to engage meaningfully with our health system very limited. Standard 2, partnering with consumers, has allowed to make some slight inroads, but consumer-led influence is still very minimal. Consumer reps have been dismissed from their roles when bringing women's voices to the table. We're required to sign NDAs, which make collaboration with other representatives for broader change virtually impossible, given the systemic layers of abuse are not isolated geographically. Even when very serious complaints are rarely heard and acted on, there is little recognition of the incidence of sex-based violence in the maternity system. Women have no Bill of Rights or mechanisms to action their complaints about unconsented procedures. The HCCC legislation is narrow and women report there, and the hospital's responses are extremely offensive. MCA doesn't believe it's appropriate to complain to an abuser in any situation, including maternity services. I'll pass back to you, Sally.
This invisibility of women's voices has led MCA to self-fund and create a system to generate a grassroots response to lack of standard 2 engagement change in the maternity care system. Best Birth Finder allows women to submit their birth experiences and receive a draft feedback email to send to their birth service. And other women can read these reviews to help them find the best local service that meets their needs. We also hope that hospitals will improve access to evidence-based, rights-respecting care and consumer-driven public oversight. And I would like to table some bookmarks that I've made. Thank you.
Sorry, while we're doing that, Ms. Cusack, could I just check how much longer your opening statement will be, just because we will only have...
Just one more para. Thank you very much.
Thank you.
The evidence supporting everything we've stated has been available for up to 50 years. The policies keep being written at state and federal level. We know what to do. They're just not being implemented. No further money needs to be spent. We just need political will to face the facts and change the culture through incentives for evidence-based care and fines in service agreements. Further fines at HCCC level and criminalising obstetric violence so that victim survivors assaulted in the birth room can access the same channels for justice as women assaulted outside of hospitals, as an unexpected finger in the anus makes a woman feel the same in both situations. The intent is control. The intent is to cause harm, and this is called torture. Harm without intent is called violence. We call on the Attorney General to strengthen the sexual violence laws to include obstetric violence, and that any funded mental health line, hospitals and HCCC begin to collect and report on obstetric violence data. Thank you.
Thank you. Thank you to both of you. I'm now going to throw out to the committee members. We've resolved to spread the questions across. So I'll start with Dr. Amanda Conn.
Thanks. My question is for Ms. Rigney, who mentioned in passing the design of maternity wards and hospitals and how that's not supportive for women. Just interested in exploring that further and how we can design those wards to be better for patients.
Yeah, absolutely. So as an example, not having the same lift where, a 60-year-old man is going in for a knee surgery and the woman's having contractions in early labour. So a separate lift, ideally, on a ground floor, a separate standalone birth centre.
Sorry, Ms. Rigney, we've lost your sound.
Sorry.
Oh, you're back. Okay.
Walls should be painted dark. Beds shouldn't either be in the rooms or not visual to the woman, certainly not in the centre of the rooms. Every single hospital room in New South Wales should have a tub where a woman can access water immersion or water birth for the significantly improved outcomes for women and their babies with reduced NICU rates and what have you.
I can pick up a little bit on this too. So Dr. Sarah Buckley, her PhD she's an obstetrician herself, and her PhD is called The Physiology of Childbearing and Hormonal Physiology of Childbearing. You can find it on her website. And in it, she talks about, the simplest way to sort of explain this is that for the most efficient labour, a woman needs to have 3 feelings, it's interesting and goes to show how important emotional safety is for giving birth. Those feelings are to feel private, safe, and unobserved. So the interesting thing is that we bring ourselves over and over into the hospital environment where that is completely contraindicated. There's no privacy. Yes, you may be in a room, but strangers can come in and out at any time. Privacy, safety, and unobserved. The maternity care system is all about measuring, assessing, observing. And also in terms of just other physiological impacts, bright lights turn off the birthing hormones and in fact stimulate cortisol instead. Cortisol is required later on, just prior to the pushing of the baby, but during labour it's highly counterproductive and will shut birth down. So bright lights, being in the presence of strangers, engaging the prefrontal cortex, the frontal part, the thinking monkey mind that has us worried about who's this person and why they're flicking through all these papers and what's this computer screen about, and what's that beeping machine in the corner of the room for. So the sight of technology is disruptive. And so there are actually some great examples of birth centres where it's a more home-like environment. So as soon as a woman goes into a foreign feeling environment, especially one that smells of antiseptic, as the research of Marilyn Ferrer and her colleagues found, this was research done here in Sydney, even the sight of stainless steel and tiling is enough to generate that release of cortisol. So a home-like environment is created, and those recommendations have been taken on board for some birth room designs. And I know, for instance, I'm from northern New South Wales, and there was quite some effort that went into the design of the birth units there, where there was measures taken such as putting the resuscitation beds back out of the way and not in the centre of the room or as soon as you walk in. And there is a bed, but it's not, this clinical high narrow bed. Room to move, places for the woman to sort of retreat and be out of the more public sort of view, where we are meant to birth in privacy.
Thank you. The Honourable Susan Carter.
Thank you, Chair, and thank you both, Ms Cusack and Ms Rigney. Ms Rigney, I just wanted to follow up on something that you were talking about in relation to funding models, and it also, I think, relates to your recommendation 12 in your group submission. So as I understand what you were saying, perhaps I'm just confirming that I'm understanding you, you think that the issue of birth trauma would be in part addressed by perhaps what we might call a woman-centred funding model, so that a woman might be given, for example, a voucher for maternity services, and then she would take that voucher to the service provider of her choice. Is that sort of voucher funding model what you're suggesting?
Yeah, absolutely how I explain it too. Even though it's not exactly how the Independent Hospital Pricing Authority explains it. But why the health economists think this is a great idea as well is because then the services are more likely to become competitive. And okay, so XYZ hospital doesn't have tubs, but ABC has tubs, you know, just an extra 10 minutes down the road. Well, then the women who really want that water birth are going to go elsewhere. And so follow the funding, and they might start becoming woman-centred. They might start improving, and hopefully less restrictions.
Thank you.
The Honourable Emily Savard.
Thanks, Chair. I've got two questions, if you'll indulge me. Thanks so much to both of you, excuse me, for appearing today and for travelling. I know you've travelled some distance to be here, Ms Cusack. I just wanted, if I could ask you to expand more on the comments around interventions that you made in your opening statement in terms of the explosion in the rates of interventions, which is somewhat contradictory, I suppose, to evidence that we heard from the Royal Australian College of Obstetrics and Gynecologists this morning, who stated that it was the same since 2012. And what comments you have on that, and whether there are occasions when interventions that may be traumatic are required to ensure the best possible outcome for babies and their mothers.
I might jump into that second question and hand over the first part of the question to Asia. So, yes, there are occasions when birth can suddenly take a very different course. Mostly, though, you know, like we're familiar with the term emergency caesarean. It's used a lot. However, we have found, and it's not just us, through the international research, that most of these procedures happen over a period of, like, there's a period of hours and sometimes even days in the lead up to these caesarean sections. So the better term is unplanned. However, there are some that really at the far end of the spectrum, at the very pointy end of the spectrum, yes, there are some very, very sudden events that can develop. But we're talking in the less than 1% sort of numbers. So, you know, the incidence of cord prolapse, which Dr. Watt referred to earlier, that's like a 0.6% chance. And yes, highly distressing, and you need to act on that. And any woman is going to want someone to just come in and deal with that. Of course, she's going to want to. We're talking about the other end of the, you know, the spectrum here, where it's over many hours and days, and possibly even weeks.
Something
women,
like preeclampsia, for example, or.
Yes, that can take. Yes, I mean, not that that's a, you know, something that can happen to most women. That too is a, you know, more unusual event. No, it's you know, things like the perception that a baby might be big, or that you know, haven't birthed within, you know, it's sort of, there's some variation there in the interpretation of the best time for a baby to be born, but, you know, there's a common obstetric view that 39 weeks is the best time for a baby to be born, and that babies should be induced at around that time. But for instance, in the case of Dr. Sarah Buckley's research that I mentioned earlier, well, it's not just her research, but she quotes it in her thesis, that though an intervention like induction of labour, synthetic induction of labour, is only going to work when the woman's uterus has sufficient oxytocin receptors in order to receive that medication. Prior to that time, all you're going to do is raise the woman's blood pressure and cause distress in the baby. Interestingly, if you just wait, like as a woman goes through her pregnancy, she's developing these oxytocic receptors, and it's, you know, hours and maybe a day or so before birth that she gets this exponential increase in these receptors. So if you try and do that, and whenever she's ripe and ready to go is a very individual thing. It's between 37 and 42 weeks. So if a woman is induced at 39 weeks and she would naturally go into labour at 40 and a half weeks or something like that, it's really not going to have much effect. So it's best for Syntocin and that induction to wait until the woman's ready, but we don't know when that is going to be. And ironically, she will go into labour anyway. So just getting into just talking there on that point of this lead up to these interventions that really is what we're talking about, and where consent is required. And many women are experiencing, sort of antenatal education, we could call it, or some people might even call it coercion, to start thinking about induction when they're at about 36, 37 weeks. Oh, you might want to start thinking about induction. Oh, baby's looking a little bit big, and oh, you're looking tired. And a lot of women end up choosing it simply because they live too far away from their birth service and they want some sense of control of when it's going to happen. So they may choose that for very valid reasons, but many other women are just wanting to go into labour spontaneously, and they're being sort of primed for this suggestion over time. And then, it might be suggested, oh, why don't you have an ultrasound scan, latent pregnancy, and that might help us kind of work out what's the best time for you, and then, oh, baby's looking rather big, so there's, 1 in 3 of those cases of suspected macrosomia turn out to be quite incorrect. We come across countless stories every year of women who, I can't say countless, but obviously a high number of stories every year from women who were induced due to suspected large baby, and baby turns out to be 7.5 pounds and not an issue. So yeah, and this is where the consent issue is so important. And Dr. Watt talked earlier about the importance of needing time to get consent from women. And I would like to point out that it's not the responsibility of the carer to get consent. It's their responsibility to give the information and for the woman to then make the best decision for herself. And this is where continuity comes in, and he's quite right. Women need time to consider their options. And, in a sudden emergency situation, she can't give that level of consent. But if she's got a cord prolapse, she's going to say, do whatever you have to do. And really, we're talking about small numbers here, I repeat. We're talking about the rest of the scenario here. So, Asia,
thanks, Sally, for explaining grooming. I was just going to have a real high oversight. We get many, many complaints every year, and a lot of them are actually, look, I was told I needed an emergency C-section. I said yes because I wanted to save my baby's life, and she sat there for 3 hours on the trolley waiting to go into theatre. So these sorts of things is, I guess, what we're trying to get at. To get at your first question, if I could just point to Denmark, who 20 years ago, both us and Denmark both had a 17% caesarean section rate. We're now at 38%, and they're just at 18.5%, 18 and a bit. Can you not exactly quote me? But you know what I mean? So it's like, okay.
It's fair to say that some women may choose to have a caesarean, and there are different categories of emergency caesarean sections. There's the category 0 through to and various stages of what is described as an emergency caesarean, but there may be different degrees within that.
2% of women have tocophobia. So yes, absolutely. We acknowledge that, that 2% or so do a maternal request, as is their right. We do have less complaints about that issue, about not being able to access a caesarean section on request. The main issues we get over and over again, not being able to access water birth, not being able to access a known midwife, not being able to access out of hospital birth, and those sorts of things.
Thank you. And I just wanted to ask a second question with regards to your statements around the midwifery shortage. We've received submissions from the Australian College of Midwives, which describe the midwifery workforce as declining, and I quote here, data indicating there are 1,220 less midwives nationally than there were in 2016. I wondered if you had any comments on that.
Yeah, absolutely. So like I said, though, that's based on how we currently have fragmented maternity care, how we currently have midwives mostly in core models. I think only 11.6% of New South Wales women have access to a known midwife. So if we scale that up to 80%, the health economists state over and over again and in their research that there will be no midwifery workforce shortage, as well as a lot of those burnout issues will reduce and the attrition rate in universities will drop out, because I'm told time and time again from universities around the country that these student midwives are dropping out because of the trauma they're witnessing in hospitals. It's not the way that the textbooks tell them that maternity care should be delivered. And so it's the moral injury.
There is certainly a shortage of midwives nationally.
If we currently have this fragmented system, yes, but what we're saying is if we had MGP targets in service agreements and ministerial directives to LHDs, then no, there will be no workforce shortage for midwives.
There's a high attrition rate that we're experiencing in this fragmented system that most women and most of their care providers are working in. Research into continuity of care models research into the experience of the carers find far higher levels of satisfaction.
Thank you.
The Honourable Mark Banasiak.
Thank you. I think it was you, Ms Ridney, during your opening statement, you mentioned women feeling coerced into getting regular checkups, and I think you referenced the 36-week mark. Do you have any actual data or facts and figures that you could perhaps come back to us on notice in terms of how many women have reported feeling coerced into getting checkups, and what is it specifically about the 36-week checkup that they're having concerns about? I'm just looking at some information about what happens at that 36-week checkup, and I'm just wondering what's triggering that concern at that point.
Yeah, absolutely. And like we would love more data capture on this, but unfortunately there's no funded maternity advocacy bodies who record obstetric violence.
What are you basing that statement on then? If there's no...
The women who contact us every single day stating, I felt coerced into seeing an obstetrician at the 36-week appointment. He didn't want me having a VBAC. He's saying that I should have a caesarean section. And then as the consumer rep, we have to go to the hospital guidelines. We look them up, we provide them to her, where it actually says, well, it could be a senior midwife that you see at 36 weeks. It doesn't have to be an obstetrician, but not every hospital has that. Not every hospital makes their guidelines publicly available. When we look at the guidelines, we know that only 9 to 12% are based on best evidence. We know that the way that the guidelines are written, it says, midwives must do this, and this. Obstetricians may do this, and this. And so there's a lot more flexibility and that you can see the power imbalance in just the way that the guidelines are written. And I'd happy to be send you an article on that later on.
But perhaps on notice, can you go away and collate some data and for us in terms of how many recorded, I don't know whether it comes through a phone call or a hotline or an email, how many people are saying to you that they're feeling coerced into getting obstetrician checkups? And particularly if they're saying anything specific about that 36-week mark, what is triggering about that point? I know there's a vaginal swab, which probably would be quite confronting, but everything else seems quite run-of-the-mill in terms of tests that they perform. So if you could just take on notice any data on that, it would be really helpful in trying to understand that very specific concern that obviously is coming to your organisation.
Yes, we would love more support in being able to capture data too, actually. So we do all of this work as volunteers, and so this is why we developed Best Birth Finder. It's a way to capture these stories in a central place. At the moment, we don't have the system. We can go. We will we will
whatever you can.
We
give us
will
would
do
be
that
helpful,
and
yeah.
go back through our Facebook messages, text messages, emails, and we can pull some of that data out. But we do not have a system that we can draw on to give you that information, and it's not captured by the system. The other thing to just be aware of is that, as most women are in a fragmented system, that what that means is that they're seen by a team of midwives who are overseen by obstetricians. And so the standard process for a otherwise well woman is she has her monthly checkups, and in the last month or two they become 2 weekly and then weekly. And at 36 weeks that's just picked as a point where the overseeing obstetrician actually gets to eyeball the woman. Prior to that, she's just been seen by midwives. So this is where a point that we've made in our submission points out to the problem that exists for midwives being restrained from acting to the full scope of their practice. They're meant to be primary carers, the experts in physiological birth who understand when things deviate to abnormal and when to bring a doctor in. So the assumption is that the women who are the midwives who are overseeing the women it all needs to be checked by an obstetrician, and it's not just an assumption, that's how the system works, and it hamstrings the operation. Yes, Asia.
And I was just going to say, and if women don't want to have that 36-week obstetric appointment, sometimes they miss out on the birth centre, the publicly funded home birth model, or the what have you. There's literally research around the missing out the qualitative stuff. I know you want more the quantitative, but we might just send you that as well because it's fascinating.
Any data on that, I just found it quite intriguing that women would be feeling coerced into going to get a checkup. So, having experienced 3 births myself, going to every single checkup, I'm just curious as to what the concern is there.
Well, if there's nothing that's detected by the obstetrician, then that's fine, and it depends very much on the obstetrician who's there at the time, and perhaps certainly with second and third babies, there tends to be, if the first birth went fairly normally, there tends to be, an assumption that, oh, look, she's likely to be okay, let's just tick that box and move her through.
Can I just ask a follow-up question to that, and just to clarify, is it that they're feeling coerced to go to the checkup, or is it that they've gone to the checkup and then felt like, okay, I've just spent 37 weeks with this plan in mind, and now everything, like I've just been given all these different information from somebody who hasn't been involved in my pregnancy until now, and now I'm really confused. Like, what are we looking at here?
Both.
Okay.
So women often will say, had this bad experience last time, or had bad experience with doctors in general. Look, there's a range of reasons, and so they just don't want the doctor-led appointment. They want the midwife-led appointment. We certainly don't care what women choose as long as they get what they want. And that's why, occasionally if a woman's getting a hard time about accessing a maternal request C-section or accessing a doctor in the public health system, she'll contact us. But that's a very small amount of the complaints that we get compared to the ones who aren't being told that they could just have a senior midwife or their known midwife do the 36-week birth plan case review.
And that person brings a different perspective to physiological birth than the midwife who has developed the relationship over the weeks and months.
I've also got a question. New South Wales Health published in March the Blueprint for Action Maternity Care in New South Wales, and it does address some of the systemic issues regarding maternity care. I'm just wondering if you're familiar with this document, and also if you think it goes far enough or if we need greater reform.
No, absolutely. I think the Queensland birth strategy is 1,000 times better, and I hear it's going to go online in the next week or so. So if New South Wales would look to Queensland, I think that would be a very good idea.
Thank you, and through your chair, thank you for coming along today to provide us with the opportunity to follow up some of the important points you make in your submission. Just looking at the New South Wales Health submission, and specifically on page 11, 3.3, New South Wales Maternity Care Survey. You may not have the submission with you, but I'm sure you've had a chance to have a look at it.
Yeah.
I'll just summarise what it says. It talks about New South Wales Health commissioning the Bureau of Health Information to complete surveys, and it refers to surveys in 2015, 2017 and 2019, and then refers specifically to the 2019 maternity
Sorry,
care.
which page was this again?
Page 11.
Because I do have it. Okay.
Page 11 of the... So you've got the document which is titled Inquiry into Birth Trauma? Yeah. So you've got page 11?
Yes, I think so. Yes.
And you've got 3.3, New South Wales Maternity Care Survey?
Oh my goodness, I'm sorry, I'm looking at the wrong
No,
one.
that's okay. I'll read these out.
Okay,
That's
you
fine.
read it.
So this is from
No,
the survey, the 2019 survey, the most recent one that's been done. Reflects the experiences of 4,446 women and highlights 94% of women rated their care during labour and birth as very good or good. 90% of women felt that they were always treated with respect and dignity during labour and birth. 86% of women felt the health professionals provided their antenatal care always, explained things in a way they could understand. 90% of women felt the health professionals were always polite and courteous. And 92% of Aboriginal women felt their emotional health was yes, definitely, or yes, to some extent supported by health professionals during pregnancy. So that's a report that's in the public domain. It's not that old. I'm wondering, I'm trying to reconcile what your organisation is saying and lining that up with what's been publicly researched and put into the public domain. Bearing in mind the majority of women in New South Wales have their births in public hospitals. I mean, those figures in percentage terms, are quite high. In fact, arguably very high. So how are a number of the points that have been made this morning through your evidence reconciled with survey results like this?
Oh, sorry, AJ.
I was just going to say, look, it's a great point, and that's why I guess I'd prefer to defer to the experts such as the health economists at UTS, who are currently developing a really rigorous and international standard of PROMs and PREMs. That's patient-reported outcomes and experience measures, rather than just BHI's like survey. But then also, I've had 2 babies in New South Wales. I didn't realise that I'd been raped for 5 years. So what sort of questions are we asking women, and do they know what's happened? I just sort of felt like something wasn't quite right, but it was only with time that I realised, that's actually a really inappropriate thing that happened. And so the way that we ask questions can be perceived as grooming and minimising and gaslighting and all these words that we hear within this.
May I ask you this then, in terms of the Bureau of Health Information work that's done, and done on I think quite a rigorous basis, and in a whole range of the domains of health. And their methodology is very clear. It's there for people to see. The questionnaire design, the sampling procedures, etc., all there. Are you casting doubt about the integrity of their survey work?
It's more the questions that we're asking, less about methodology, but more how are we asking questions? Are women understanding? They might say, well, I received care, and any care is better than none, not realising that actually they didn't get access to a known midwife. Therefore, that perhaps their preterm birth could have been prevented if they were Aboriginal by literally 50%. And so they don't know what they don't know. And so, that's why I guess we have concerns when things like this aren't done independently to government.
I encourage...
Can I just want to drill down a little bit here? I mean, the New South Wales, or the Bureau of Health Information, isn't run by the government. Isn't run by the government. You would know that, wouldn't you?
So with government agencies who get government funding, though, and I sit on, many of these, so actually have experience, but unfortunately, like I said, having to sign non-disclosures, the way that those committees are formed leaves a little bit of questioning.
Says who?
You know what I'm saying?
But says who?
Well, it's just sometimes the way that they structure it is to achieve a certain goal. Remember, these agencies are run by members of the medical lobby.
Well, can I just move on to another line?
Sorry.
Could I wouldn't mind.
Gotcha.
Sorry, I just haven't had a chance. Thank you. I just wanted to ask one quick question in relation to continuity of care, because that is something that comes up around information that women have throughout their pregnancy and giving birth. And obviously in your submission you talk a lot about having the continuity of midwifery care. But I guess I just wanted to ask your opinion or perspective as to whether or not it's actually important to have continuity with someone who you feel comfortable with. And I'll take this as an example. I live in a regional community. I had 2 babies at my local hospital, and that relationship for me was with my GP, and I felt really strong and confident in that. So do you think, regardless of who the caregiver can be, and sometimes there's workforce challenges around that, is the kind of overall message that if you can have that continuity of a trusted relationship with whoever as a woman you choose to go down that path with your sort of antenatal care, that continuity is the most important piece?
So remember, I assume your GP wasn't there for the whole 12 hours of labour?
Not
so
for
therefore
all
it's
of it,
not
no.
continuity of carer. Yeah, so unfortunately, what the Lancet, the Cochrane, the United Nations, UNICEF, all of the above, what they say is continuity of midwifery carer is what improves outcomes. So yes, absolutely. If you love your GP, that is fantastic that you can see your GP, and no woman should be stopped from that. However, women are absolutely stopped from having an own midwife, and that's what we want to put a stop to.
So you see those as two sort of different levels of the support that you receive throughout that process. I just want to be clear so I understand.
The research supports that having continuity of midwifery specific continuity of care delivers the best outcomes. They're the experts in physiological birth. But as in your particular situation, there may be, very little difference in terms of outcomes because you had that very strong relationship with your GP.
Yep.
But just overall, we're talking about population.
Yeah,
here.
no, I mean, and everyone's got their own experience, right? But I'm just interested in that continuity model and what you perceive that to mean. But that's been useful to clear that
and
up.
possibly I think the relationship that your GP would have had with your hospital would have, your GP when not there would have had. They'd be familiar with how your GP practices and his or her expectations, and the staff would work pretty synchronously with that. So, but generally, the general finding is that midwifery-specific continuity of care.
Okay, no, thank
delivers the best outcomes.
Thank you. Yeah,
Thank you. Unfortunately, we've run out of time now. Thank you both for attending today. I'm assuming that committee members will have additional questions for you after the hearing. We've resolved that the answers to these, along with any answers to questions that were taken on notice, and I believe there was one, be returned within 21 days, and the Secretariat will contact you in relation to these questions. And again, thank you so much, both of you, for attending.
Yeah, thank you, and I'm happy to provide more information to the member about the BHI survey.
Thank you.
Yeah.
I now welcome our next witnesses. We are joined with Ms Amy Dawes and Ms Amanda Turnell. Could each witness, starting from my left, please state their name and position title and swear either an oath or an affirmation?
Oath. I swear the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Would either of you like to start by making a short statement to the committee, just keeping it within a few minutes?
Yeah.
If possible. Thank you.
Thank you. And thank you to the committee for this opportunity. We commend the work in establishing and undertaking this inquiry. 8 years ago, I was diagnosed with life-altering injuries as a result of the forceps delivery of the birth of my first child here in a New South Wales hospital. My diagnosis occurred in an appointment with a private women's health physiotherapist, and when I got home from that appointment, I Googled physical birth trauma and nothing came up. So I Googled birth trauma and I found an organisation in the UK that focused on PTSD as a result of the birth experience. So after this, I started researching and I found out how common birth trauma actually is. Yet despite this, there was no support for women. It was this reason that I co-founded the Australasian Birth Trauma Association, so that other women like me would be able to find the support that I couldn't. Since starting the ABTA, we have gone on to support over 4,000 women and parents who have experienced psychological and or physical trauma as a result of the birth process. We work collaboratively with both parents and the range of clinicians involved in the care of birthing families to better prevent, diagnose and treat birth-related trauma. This includes obstetricians, midwives, nurses, doctors, mental health clinicians, specialist surgeons. This is in our mission to increase understanding and provide support and advocate for people impacted across the community. We have developed a range of health information and resources, and we've presented to thousands of healthcare providers to raise awareness and educate about birth-related trauma. Our aim is to develop a trauma-informed model of care to be used in a maternity setting. Birth-related trauma is underreported, undervalued and overrepresented in the community. This issue has wide-ranging ramifications across society, yet is mainly women and families that shoulder the burden of living with the impacts and finding the support that they need. The work of the Australasian Birth Trauma Association is done by an almost entirely volunteer workforce. Everyone involved has some lived experience of birth-related trauma, and we receive little to no government funding, and we rely solely on the donations and the energy of our passionate volunteers. Most of the work that we've done to raise awareness and education and support is done by people like me with a lived experience and whose lives have been affected by birth-related trauma. From feedback within our community, we see that health system care pathways are fractured and access to care can be a lottery depending on your postcode and socioeconomic status. This shouldn't be the case, and we look forward to working together with the New South Wales Government and the maternity health systems to prevent ongoing birth-related trauma in New South Wales. This type of inquiry should be extended to all Australians. Thank you.
Thank you. The committee resolved for free-flowing questions. Does the government want to start today?
Sure.
Ms Emily Saval.
Thanks, Chair. Thanks, Ms Dawes and Amanda Turnell as well for appearing today. I wanted to start by congratulating you, Amy, on your recent Order of Australia, which acknowledged your service to women's health,
Thank you.
and particularly to birth-related trauma. So well done. I wanted to ask, it's true there is no universally recognised definition of birth trauma. So I suppose that's probably a first challenge. And in your submission, it is referenced that 1 in 3 women experience birth trauma. Where is this figure from?
That's an Australian-based study, but it was done quite a number of years ago, and we definitely need some more research in this space. But interestingly, it's come through in the surveys that we've done, but we'd like population-level data, and we'd like that gathered by the government as well.
So are you referring to the BEST study that we heard?
No, this was a study done a while back by Creedy. It's in the report, and we can give it to you later.
Wonderful.
Yeah.
Thank you.
Yeah.
The other, I suppose, question I had for you, we've heard a bit about interventions today and reasons for interventions. Do you have any views on the occasions when interventions that may be traumatic but are required to ensure best possible outcomes for babies and mothers, and what your thoughts are around when these are required?
Look, I think it's an interesting conversation. We've seen, obviously, we heard Ranskog speak earlier, and they were talking about specifically we can't possibly inform women about all the risks associated with birth. And I think we need to stop infantilizing women, and we need to actually empower women with information. Like, we know statistically that 1 in 5 women are going to end up with a unplanned caesarean section. We know that 1 in 4 first-time mothers are going to end up with an instrumental delivery. So why aren't we talking about this before women are in the birth suite? And that's the biggest thing. As we've touched upon earlier today as well, birth-related trauma isn't always preventable, but there is hope, there is preventable trauma, and a lot of that can be done with informing and providing women knowledge and resources and information and tools to prepare effectively for birth.
Yes, the Honourable Sarah Mitchell.
Thank you, Chair. I also just want to say thank you, Ms Dawes, for your submission and for sharing your story, but also to the many women who have provided excerpts from their experiences in your submission. I thought that was really powerful, and I think for us as a committee to really understand the different experiences and the different levels of trauma and impact was really useful. So I just wanted to put on the record thank you to everybody who helped and gave you that information. I want to sort of follow on a little bit from what my colleague just asked about, and in your recommendations at the beginning of the submission in sort of section 8, where you talk about more evidence-informed information, enhancing standard postnatal information provided to families, because I completely agree with you. I think that's been a really common theme throughout the submissions, that we actually have to be providing more information for women and families going through this process. If we were to recommend, one thing that we could do to improve that access to information, is it, standardising what comes in antenatal classes? Is it more public information available? Where do you see the really obvious gaps around the information that women receive as part of this?
Yeah, I love that question. I think there's a real positive to be drawn from the new LEAP guidelines that are in development in collaboration with the College of Midwives and the College of Obstetricians. And those guidelines for antenatal education, they're being refreshed, I guess, for the first time in 5 years. But these are the first national guidelines that are for postnatal care that have ever been developed. So postnatal care is just non-existent, and that is quite staggering. So I think that's going to take quite a process, but I think we need to implement recommendations from these guidelines. And I think it's really important that we look at how antenatal information is delivered. And I think what we would like to see, this collaborative care model where midwives and doctors are working together to deliver information, but also including mental health clinicians when required, and pelvic health physiotherapists have a really great and important they bring some knowledge into this space to help prepare women for physiological birthing and identify those that may be at risk for complications or difficulties. So it's that collaborative care. And one thing that I think we've really missed, or that I think needs to be addressed when we're talking about birth-related trauma, is also how we screen women effectively for those that may be at risk of experiencing psychological trauma as a result of the birth experience. And that's maybe not so much as education, but how do we work with women and families to give them an environment where they can disclose information safely with their caregiver about things in their history that may influence their birth experience. And that seems to be a real gap.
Yeah, well, that was actually going to be my second question, which goes back to part 6 of your recommendation around having that screening process for pre-existing trauma, because you're right, I think that's a space where more needs to be done too. So you've sort of answered my second question in the first as well, unless you wanted to add anything more about that.
Yeah, and it sort of talks to you thanking us for sharing the stories. We pride ourselves on learning. We've been learning from the community that we've supported for the last 7 years, and I'm so incredibly lucky that we've had brave women that have disclosed their pre-existing trauma of sexual assault or abuse and how that has influenced their birth experience. And I've only learnt that from the community that we've supported, not from the clinicians that we're working with. So I do think that is a gap that we need to perhaps address and look at how we can do that well.
Thank you. I'll let someone else.
Dr. Amanda Khan, thank you.
Thanks. Your submission raised not just prevention of birth trauma, but treatment for trauma, whether that's accessing treatment for physical injuries or accessing psychological treatment for psychological injuries, and it's something we haven't had the opportunity to discuss yet today. So I was hoping to understand in more detail some of the challenges that the people you've spoken to have had in actually accessing treatment for their injuries and the recommendations around improving that.
Yeah, I think if we talk about physical birth trauma first, it really came through in our birth injuries report that we did last year in 2022. And the aim of that survey was really to understand the prevalence of birth injuries, how the system is at diagnosing them and the impacts of those injuries. And the one thing that just came through again and again was how difficult it was to get a diagnosis. They would maybe go to a care provider and talk about ongoing pain symptoms, issues that they were experiencing, and often they were dismissed or they were told it was a normal part of childbirth, and that further exacerbated their mental health challenges, because they're navigating, remember, looking after young babies, while many are unable to leave the house until they've had a bowel motion or they're suffering from incontinence, and the psychological impacts and the physical impacts often go hand in hand. What came through and why we really advocate for pelvic health physios to be as involved in the care of birthing families as we'd like to see midwives and doctors is because it was often private pelvic health physios that were the first ones to identify any type of trauma and also signpost them to mental health support as well. And then with the psychological aspect of trauma, it's really complex as well, because identifying many women that we support may have symptoms of depression or anxiety, but they may benefit from specialist trauma treatment, but there is a gap in that kind of information for care providers. There's no screening done to identify those that may be experiencing PTSD symptoms as a result of their birth, and so they might go through traditional mental health treatments. They might have depression and anxiety, but that could be as a result of the trauma. And so often, again, they're struggling to get the support that quite suits their needs, and that comes through a lot in the stories from the women that we support.
Thank you. The Honourable Susan Carter.
Thank you, Chair, and thank you very much for the submission, especially I think the insights that you get from all the contributions that are in the submission. If I can take you back to the issue of screening or better understanding women who are presenting who may be at greater risk, and therefore we might look at more support for those women. I was very interested in the comments made in the submission in relation to the stages at which trauma can occur, and something that had not occurred to me at all before, that experience of prior termination may be something that causes or puts women perhaps at greater risk of birth trauma. And I wondered whether you had any comments as to whether that should be something that is routinely screened for. And also, I suppose, the comments seem to suggest to me that we're looking at birth trauma, that perhaps there's also trauma associated with termination and the extent to which there should be debriefing and counselling available to women post-termination.
Yeah, I think one thing that we've sort of discovered in our work as well is all through the process of that journey to parenthood, there can be challenges, and those challenges are underpinned by how we're treated. And we know that many women, even going through the IVF process, or parents going through the IVF process, it's incredibly challenging, and yet many don't get offered counselling, and there's no support. And so you would apply that for people that have to go through termination, absolutely. And then it's also understandable that people that maybe have experienced early pregnancy loss, they're going into the pregnancy and birth experience rightly and understandably with a level of anxiety, but we're not necessarily picking that up and understanding why that individual in front of you is feeling a particular way. And so it's working with our care providers to better screen for pre-existing conditions.
Thank you.
Thanks.
The Honourable Mark Benasiak or the Honourable Natasha McLaren-Jones, do either of you have?
I'm fine at the moment.
I've got one in. Thank you very much. Just in relation to one of the recommendations you've made, which is on page 10, in relation to New South Wales Health undertaking review of New South Wales maternity care practices. And you refer to genuine birth model choice. Could you outline what that means and what type of review we would be looking at for the department to take?
Yeah, providing women an option for choice, and that's the one thing that we really want to see, genuine choice. Like, there's been a lot of conversation today about caesarean section rates, and what I sort of discovered very early on in working in this space is that often when we look at birth trauma, we are looking at vaginal birth versus caesarean, but we see it as much more than that. We see it as women not being enabled an opportunity for truly informed choice, whatever that could look like. We support women that have had incredibly traumatic caesarean sections, and we support women that have had incredibly traumatic vaginal birth, and we support women that have had everything in between. And so we need to create a model of care that enables women to have informed choice and their choices provided. And that could be a home birth, that could be maternal request caesarean, but at the moment it's a postcode lottery.
And I suppose, how does that work in the case of an emergency?
It's down to the individual. If we are informing people if we're providing evidence-based information in birth preparation, then decisions are made. If somebody decides to have, a home birth and they're not within a reasonable distance to a hospital, that's a choice that they're making. But do we enable that choice to help reduce trauma potentially? Is that what you? Is that?
Yeah, I suppose that obviously there is the element of consent, but I suppose my question is more about obviously giving women or allowing them to make that choice as to what type of birth, but how does that fit into a situation where, and we've heard before evidence that there is sometimes a split decision needs to be made. I suppose, how do you fit that into ensuring choice? And you referred to home birth. If it is identified that a woman is at risk, I suppose, how do you manage the choice of taking that risk and having a child at home versus going to hospital? I suppose, how do you manage that?
I don't know if I could effectively answer that question, but I can talk about, risks associated, say, in a hospital, for example. So often, even in my own experience, it came down to a decision between a forceps delivery and a caesarean section, and I didn't really know anything of the risks associated with forceps. And then I've seen the form where I've signed and agreed to that forceps delivery. So what we'd like to see around choice and risk is that conversations around risk need to occur long before they're in birth suite.
And probably also sort of uniformed information about the risk, so everybody knows quite clearly what.
Yeah, and I think, I just think we need to move a lot away from this conversation where we can't talk about risks associated with birth, because that's what it comes through again and again from the community that we support. Often women that we support say, I feel like I'm really prepared for birth, but nobody told me that this could happen. And that is a real disservice, I think.
Can I just quickly following on from that? In your submission, you also talk about the role of partners and their information, and there's a few fathers that you use. But do you think there's something in that space too around, particularly when you're in that moment of making decisions about what you need to do when you're in the birthing suite, to have better involvement of partners in that process, because then you're able to have that again before you're in that moment, if that makes sense, and then their inclusion in the process as well, because I note you say that some of the dads in this instance feel quite anxious about what happens in that space too. Is there something there that we could look to as well?
Yeah, I think it comes down to resourcing and investing in workforce, because often when we hear stories of from fathers, or we hear from women telling their partner's experience, is that they're typically left aside. They feel like a spectator. They feel useless, completely disempowered, and actually, often they're left often for hours wondering of the status of their partner or their baby, and there's just little changes that we could do if there was somebody in the room dedicated to communicating safety. And there is evidence that says that PTSD can be prevented in the moment that the trauma is occurring with the application of compassionate care, but that isn't occurring, and so people are walking out understandably traumatised because they have feared for the life of their loved one, or they fear for the life of themselves.
Yeah, thank you.
Thank you. I noticed in your submission you talked about that the New South Wales government should actually set up some kind of a legal clinic, particularly around OV. Can you talk about how this would work and why an actual legal clinic in this space is needed?
I don't think we did have that. Was that in our submission?
I believe so.
I think it was the one before.
Oh, okay. Sorry about that.
I have a different question if you need a sec.
I'll just ask another question and then throw it back to you if that's all right. And I believe, correct me if I'm wrong again, in case I've made a mess of my notes. You mentioned the economic impact of birth trauma in your submission. So, do we have any rough figures on what that actually costs at a financial level? Obviously, we've got a government right now that's talking about a budget black hole, and there's a lot of submissions that we've received to this inquiry with recommendations that would require, obviously, funding to be put into those spaces. But could I get an understanding of the cost of the system where there is birth trauma? So, will changes in some of that funding actually also help us save money over time?
Look, I really think this is an important part of the conversation. We know there has been, and I think we've got it in our submission, I'm sorry I can't find it, but the cost of depression and anxiety. And we know, we can pick out some of the factors in relation to birth trauma. For example, the cost of incontinence, that's in our submission as well, I believe. But it's very difficult to measure the ongoing costs. We have done some work with the Australian Physiotherapy Association to try and demonstrate the benefit of accessing a pelvic health physiotherapist in the perinatal period to, so that women are recovering effectively from the inside out and hopefully preventing ongoing issues such as pelvic organ prolapse and ongoing incontinence. We know that incontinence is the leading reason that people go into aged care, for example. But we'd like to get more understanding. I think there needs to be more research into the actual economic cost of birth trauma. We know that many women that we support will need multiple care providers. When you budget for a baby, you don't budget for the cost of couples counselling or psychiatry or specialist surgeons, and typically that element of cost is from families, and also the cost of not being able to return to work as well. We see that as well.
Thank you.
If I could just add, actually, that I think a lot of these economic costs are unquantified, and that's one of the reasons we are looking at extending the birth trauma inquiry and certainly making it Australia-wide, because at the moment we're only looking at New South Wales. I think also on an individual level, women could spend thousands of dollars looking for treatment and finding the appropriate treatments. So these things are all unquantified and also depend on the socio-economic status of the individual.
Absolutely. And I know you mentioned C-section before, and obviously a lot of our submissions talk about C-section rates and the link between C-sections and birth trauma. And I know obviously and I agree with your summary that it goes obviously beyond C-sections. But I think you mentioned that that there were at some point an attempt to create targets to actually reduce C-section rates that were abandoned. Can you give us any insight as to why they were abandoned and whether targets are the way to go? We've heard that there are various factors as to explain the increase in C-sections, such as age, but then there's not really been given any explanation as to why Australia is so high compared to other well-resourced countries. What needs to happen in that space?
I think targets around caesarean sections can be problematic, and it's interesting that the UK's low caesarean section rate was brought up. I think we mentioned in our submission the Ockenden inquiry, which was an investigation into 300 baby deaths and 9 deaths of mothers and hundreds of incidences of lifelong injuries, and that was a particular area of the NHS which took great pride in saying that they had the lowest C-section rate in the country. We don't want to echo that in Australia.
Thank you. Sorry, Dr. Mendicon had a follow-up.
Thank you. Sorry, on a very different topic, if that's all right. One of the terms of reference of this inquiry is looking at exacerbating factors that can impact birth trauma for particular priority population groups, and most of the large stakeholder organisations that we've spoken to haven't had any relevant data for LGBTQI plus people. And I note that you made some comments in your submission about LGBTQIA plus people as a group that are more likely to report having negative experiences with healthcare, and hoping you could expand on that.
Yeah, I can only talk about the support that we've provided to, say, same-sex couples, for example, and often having to really advocate for themselves in a situation where, 2 women are there and the care provider, well, who's the mum, or, I think we gave that example in the submission, and stories like that we hear quite frequently. But again, there's just such a lack of research in this space, and I think we just, our main recommendation is that we need to start gathering research. It's the same with culturally and linguistically diverse. What we see is, I'm sorry to say it, but seeking support for trauma does have an element of privilege, and I think there are barriers to particular groups to accessing to even acknowledging that they've got trauma and possibly talking about it. We need to find ways to break down those barriers, and I think that is by seeking to understand it more.
So true.
Yep, the Honourable Greg Donnelly.
Thank you both for coming along today. I think you were here earlier today and heard the evidence from RANZCOG, or part thereof.
Yeah.
Yep. You recall there was commentary in the contribution, also some questions around the definitional matter of birth trauma and obstetric violence. And if I could ask you some questions around the same matter, and that is that in terms of the two phrases, the two terms, obviously your submission running through it comments mostly on birth trauma, but does make some reference to the phrase obstetric violence. I'm just wondering, and you may recall from the RANZCOG submission, there was some tepidity that the idea of using the phrase obstetric violence might have some particular downsides, at least from their point of view as an organisation. I'm wondering, can you tell us about your organisation's thought about the two notions, the specific way in which you define both, and the utility or otherwise of actually using both the terms?
Thank you for that question. Yeah, we've really, it's a really important conversation, I think, to be had. I think that the label obstetric violence does act as a powerful reminder that some of this birth trauma or birth-related trauma is preventable. I do understand that RANZCOG's stance that it implies malice and intention, and I think it is really important to acknowledge. So we've talked today already about the workforce and people. We've got midwives leaving the profession, we've got obstetricians leaving the profession. We need to work collaboratively with the caregivers that are providing the support to families. to improve outcomes, and also more research. As I'm going to keep saying, more research. We need to sort of work with individuals that are directly impacted by trauma to find out how they feel about that terminology. I think we noted that we don't see it used within our community, but that's not to say that they wouldn't identify having as having obstetric violence. Maybe they haven't heard that terminology before, because even now we get calls saying, I've just read an article about birth trauma, I think I've got that. So we're sort of still fighting to get birth trauma recognised, and in fighting to get that recognition, we want to work with clinicians involved in the care of birthing families to improve outcomes. And I think if we're going in and saying that you're doing everything wrong, then it's going to be difficult to create change, and that's ultimately what we want out of this.
But don't you run the risk of trying to walk down the line and have two bob each way? I understand your answer.
Yeah.
But obviously there are particular groups and organisations and advocates and even academics that we'll hear later today that seem to believe it's quite important to quite deliberately and emphatically use the phrase obstetric violence. Now, if that does become entrenched in the vernacular in terms of dealing with the matter that's before us, does that run the risk of creating some tepidity and reluctance and, dare I say, even pushback from engaging on dealing with what is clearly a set of issues that no one's going to say, listen, this is all being imagined. That's just not the case at all. So is there that tension there?
I think so, yeah, absolutely. And I think it's important that we learn. And I think that there is space to use that terminology while also recognising that many people that have birth-related trauma do not identify as experiencing obstetric violence. But also equally, a lot of trauma that we see is completely underpinned by how people were treated in that moment as well. So they go hand in hand, and it's important to acknowledge both. I don't know if that answered that part of it.
It's I think going to be a challenging narrative to deal with over time. Just finally, from me anyway, the matter of consent. And you deal with this in your submission, and it's quite interesting. Would you like to elucidate a bit more about the idea of trying to bring about a greater clarity and determination that consent is actually being achieved before steps are taken or procedures are enacted?
Yeah, so in the stories that we hear, one of the biggest, consistent narratives that we hear is that I just didn't obtain. Nobody gave me informed consent. Nobody told me what was happening. I didn't know that having, say, for example, an induction would result in this. And it is often because these conversations are not occurring until women are actually birthing, and it's too late. There's no other medical procedure that you would obtain consent in the moment. And of course, I think that again the nuances lie is that birth is, particularly vaginal birth, is perceived as a natural event, so we don't seek to obtain consent, but yet so many women will end up with an instrumental delivery. So how do we have conversations? It needs to occur earlier, and we've tried to do that as an organisation. We developed Think Natal Education, which was designed to cover topics that are typically underrepresented in antenatal education, such as instrumental deliveries, such as perineal tears, for example, or recovery from caesarean. We want to sort of give that autonomy back to consumers, because so many people that we support come out of childbirth and go, right, I know what I need to do to advocate for myself. And we're trying to encourage them to have those conversations with their care providers sooner. For, as I said before, for some people, that's striving to have a vaginal birth. And for other people, I really want to avoid an instrumental delivery, but I want to try for a vaginal birth. How do I avoid that? And that can only occur. And I think that is where there's that opportunity for midwives and obstetricians to work together collaboratively, because midwives are incredible and they are exactly there to provide support for a physiological birth. But when things aren't going to plan, it is going to be an obstetrician that's going to come in and do the instrumental delivery or at caesarean section or in an emergency situation. And as was touched upon earlier, it's a complete stranger if they've had no relationship prior to that point. So how do we improve our care models to have sort of a collaborative approach so that women ultimately don't come out of birth blindsided by the outcomes?
Yeah, thank you.
The Honourable Anthony Dietten.
Thank you. Many of the submissions effectively favour or are encouraging the committee to look to specific models of care in preference to others. Your submission doesn't appear to take a position in relation to a preferred model of care that would reduce the likelihood of birth trauma. Can you elaborate on why you've taken that approach?
Yeah, absolutely. We support women that have experienced trauma from obstetric-led care. We support women that have experienced trauma from midwifery-led care. We support women that have experienced trauma from home births. So there's something that is occurring, and although it's really important to acknowledge the vital work that continuity of midwifery-led care offers, we also see there's opportunities to improve our care models, and that is with that collaborative approach. If we just said midwifery-led care is the best model of care, then we are ignoring all of the stories of the many women that have experienced trauma from that model of care as well.
In terms of it seems, I mean, I expect that the data is contested, but it seems that certain models of care have a lower incidence of birth trauma. And so I wonder, you know, obviously all models have issues, but some perhaps are better than others. Can you perhaps?
Yeah, I think for us, what we can say is that the women that we support are struggling to get a diagnosis. The women that we support are not under any model of care typically when they find us. Often people don't find us until they're pregnant the second time or they're thinking about conceiving. So I guess, how do we measure birth outcomes at the moment, and can we improve birth outcome measurement? Because, you know, again, we touched upon debriefing and connecting in with women after the birth experience. What we see is that typically they don't actually want to talk about their birth when they're in the hospital. So I think we've mentioned it in the submission as well, is that we want to see birth outcome measurements well beyond, you know, maybe perhaps a standardised 6-week check, but checking in with women at, you know, 3 months, perhaps up to a year postpartum, to really see how they feel about their outcomes. And I think that that's possibly what we're seeing. So many people they simply don't identify as having trauma. I personally didn't until I was 16 months postpartum.
I'll just go one quick one. Can I just jump in?
Yeah.
I just note you'd be aware of the work done by Western Sydney University.
Yes.
And specifically the BEST study.
Yeah.
I just note from looking at the paper itself, at the back, the acknowledgements, and it lists a number of organisations, consumer organisations, that were involved in the co-design and also the funding of the study, which I think raises the issue itself about actually people funding a study. But putting that aside for a moment, I just note that the Australasian Birth Trauma Association was not part of this, or at least not acknowledged. Is that the case? You weren't invited to participate in the study?
That is correct.
And can I ask you, did you receive or seek any feedback about why such a well-known and highly regarded advocacy group wasn't involved or invited to join?
We didn't seek feedback, no.
Did you receive any feedback from anyone about why you may not have been?
Only from members of the community asking why we weren't involved.
And what did you say to that? Just
I think there's perhaps at times a misconception that because we don't talk about, exactly to your question, that continuity of midwifery-led care is the answer to birth trauma, it's perceived that we don't support midwifery-led care, which is completely untrue. I work with universities, particularly in Queensland as well, presenting to student midwives, and I see firsthand where the burnout begins as well, is that these student midwives are undervalued. They're often told that they need to do dual degrees because midwifery as a profession isn't valued enough, so they have to do nursing as well. And then they're doing their studies and they're doing their prac, which they don't get paid for. So then they have to do, work on the side because they need to live. Yeah. And I recognise firsthand where the burnout begins. And we work collaboratively with hospitals across the country, but there is a misconception because of our position. But our position always comes down to the community that we support.
Thank you.
Thank you. So did you have something to add to that?
I just had something to add to the former question by the honourable member.
Thank you.
Just to say that we're really looking for a trauma-informed model of care. So it's not midwifery only or obstetrics only, it's really education and advocacy about these issues so that women and birthing people are actually aware of what could happen and how to treat it and who they can contact.
That's helpful, thank you.
Thank you, and thank you both for attending today. We really appreciate your time. The committee members may have additional questions for you after the hearing, and the committee has resolved that the answers to these, along with any questions taken on notice, be returned within 21 days, and the Secretariat will contact you in relation to these questions. So thank you again. Thank you.
Thank you for the opportunity.
Thank you for your time.
The committee will now break for lunch and return at 1 p.m. I now welcome our next witnesses, Dr. Hazel Keedle and Professor Hannah Dallin. Could each witness, starting at my left, please state their name and position title and swear either an oath or affirmation?
My name, is that on?
Yes.
Yeah. My name is Hannah Dallin. I'm Professor of Midwifery and Associate Dean of Research and High Degree Research and also Discipline Lead at the University of Western Sydney. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
I'm Dr. Hazel Keedle. I'm a Senior Lecturer of Midwifery at School of Nursing Midwifery at Western Sydney University. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Wonderful. Thank you both. Would either of you like to start by making a short statement of just a few minutes to the committee?
Yes, please. So first of all, we want to thank you for this inquiry and to thank you for the time that you've given to the voices of women in this state. We know that women have poured out their heartfelt traumas and experiences, and we hope that finally something is done about it and this is taken seriously. Over the last 20 years at Western Sydney, we've been involved in more than 20 studies. We've had more than 20 HDL, PhD students, more than 100 papers and book chapters on this issue. And nothing has been done. And the same things are coming up again and again and again. So I want to thank the committee, and I particularly want to thank you, Emma, for pushing this through and making this happen. No means no, except apparently in childbirth. And it's time to change that. This is the Me Too movement of birth that is now finally coming to fruition. The intervention rates in New South Wales have risen dramatically. When I was training back in the late 80s, early 90s, we were horrified at a 15% caesarean section rate. We now have a 38% caesarean section rate. We only have 50% of women having a normal vaginal birth. We have now got a 1 in 4 episiotomy rate that was high when I trained, went down due to the evidence is going back up. Our perinatal mortality and our maternal mortality has shifted slightly, but not hugely in that time. And we have about 13% of models of care that are midwifery group practice in this state and nation. We've become really good at saving lives, but we have not become so good at protecting minds and hearts. And there is more to life than death, and we need mothers and babies to be alive and well physically, but also psychologically, socially, culturally, and spiritually. Alive is the floor, but everything else is the ceiling. And I think in 2023, we owe women more than the floor when it comes to health. So we're standing before you today to say we have got a problem, and we are part of the problem as health providers, but we have solutions as well, and we're a major part of that solution as health providers. There are some key things that obviously are in our submission and many other people have raised throughout this time, but the first thing we need to do is prevent birth trauma in the first place. And I think we could halve birth trauma overnight if we actually really valued relationship-based care, and we had women being able to journey with a provider they knew throughout the pregnancy, the birth, and then able to debrief and be well dovetailed into appropriate services postnatally. We need more midwifery models of care. We know the evidence says that they lead to the best outcomes when it comes to ticking all the big boxes, which is quality, which is safety, which is cost, and it's something women are wanting. But we also need the right training pathways. We need the right retention strategies because midwives are burning out there, and we have a shortage of staff that is pretty horrendous, and no midwife running between several rooms can give respectful care in the way that women deserve it. We need to embed respectful care and the understanding of consent and coercion into undergraduate and post-registration education, and that's something we are looking at Western Sydney. We've led the way on perinatal mental health by getting doctors and midwives, social workers, psychologists to train together at undergraduate level, and now we're doing that nationally at clinical level. So I just sort of want to end by saying thank you. Yes, we're going to hear about a lot of problems, but we also know there are a lot of solutions, and we really hope that we can focus on the positive and take this forward for the sake of women. Thank you.
Thank you. Thank you both so much. Well, Susan Carter, did you want to start out?
Yes, thank you. Thank you both for coming today, and thank you both for the wealth of research and experience that you bring to this field. And thank you for providing a copy of your paper, Violence Against Women. Just a couple of questions in relation, I think, to the BEST study that underlies a lot of the work. So 8,500 responses. How were those responses obtained? Who were the women who responded to the survey?
Okay, so our co-designed survey with maternity consumer organisations was put out on different platforms in 2021 in March and was live for 9 months. We've actually written a paper about methodology which is under review at the moment, so I pulled some stats together from that. We used a variety of different techniques, both with our consumer organisations and then also using social media. We looked at what the evidence said about social media advertising and saw that there was an increase in getting a more varied response from women if you used social media advertising called micro-targeting. So we did 10 paid micro-targeting adverts, which meant we could highlight that we were looking for gender, the age and the location being Australia, and interests in pregnancy, and also looking at different cultural groups. So the languages, we had 7 different languages which were from the high migrant groups coming into Australia. So each of those adverts were available in English and also in each of those different languages. Altogether, we had over 12,000 people start the survey and 8,804 complete more than 70% of that. But with the advertising through social media, we were actually able to get 51,702 accounts access through, well not access, but advertised to through the advertising. So we really did have a broad spectrum across Australia. The posts were shared nearly 500 times, and we also had a QR code which was on a postcard, and we got about 2,600 come through that. So we did use social media, but we made sure that it was an evidence-based approach and that we could really target the groups of women that we were trying to target.
So in terms of the survey, you have representatives of all ages, representatives of all birth experiences. You've got regional and city, so it's statistically reliable in terms of city, country, birth experience.
Absolutely. When we looked at the rate of birthing in all the different states and territories, we had the same, if not more, in some of the smaller states of representation. So we had a good representation across the whole of Australia in all states and territories.
So, sorry, when you say same, if not more, it's my understanding that if you're putting a survey like this together, what you want is to go, all right, there are so many women who birth in a city hospital, so many people who birth in a base hospital, so many people in a regional community, and you will want, therefore, the same percentages of those represented. There'd be so many called women, there'd be so many First Nations women, you'd want the same percentages represented. You've got that in this survey?
We absolutely tried our hardest with that, certainly with getting the languages
So
done.
you have that in this survey?
We have slightly lower when it comes to Aboriginal and Torres Strait Islander and culturally and linguistically diverse communities, even though we did reach out to organisations that and consumer organisations in that space.
And so you have women, is this purely self-selection, or you went out to women who would not ordinarily be interested in filling in this survey?
We did work with organisations such as Refugee Health, and they did share our survey. And actually in the paper under review, we've listed all the organisations that shared the survey that would then be followed by members of that community.
I guess but perhaps what I'm trying to determine is we're specifically looking at traumatic birth. There may be a number of women who experience no issues in birth and therefore perhaps wouldn't self-select to fill in this sort of survey. How did you reach out to that part of the population so their views are represented in this survey?
Can I just add to that? The other thing that we did was go to places like Playgroup Australia, Australian Birth Breastfeeding Association. We also advertise through some of the major parenting websites like Kids Spots and Baby Centre and places like that. We also got interviewed in a lot of newspaper articles and online articles and asked people to contact us, radio interviews, etc. So we did our best.
I'm not. I have no doubt that this is, and this is a very hard area to do research in, and this is a large-scale first study. But to help us understand how we can best make recommendations for birthing women in New South Wales, it's good to really understand the nature of the data that we're being offered and what the holes in it that might be, how representative it truly is, and perhaps therefore where other work may need to be done to help us and to help all the women in New South Wales.
Totally agree, and no survey is perfect, and we definitely acknowledge the limitations.
And I wondered in particular, it was very helpful, some of the way you specifically in your submission address, for example, First Nation groups. Can you tell me what the sample size of the First Nations women was that you were using to draw those conclusions?
So this data is from the New South Wales data. So we pulled out all the respondents that were from New South Wales and focused on that. And what our numbers were.
It was slightly below.
I think we had about 3%.
Slightly below the birthing population, which sits at around 3%. It was slightly below that. It was something like 2.7%, if I remember correctly, which was quite good considering the difficulties that we have actually getting Aboriginal and Torres Strait Islander people to answer surveys. And we had Aboriginal and Torres Strait Islander people and a body involved in the survey design to look at the questions and make sure they were acceptable.
I can get the actual numbers for you if you
Thank you, that'd be, and one more if I may. As I understand it, this was an international or part of a larger international study. Are you able to look at, for example, how the experience of giving birth in New South Wales compares to other countries, and can we draw insights from what's happening in other countries?
Yeah, it's exciting that we're now part of the Birth Experience Study International collaboration. But as Australia, we're leading that, and we are the leads of that international collaboration. So far we have 12 other countries, and us makes 13 that are part of that collaboration. And so far only one of them have got data, which is the Netherlands. The others are in varying points of getting their ethics applications or putting the surveys out. But we do cross every single continent, and we've now also got countries in low and middle income countries as well. So we've got a really, we'll end up with a very interesting data set where we can compare women's experiences here to these other countries as well.
When might we expect that international data to be available?
Well, I think within the next few years. So we've got, we're working on one paper now between Australia and the Netherlands, actually looking at birth trauma and the factors that contribute to birth trauma, both here in Australia and in the Netherlands. And I believe our next country to collect data is Taiwan, and that'll be quickly followed by Denmark. And so, yes, we have they will be having their surveys out by the end of this year.
And just to let you know, the birth trauma rate in the Dutch data is much less than ours. We won't give you the precise amount, but the Netherlands has midwifery care for pretty much all women right through. So there'll be some really interesting exploration of that data.
Thank you. Dr. Amanda Conn.
Thank you. I'm about to ask some sticky questions as well, but I wanted to start off by acknowledging that the work that your group has done has been really seminal. The volume of other key stakeholders who've submitted to this inquiry who cite your work as, providing the key figures, particularly for the prevalence of birth trauma. You've clearly put this issue on the map. You're one of the only Australian sources of peer-reviewed data on this topic, and I really greatly appreciate that, and I wanted to acknowledge that before I get into the weeds of talking about the research. My reading of your submission is that you're presenting sort of raw survey results, and that those the different categories haven't actually been correlated with each other. Have I got that right?
Yes, we haven't done the full statistical analysis. Just for the timing of the report, we put together what we could for that.
Okay, thanks.
That's just for New South Wales, but we have done it for the big data set, and we have done it for the longitudinal birth in the time of COVID data set, and we found very similar trends in the outcomes. Yeah.
So sort of following on from that, I'm interested in the summary that you provided about different modes of birth that were most associated with birth trauma and then least, because some of that sort of appears to be contradictory, and I think without that formal correlation it's very difficult to unpick. For example, private obstetricians have some of the highest levels of intervention. Higher intervention was more associated with trauma, but private obstetricians had a much lower level of trauma. So what I'm trying to do is unpick sort of what are the actual causative factors there, because it seems like it's not just the model that's producing that result.
I think the tying thing there is its relationship-based care. So when bad things happen, or things that happen that are outside your expectations, and you're in a relationship with someone who you trust, who informs you, who then can debrief with you afterwards, no matter what happens, that leads to safer care. Yes, the intervention rates are much lower in midwifery care, and of course the lowest rates of birth trauma in private midwifery care, with the lowest intervention and the highest continuity. So there's no doubt continuity of care is got to be one of the biggest things in protecting women, regardless of what happens during their birth. And in the private sector, there are more women that choose private obstetric care because they are wanting to either hand over their decision-making to an expert, or are actually seeking intervention. That's certainly not all of them, but there is a higher amount, and we do have that data as well to show that having a normal vaginal birth is not as important as it is to women who aren't in the private sector. So there is an element of the need being met by the service as well in that.
So can I just jump in on that point then? That sort of aligns with what Dr. Watts was saying earlier about the profile of those who choose private obstetricians, being older and therefore more likely to have interventions, and that's more likely to be a question of choice. Is that fair to say?
So just to answer that, the profile or the demographics of women who choose private obstetric care are almost identical to the demographics of women who choose private practicing midwives. That's the great interesting thing about this. In fact, the women are older in that group that choose privately practicing midwives, yet you couldn't have two more polar opposites when it comes to intervention. Of course, women who choose privately practicing midwives are much more likely to want a physiological birth and a experience that they make those choices and are in control, whereas women who choose private obstetrics are more likely to perhaps not want that. But when we adjust all the data, as you very rightly pointed out, and we adjust for demographics, and we adjust for medical risk factors, and we adjust for mental health, we're actually finding that when you adjust for all of that, the best outcomes overall in all the models of care are private midwifery practice, followed by MGP, followed by private obstetrics, followed by GP shared care, followed by standard care as being the least positive in rates of intervention and birth trauma. So it's come out in two major studies that we've done that seems to be, and if you look at it, that really follows a trend of how much continuity you get. So continuity is, again, the key here.
So that would dramatically tip, if we adopted that as the, I suppose, the object of this inquiry in terms of recommendations, that would totally overturn the current state of play in terms. That's fair to say? I mean, the majority are in those latter two categories in terms of births.
Absolutely. So what most women have available to them at the moment is that standard fragmented model of care where they will see someone different every time and not be able to develop the relationship-based care, one that is continuous for labour and birth and postnatally as well. And so certainly what our studies and this study shows is that the importance of continuity of care, not only in all the results we already have from our Cochrane systematic reviews that we can see with midwifery continuity of care, but now also the impact of birth trauma and obstetric violence on women as well.
You mentioned the Netherlands. I think in another submission they cite that the Netherlands has 28% home births. I mean, and it's a totally midwifery driven system. Has that always been the case, or how did that I suppose if you're proposing a transition to a completely different system, maybe the Netherlands offers as a model of how you go from A to B, Are you able to give us any information about how the Netherlands achieved that?
The home birth rate in the Netherlands actually now has dropped quite a bit. So that's the honest truth. It sits at around 16, 17%. It used to be much, much higher. However, the midwifery model of care continues to be very strong. It's how the government has funded. So really, if you want to drive change in models of care in this country, and I know this is not New South Wales specific prerogative because this goes beyond you into Commonwealth funding, you have to relook at the models, the funding models that fund women. So, for example, New Zealand now, over 90% of women have a midwife they know provide as their lead care provider, providing that care. And that's because the funding has been given to women for women to decide who they select, and they can go out and they can use that funding and they can then get that provider. In this country, the funding is driven by the provider. And that is really shaping the models of care that are on offer. And I think that's a really important point to make.
So I don't think Dr. Amanda Conn had finished her questioning, so I'll return to her.
It's all relevant. I'm trying to unpick page 19 and 20 still, and it strikes me on reflection to your answers that the thing that private midwifery practice and private obstetrician care have in common, as you've said, is the continuity, but also that we're talking about patients with a certain amount of privilege and financial capacity to actually choose. So is it the choice that actually is the benefit of those models?
I think it is down to a choice, but I think it's also down to what women are actually looking for and expecting. And certainly we do have a document that I've brought around to you all as well called What Women Want, that does actually focus on a paper we've got coming out at midnight tonight in the BMJ Open that looked at the question in the survey, if you were to have another baby, what would you do differently? And so we've already then got women who've gone through a model of care and then are looking forward and going, well, what would I do? What are the changes that I would do? And we had 6,101 comments from women to analyse. And then we could actually look at, well, what is it about the model of care they want? What is it about the type of birth they want? And what things would they do differently? And there we can actually see that from the model of care, that choosing a midwife, continuity of care with a midwife, had the highest amount of comments, as did wanting to have a vaginal birth compared to choosing a caesarean. So I think that's one of the things you've got to bring into it. Not only is, what does have lower rates of trauma and obstetric violence, but measuring that against what women are actually wanting and requesting for in their next birth.
Can I just add to that and say that we have a Cochrane systematic review, over 17,500 women, 11 randomised controlled trials, where women are randomly allocated to midwifery, continuity care and other models. And so these are not all the same women. These aren't women who choose. These are women who are randomly allocated. And we have stunning results with less intervention. We have less babies dying. We have 24% less preterm birth rate. And we've also got cost effectiveness. So the randomised trials have been done. However, to come to your point, it is still often a privileged white pathway into these models. It's a who do you know and who's got the information. And everybody knows once they've had a baby that you need to once the blue line appears on the stick, you need to ring up and book your place for a midwifery model of care, which means that some of the women who would most benefit from these models are not getting a look in. And that's a real problem. There is lack of equity when it comes to accessing models of care that we know would probably make a bigger difference, because the research is now showing that, particularly with Aboriginal women. The bigger difference, the bigger bang for your buck from midwifery continuity care would come where there is disadvantage and in more of our minority groups.
Thank you. The Honourable Emily Savell.
Thanks, Chair, and thanks to you both for attending today. I just wanted to start with a bit of a leading question, I suppose, and seek your your advice. Would you agree that as health professionals and as elected representatives of a level of government representing the people of New South Wales, it is incumbent on us to consider evidence that is of the highest possible rigour when considering making decisions about healthcare within New South Wales that would impact people's lives and indeed the quality of the healthcare that they receive?
Absolutely, and as Hannah just mentioned, we already have that with randomised controlled trials and then a Cochrane systematic review on midwifery models of care. So yes, we have that. What the BEST study did was literally really go into the depth of what women were actually experiencing and their own experiences and their own comments around that, which is just as important when we are designing maternity services, that we actually listen to the experiences of women. And we ended up with over 54,000 comments throughout the survey, which is an important part to bring in. Not only do you need that high level of evidence, but you also need to be able to hear the voices of women as well.
Can I just add to that? I think also we need to look at what other government bodies are recommending, what other health bodies are recommending, and if you look at the WHO, if you look at the UN, if you look at ICM, if you look at FIGO, if you look at the NICE in the UK, etc., continuity of care is a central mandate now in all of the recommendations.
Yeah, thanks. And in terms of the BEST study, which you mentioned, the study utilised a non-probability self-selection for the recruitment of participants using social media and during screenings of a birth activist documentary. The paper also states that most respondents had a combined income of more than $100,000, were university educated and married or in a long-term relationship, and that 87% of the respondents were women that were born in Australia. How does your analysis account or control for selection bias?
I mean, it's part of any cross-sectional survey that's out there, and you try and mitigate that. And we certainly did by getting surveys translated into different languages and working with organisations that represented women from those communities. We did get more than we would usually get in previous surveys from those different representations, but still not quite as much as we would like. And this survey, which will be a rotating survey, we will learn from what we have got and keep on trying to get those voices out there. But you will find that is something that's common across cross-sectional surveys, which is why we did look at micro-targeting to really try in both languages, in different languages, and in English to try and get that out to women from a variety of different backgrounds.
If I can just add to that, what we do is also look at the data using statistical techniques that adjust. So that's the work we're doing now, where we're adjusting for demographics, we're adjusting for risk factors, we're adjusting for mental health, we're adjusting for a whole lot of predictors of both women who go into models of care specifically. Nothing is as good as a prospective randomised control trial, but they cost a lot of money and we have quite a lot of them. So really this was about having another look at another aspect of the data.
And in terms of the study, results that have grouped the yes and maybe responses to questions on obstetric violence together, are you able to provide the data on the two responses separately?
We did look at that, and we did put a definition of obstetric violence in the question because, as has been mentioned earlier today, it can be a term that maybe women are not familiar with. So we did put a definition in there. And the maybe just allowed women who were maybe not sure to then be given the option to leave a comment. So if they said yes or maybe, they would be put onto the next question, which was, would you like to tell us more about your experience? And that's where the paper came from, was the analysis then of those 626 comments around the yes or the maybes. When we, because that was a qualitative study, a qualitative content analysis, we did put all the comments together, and it certainly was not visible to see any difference between a yes and a maybe. They were all experiences that were valid and could fit the definition that we had put in the question.
So are you able to provide figures on the separate responses?
I can do, absolutely.
You can pull it
we
apart.
can go back to it.
Yep.
Yep.
Yeah, you can take that on notice.
Yeah,
Yep.
absolutely.
Thanks. Thank you.
The Honourable Mark Benaziak.
Thank you. I've just got a couple of questions around some of the recommendations you make, and feel free to take some of the detail on notice. In section 2 it says, ensure midwifery regulation protects women's rights by not punishing the midwives who support them.
Yeah.
It seems like a bit of a loaded comment there. Can you, perhaps on notice, tell us where in the regulations you see there is a potential or there is something happening there where midwives are getting unfairly or seemingly unfairly punished?
Yeah, I'll take responsibility for that one. These come from our book that we published in 2020 called Birthing Outside the System, The Canary in the Coal Mine. Myself and some colleagues put together international research on why women are avoiding our system. And analysing everything that people have written, we came up with recommendations. We've slightly adapted these. What we know from the research we've undertaken and others have undertaken is at least 50% of privately practising midwives in this state have been reported to AHPRA. And they've been reported often for just simply entering the doors of a hospital with an appropriate transfer, where they're transferring a woman from a planned home birth when she needs extra assistance. So we know that there is a disproportionate reporting of midwives when it comes to models of care like privately practising midwives. So we don't actually know the precise number. We know there's over 1,000 endorsed midwives in this country, but actually practising as privately practising midwife, there's much, much less. And we also know many of them have left and have been burnt out by the numbers of reports that they are getting to the regulator that are some vindictive, some absolutely needed to be done. But we've got a problem where we target people who are outside our norms in our system through the use of reporting to AHPRA.
Okay. And just probably the last one in that section too, appoint a chief midwife in the state.
Yes.
Governments of all persuasions like to create titles, and when you look at them, they look like a bit of an empty vessel. So I'm just wondering whether you could provide a bit more detail as to what you would want that chief midwife to be doing, what powers you would expect them to have, just a bit more meat around the bones in terms of that role. Otherwise, we leave it potentially up to a government. It might become a bit of a placeholder, but not much else. So if you could provide some detail around what you would like that chief midwife to be able to do and where they fit within the system and who they report to and all those sorts of things, I think that would be really helpful.
So we've been lobbying for this for a very long time. It's been in the UK for a while. There's a chief nurse and a chief midwife. As of last week, there's a chief midwife going to be appointed in Queensland, which we're very excited about, which will report, I believe, to the Deputy DG. We have a chief nurse midwife in this state that isn't a midwife, but functions in both roles. And they do great jobs. In fact, there are 2 chief nurse midwives in this nation that have midwifery. The rest only have nursing. And they do a wonderful job, and they have a very hard job. This is no criticism of them. But often, as a result of lack of knowledge and also dealing with a massive portfolio of nursing, midwifery gets left off the agenda and is not often prioritised or properly advocated for. So the role of a chief midwife would be to give advice to government, would be to be looking at what's happening on the ground, would be around putting into place support programs that are around sustaining the midwifery workforce, that are about growing that midwifery workforce, that are about putting evidence into practice and advocating for that profession. We've got such a shortage of midwives, I'm sure you're all aware, not only in this state but around the world. And one of those things that would be an absolute priority would be to build back midwifery so that we can actually provide women with the care they're asking for.
Do you have a preferred model in terms of the chief midwife that you're leaning towards? Obviously, it might be too early to tell about Queensland, but...
Look, I mean, the UK has a chief midwife, and that's the first chief midwife, and is now that chief midwife has become the chief midwife of the International Confederation of Midwives, which is even more exciting. So there's now one at that high level. But that midwife reports to the chief nurse, so I don't think it's perfect. I do think we need to have them respected equally and probably reporting to the Director General.
Okay, thank you. Thanks, Chair.
Thank you. Just a follow-up question from that. I was going to ask about the chief midwife as well. And you said one was appointed in Queensland.
They've just announced they will.
Just announced it. We also heard this morning that Queensland had a better sort of blueprint for action. We're hearing some quite positive feedback about Queensland's model. What can we in New South Wales be doing or learning from Queensland?
So Queensland, 28% of models in Queensland are continuity of midwifery care and 13% are New South Wales is lagging way behind. What really has made Queensland step right ahead has been that they have dealt with the issue of endorsement. I'm an endorsed midwife, by the way. And I worked as a privately practicing midwife for nearly 10 years. So what they've done is open the doors to endorsed midwives, which of course came about in 2010, Medicare, insurance, all of those things that are possible. But built into that, and I was the president of the Australian College of Midwives when this actually happened, there was a mandate to sign collaborative arrangements with obstetricians, which was the death knell to private practicing midwives. Obstetricians wouldn't collaborate, wouldn't sign up, and a midwife couldn't get entrance into a hospital unless she had that signed agreement. Now, there has been recommendation recently to get rid of that. That's going to take a little while to get into place. Queensland very smartly got the arrangements in with the hospital and not the individual provider, and they enabled privately practicing midwives to set their businesses up and bring those women directly into hospital, provide their care, and provide their care postnatally and antenatally in the community. We are way behind Queensland when it comes to that, and I really hope with the recommendations now that we do not need a signed collaborative arrangement. It was putting the fox in charge of the hen house, to be really honest, and we're 13 years down the track and we've proven that was a big, big mistake. That's not to say we shouldn't collaborate. Collaboration is absolutely key to safety. Women want us to collaborate, we want to collaborate. But to force a signature and make doctors feel vulnerable that they're responsible for decisions midwives made was always going to be a problem.
Yeah, thank you. In our submission from New South Wales Health, they say that they're experiencing barriers to expanding midwifery continuity of care models. Namely, they're talking about the workforce shortages and also individual challenges for midwives to work in a model with on-call requirements and things like that. I just wanted to get your response about that. I mean, how do we implement a midwifery continuity of care model? And are these sort of, if they are legitimate barriers, how do we address them?
I might respond on that because I have a PhD student just finishing her PhD on exactly this question, on how do we sustain midwifery group practice in Australia. And she's done an amazing study and is about to publish a paper that's really going to unpick what is going on. What often happens, these models all start with great bangs and everybody brings a cake in and sets off balloons and we're all really excited and then they drift, they morph, they are sometimes over micromanaged or they are sometimes not managed enough. And I think what we have is essentially an organic model that is about working with the woman when she needs it into a system that's all about the system. And so we often have managers who don't understand the way the model works. We often have higher managers, the executive managers, who don't understand the way the managers are trying to run the model. So we have a massive problem in fitting this really different way of working, that a midwife might be out gardening with her phone on her hip, and then she'll be in all night. And we have a real problem in working that out. We've also got a problem with our industrial arrangements where you can pop across the border and get better rates in another state. And so we lose midwives across the border. We're supposed to have one standard, but we don't. We also have a really interesting data that will be coming out in this survey, which is looking at what's the best training pathway to have midwives enter into midwifery group practice. And it's becoming increasingly obvious that the Bachelor of Midwifery, which is the 3-year direct entry program, leads to the greatest number of midwives going out there and practicing as midwifery group practice midwives. And so we need to really start looking at how do we expand these models that we know are leading to that success, how do we manage these models better, and how do we get smarter about the way that we sustain midwives in the model. So there's a lot of work to do, but we've got some very exciting results coming.
Thank you. And I guess the other question, which is related to that, I'm sure you've seen in the media that the government's talked about a bit of a funding black hole, and so funding's quite difficult. And obviously a lot of the recommendations that organisations have put forward will require funding. I just wanted to get your thoughts on, some of the other side of that we're also hearing about the cost of birth trauma. And, are we spending more by not actually putting in some of these sort of upfront funding? And if you've got some thoughts around that.
Absolutely. There's an ongoing cost of birth trauma for both the woman, for her family, and then also for those working in the system and the health system. certainly I know ACM will be able to talk about this later on, about the impact of birth trauma on midwives and what they found in their survey. But certainly from the women's experiences that we have collated, there is an ongoing impact, and that can be psychological support that they are needed and often aren't able to find, and then not being able to afford either, and the ongoing impact that can have with their next pregnancy as well. So yes, there is the psychological impact that birth trauma can end up with postnatal depression, PTSD, anxiety, but also untreated mental health issues as well.
Can I just add to that, because Hazel did touch on it, and I think this is a really important point. Birth trauma affects health providers as well. There are lots of traumatised midwives and obstetricians out there that are traumatised by what they work in, by what they see and what they're part of, and that is driving our workforce away. And so solving birth trauma is number one about women and babies and families. But women and babies and families are not the only ones traumatised, and we need to solve this for all of us. And it's an expensive thing to drive out after you've trained a midwife or an obstetrician to drive them away because they no longer can psychologically deal with what they're doing.
Yeah. I will also add, as well as in my role at Western Sydney Uni, I'm the academic program advisor, which means whenever a student has a problem in the Bachelor of Midwifery, they come and speak to me. And so I do hear from students about the impact of witnessing and not being able to then act, not knowing what to do, of seeing birth trauma. Now, most of those students will go through and continue their training with the hope that they're going to make a difference in the future and that they can make different choices. But unfortunately, some students are not able to work in that system and then leave.
I also wanted to ask you about the term obstetric violence that's come up a little bit throughout this morning, and I know that you have chosen to use that term. Can you sort of give us a bit of information about why you've chosen to use that term, and what terms we can be using to sort of differentiate something which talks about avoidable harm in comparison to trauma that is unavoidable?
Look, I can actually understand the sensitivity. I can, because at face value, it can sound like it's about obstetricians, and in fact it's not. If you look at the Latin for obstetrics, it actually is pertaining to a midwife. If you look at what it actually means, it is one who stands opposite the woman giving birth. That is exactly the Latin underpinning of obstetrics. We don't have a problem with obstetric trauma. We don't have a problem with obstetric hemorrhage. We don't have a problem with obstetric emergencies. We understand that involves all of us in there working together. We have a problem, or some people have a problem with obstetric violence because they feel that it is a direct label of a group. And it is not a direct label of a group. Midwives are absolutely involved in obstetric violence. The WHO has talks more about disrespect and abuse, but we also have the UN that has had a special rapporteur report that has directly used the word obstetric violence. It's also a legal term. It's also a term that is in legislation in quite a few countries. I actually think that our a colleague who follows shortly, who's a lawyer, is going to be much better at telling you exactly what the legal underpinnings of. However, I think if we need to move on, I think we need to learn what environments and what language do we use in what environments in order to get us to move on together. And I'd like to say right up front, this is not about obstetricians. This is about all of us. And it's women who suffer. And the term is a legal term. It is a well-recognised international term. We once didn't like the word domestic violence. We preferred domestic discord. We preferred softer words. Now nobody blinks an eye at domestic violence because it is what it is. Perhaps we'll come to a point where no one blinks an eye at obstetric violence, or perhaps we're going to have to soften and change the term to get us all on the same page. But I do not think the term should hold us back from recognising the reality of what women have told us and that we need to do something about it.
Yeah. Sorry? And in our paper on obstetric violence, we asked women what they thought, what they described, and certainly their descriptions included feeling disrespected, feeling powerless, but also experiences of physical and sexual assault and trauma and violence. So if we have a look at what is being experienced by women and those experiences were there, then the term violence most definitely comes in. We're also an international collaboration, and so if we had one term that we use in Australia and then different terms across our 12 other countries, then there would be maybe an issue with our data as well. So we have to recognise that this is an international problem, and we are part of that international community.
Thank you. I also have got a question about informed consent and informed choice, and I think you refer to both, and I just wanted to get an understanding of the difference between informed consent and informed choice. We also have in the New South Wales Health submission, they said that that there is consent training through the My Health e-learning system. I'm not sure if you're familiar with that consent training, but is that enough when we start to look at some of the data that's coming out where I know one of the submissions said that 1 in 5 women felt that they didn't have consent, they hadn't quite consented, or they weren't sure if they'd consented to things. Obviously, there is this consent training happening, but why is there this gap, and what can we do?
I think the legal definitions will certainly be mentioned a little bit later, and not for us. But from our study, we did actually look at the informed choice aspect with how involved women felt they were in the decision making, and we used some recognised validated tools that are used across research, which are the Mothers on Decision Making and the Mothers on Respect Index. And we could see that the highest score would be high autonomy, which is having full involvement in all the choices and the decisions that you made during pregnancy, and less than 0.5% of the women in our survey felt that they had that high autonomy, and going down to 9% of having very low autonomy, having very low involvement. So others can look at the definitions, but to understand that women are not experiencing informed choice in their maternity care experiences.
Thank you. I've just got one more before I throw to the Honourable Greg Donnelly. We've seen this thing called the Blueprint for Action Maternity Care in New South Wales, which was published in March, which has come out from New South Wales Health. I'm just wondering what feedback you've got on that document, if you've read it, and if you think that it's going to be enough to help us sort of move through birth trauma.
Look, I would have preferred to have seen it much more in line with the woman-centred care strategy that has been put out by the government. I think that's an extremely good strategy. I think there are some very good things in it. My concern is, and I've probably been in this business a little bit too long now, but I've seen us moving away very much from the woman and down to the line of the baby. And I really, I'm 100% behind the first 2,000 days. I think that absolutely nothing matters more to a woman than her baby and her partner. But if we do not put enough protection, support around women, the hand that rocks the cradle does rule the world. And we will see the implications of that in the children. So my only concern would be, let's get up the front end. Let's prevent the bad stuff happening. Let's stop always going down here and pulling people out. Post-trauma, post us making a mess of things, post us not providing services. And I think we need a little bit more focus on the prevention.
Thank you. The Honourable Greg Donnelly.
Thank you, and through you, Chair, thanks for coming on this afternoon. I just want to ask a couple of questions around trying to reconcile some work done by New South Wales Health and testing satisfaction, use that phrase, satisfaction levels or satisfaction rates with women giving birth in New South Wales, and the figures that you have in your in your documentation. I've just got a copy here of the report. I wonder if someone, Secretary, just thank you. Just if you could please, thank you, pass it up. I'm sure you've read the New South Wales Health Report. It's paragraph, it's section 3.3 on page 11. I'll let you just perhaps read that. Just take a couple of moments.
Yeah, we're definitely very aware of that.
Of course you are, yeah. So, just looking at the numbers, that would suggest, it seems to me as a layperson, a high to pretty high satisfaction rate with respect to those questions asked. I don't know what the precise questions are, but they are the percentages that are attached to what's said there. So if you just take the first one, the headline one, 94% of women rated their care during labour and birth as either very good or good. And reconciling that with the figure nearly 30%, or in your documentation, 28% of women experiencing birth trauma in New South Wales. How does one put them side by side and say, this is reflecting the same thing? This is women experiencing the same thing in the state of New South Wales as they experienced labour and the birth of their child.
First of all, ask very different questions. I have no problems with the prems and the proms. I think that they provide a very important service, and I think they answer a very important question. So the prems measures really the process of the care provision. The proms measures, clinical care effectiveness. It's a short survey. It's designed to be completed to meet a whole bunch of benchmarks. A classic example for me is when the results were released a couple of years ago, and we had the RIDE continuity care midwifery practice and the Wyong one, etc., which scored green.
Is this a 2019 survey you're talking about?
Yeah. So they scored green, excellent for everything, and then they scored red for the appointment was longer than 20 minutes or took longer than 20, whatever the standard was. And that's because women in that model had an hour-long appointment. So there are things in that need to be adjusted to run with our survey, to run with our current contemporary models. However, the difference and the value, and I'll let Hazel continue on from here, is we analysed women's comments, numerous comments. Those are not as freely available in the prems and proms, and it was the comments that enabled us to really nut down on some of the issues that are not being picked up. So the questions around birth trauma, it doesn't mean that all birth trauma is caused by providers or that women aren't satisfied with the care that they got, but they're traumatised. So there's a lot of, subtlety. The other thing is that 90% felt they were respected with dignity. Well, that means 10% didn't. And that kind of lines up a little bit with some of the stuff we found with obstetric violence. So it is a different survey. It targets a hospital population in the majority, and it certainly serves a purpose, but our survey was specifically looking at birth trauma and that experience.
But just confirm, we talk about the same. So this is the Bureau of Health Information survey of 2019. Yeah. You said a couple of years ago that's only 2021. Are we talking? Sure, we're talking about the same survey?
Yeah, we are.
So your answer to the question is that you can put these two side by side, and it's not irreconcilable that you actually have one survey saying 94% of women rated their care during labour and birth as very good or good across the state, New South Wales. But also, if you asked another question or conducted another survey asking another question or other questions, you would find that 30% of women would say they have experienced birth trauma.
I think that's understandable. It also comes down to timing of when these surveys are put out. So if they're put out in the immediate postnatal period to be filled in and then sent back in.
Sorry, can I just clarify? The survey that we're referring here is the BHI data, not the PREMS survey.
Okay.
Yeah.
Right.
First of all, you need to...
That's why I've asked the question twice. So we're not talking about the same survey you referred to, just in your response. Is that right?
Well, if it's not the prems and the proms, that is the most common survey that I am aware of that is sent out.
Well, that's why I took the time to take you through. This is the Bureau of Health Information survey.
So I just want to let the member know we've got some other questions, so just to get to the point of the question, just for the time.
Well, I've asked the question clearly. We've now discovered the...
Can I suggest that we take it on notice and we'll get back to you with the response?
Absolutely. And one final one. Was there a reason why, with respect to the BEST study, that the Australasian Birth Trauma Association was excluded from participation?
I'm happy to answer that. We've just been in the corridor, had a lovely conversation, shaken hands, and they will definitely be involved in the next version. The Birth Trauma Association has moved on a long way from their original setting up. And the original setting up was very much focused on pelvic floor trauma, and some of the discourse that was out there was very, very dominated in that area. However, there has been a significant change, and they are doing amazing work, and Amy Dawes and I have been out there having a lovely conversation, and they will be involved in the next survey.
Wonderful, thank you. The Honourable Sarah Mitchell.
Thank you, Chair. I just wanted to pick up on something I think, Professor, you said earlier about Queensland having a higher percentage rate of midwifery-led care in comparison to New South Wales. And I'd be curious whether you've got any insights into, particularly in rural and regional communities, and obviously there's similarities with distance and population in Queensland as there is here in New South Wales. Do you know if the rates there in rural communities also increased, or was it more in the metro parts of the state? I'm just trying to understand whether the rural element has seen growth in Queensland as well.
Better than us, but certainly not perfect. And there's no doubt that rural remote women, and I've just been in Canberra last week at a round table looking at the plan for rural remote women, there's no doubt that they have less options and less models, but Queensland is doing that better than us.
Is anything specifically that Queensland's doing that we could look to emulate, particularly in the rural communities? I mean, better than it's useful, but anything specifically?
Privately practicing midwives is something that they are doing because they've got the ability to open the doors to them. Queensland's not perfect, and what they're not doing well is not providing publicly funded home birth, may I say, and that's something New South Wales does really well.
Okay. So with the privately funded or the private practice midwives, do they have those relationships with the local hospitals that you spoke about earlier as well?
That's
in that
right.
model? And how do they manage that with staffing as well? I'm making general assumptions here, but if you've only got sort of, maybe one or two midwives in that, if there's multiple women, they happen to be labouring on the same day, like in practical terms, how does that actually work?
When I was in Parliament House for this roundtable last week, we were exposed to some incredible models where midwives, GPs, obstetricians all worked together, and the midwife had the woman had a midwife she knew as the thread throughout that care. And we've got some extremely good exemplars. We've also got an extremely good model down in South Australia where they are, dealing with incredibly remote areas where they have turned everything over to a midwife-led care, collaborating with obstetricians and GPs. We can do it. We've got some really good examples of how to do it. We have to get past the politics, and we have to also start to look at funding and access agreements.
If possible, on notice, if you could provide some information of a couple of those examples or communities that maybe the committee can look into in a bit more detail, that would be
I'll send you through the South Australian example. It's extremely good.
Yeah, that'd be great. And I just have one other quick one because I know my colleague has a question as well. Just in relation to, I think it's page 8 of your submission, where you look at the impact of induction of labour on birth trauma and saying that there was a higher rate of birth trauma for women who had to be induced. Just some general comments on, what you found in that study, why that is. I mean, again, making a very general assumption that often people who do have to be induced maybe have other sort of underlying risks or factors, but is there anything that we can take away from that particular statistic that you think is relevant?
Well, our induction of labour rate has increased across Australia, and we haven't always asked women, how do they feel about that and what is their experiences. So not only did we see that there were higher rates of birth trauma, but in the paper coming out tomorrow, we asked them, when they looked at what they would do differently, many women said that they would avoid having an induction and that impacted on their birth trauma. Like most basically, if you have a plan for to be upright and mobile and have active labour and birth, then being induced really makes that very challenging. So, then we've got higher rates of intervention with that cascade of intervention that I know many submissions have spoken about, that then start with that first induction of labour. You can speak more to it.
And 41.3% of first-time mothers in New South Wales in Australia, and New South Wales has very similar statistics, are being induced, and that has risen dramatically. And not enough attention's been put on the impact on women. And some big reviews, systematic reviews of the evidence, have shown us that women don't feel adequately informed or prepared for what happens.
I just wondered if that's part of the broader education piece that we've been speaking about today too, in terms of what your choices are around induction and what
why not you might need to. So that might be
And
something
the
we can
UK, may
explore.
I just say, a really good example is the NICE guidelines on induction from the United Kingdom. They have an extremely good section on what does informed choice mean for women having induction, and it's really worth a read. I'm happy to send that through.
That would be
to
great.
you.
Yeah, thank you.
Thank you very much. I'm mindful of time, but I wanted to ask about your question around the complaints process, and I'm mindful that there was quite a large number of people that said they didn't feel they needed to complain. However, around 400 said that they did. I'm interested to know if anything came out of the research as to what needs to be done to improve the complaints process, I suppose beyond increasing education, but specifically around the Healthcare Complaints Commission and what things this committee could look at.
I think from the comments that we looked at, and we're also looking at the debriefing process as part of that paper, is that women often don't know what the options are, or if they go straight to the hospital, they might not get a very adequate response and feel that they don't then know where else to take it. We're also asking women who've just had a baby and are very busy with caring for a baby to then go for that next step of writing it down. And we know just from the submissions that it takes a lot out of people to write down their trauma, and so that also comes out into how you would then write that letter of complaint. But a lot of it is just not knowing what the options are and what the processes are, and then actually getting a response that is not defensive or tries to negate the woman's experience.
Can I just add just one comment to that? The paper that's coming out tomorrow, one of the saddest things about that paper is one of the largest category is that next time I'll advocate for myself better, and women are telling us that it is basically their fault that it happened to them. And so women take on a lot of self-blame and they feel a lot of failure, and therefore they often don't feel they have a right to complain because they feel it was their fault. So I think we have to change the discourse. We don't want to open up the doors and say everybody complain. That's not the answer. But I think we need to really start to have conversations with women as to what are the pathways and what are the potential strategies that can help them move on.
And just one last question, just about the survey which was conducted in 2021. When you were looking at the responses and whether or not you've actually sliced the data, looking at it from each jurisdiction and the pre-COVID period and the COVID period, because obviously each state and territory were dealing very differently in response to COVID. So I'd be interested to know, did that affect, or if you've actually looked at the when those women responded?
So we kind of had two studies going on at the same time. So with BEST, we have in future papers, and the one coming out tomorrow, we have actually brought into the pre-COVID and during COVID, because it wasn't ever after, pre and during, so they can see the spread of those comments. But then we weren't asking particular questions about COVID, but most definitely there were impacts to it with a lack of support or being able to bring people in, or changes to their models of care. But then Hannah was leading the Birth and Time of COVID study, which was looking particularly at women's experiences during COVID as well.
Yeah. So we do have a specific study which we're publishing on now, which is looking at women's birth experiences during COVID and what changed. And I can tell you that the more negative experiences were in places like Victoria.
And that's I'm interested if you've broken that down by jurisdiction, because obviously Queensland would be different to New South Wales, to WA and every other.
We haven't yet, but there's so much data and so much work to do, but thank you for the suggestion.
I don't want to put you in more work.
More work.
Well, thank you both so much for attending today. If committee members might have additional questions for you after the hearing, so the committee has actually resolved that the answers to these, along with the questions that you've also taken on notice, be returned within 21 days. And the Secretariat will contact you in relation to those questions. But thank you again so much.
Thank you all.
Thank you.
Thanks for coming.
Thank you.
That I've known Dr. Kumar Hazard for a very long time. She's an old friend of mine, so I just wanted to put that on the record.
Thank you.
You have to be nice then.
I'm always nice.
I know.
You that.
When Mr. Diadam and I were at university, we used to laugh about whether or not our economics degree was going to take us anywhere. Here we are. Where else would you rather be?
I now welcome our next witness, Dr. Bashir Kumar Hazard. Could I ask you, please, Doctor, to please state your name and position title and swear either an oath or affirmation?
My name is Bashi Kumar Hazard, and I am the Chair of Human Rights in Childbirth. I'm also have a doctorate with the University of Sydney Law School.
Sorry, did you swear the oath
no,
or defamation? Okay.
Pardon me. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making a short opening statement of a couple of minutes?
Yes, if I may. Since my statement or my submission's not online, if I could just quickly go through the summary of observations human rights in childbirth. Let me start by saying that we are very grateful to this committee for initiating this inquiry. We think that it is a conversation that is about time that we had in Australia, but the fact that New South Wales is starting it is probably going to mean something for the rest of the country. Our organisation is an international not-for-profit legal and human rights foundation. We were founded in The Hague in 2012. I was asked to join the organisation in 2013, shortly after I commenced practice in this field. And then I've recently been asked to take the chair. So our mission is really to monitor and report human rights abuses in pregnancy and childbirth. And in Australia in particularly, we've been advising and advocating for women in this space. We advise women who are abused or mistreated while accessing institutional care, but we also advise and advocate for healthcare providers or support people whose employment or income is threatened, or for protecting women in their care. And we also, in particular, probably support the most vulnerable amongst us, women who face police inquiries or have to deal with the Department of Communities and Justice and extended hospital investigations or reports because of the choices that they made while they were pregnant, healthcare choices while they were pregnant. So I would like to start by making a few, these are the summary of observations in my submission. The abuse and mistreatment of pregnant women and people in maternity health facilities is a normalised everyday event, and it is embedded in the institutional and professional culture and practice. And I ask that the committee considers this when you are dealing with somewhat defensive responses, or because we do see that in our practice every day, is that what happens is that people have become very accustomed to doing things a particular way. And so when we call something into question or we challenge the way that's being done, there's definitely a response of, but you don't understand what's happening here. From our perspective, of course, we're seeing the impact that it's having on women. So we've had clients and women come to us who've sadly committed suicide or attempted suicide. We've seen situations where women have rejected their infants, and it takes a lot of counselling and support to get them back on track. We've seen women who engage in, basically substance abuse or relationship breakdown is a very, very big part of what we've been seeing. Families separate basically because the woman who's been subjected to the abuse feels that she's been betrayed by her partner, who was equally helpless in that space. We see a lot of ongoing diagnoses of PTSD and anxiety and depression. We see a lot of women give up their careers and also struggle to re-enter the workforce, and that is a very big issue because many of them have significant out-of-pocket expenses that have come as a result of that injury, either because of getting psychiatric or psychological assistance, or they have pelvic floor injuries or third or fourth degree tears. So those are the things that we see. We see a spike in domestic violence, and we see women reject healthcare, particularly for themselves and their infants, and vaccinations is especially a battleground in that respect. It's not limited to the intrapartum period. There's a lot of focus on labour and birth, but from our perspective and the work we do, we see it happen from the time a woman is initiating access to a health service. Indigenous women are particularly vulnerable in this space, refugee women as well. And if women cannot speak English very well or as a first language, then they really are in difficulty. Young women, women from lower socioeconomic backgrounds are particularly vulnerable to being pursued by the police or the department, DCJ, and of course reports to the health authorities or in fact to the sheriff. So we've seen a bit of that. It's also not confined to the women. Okay, anybody who stands up for the woman, we've seen actually also it's a guilt by association. They tend to get attacked or abused or sidelined. So there's generally this sort of feeling of hostility that surrounds a woman who's seen as alternative. And underpinning all of that, and you've probably seen it from all of the submissions that we've seen being put on site, is that informed consent is a very big issue in the way in which healthcare is being delivered. So, and I do acknowledge that this is probably something that no one else has looked at, which is the discriminatory laws and practices that we have in place, which I think Parliament can actually examine, and this is a fine opportunity for us to look at and review some of those legislation, and also to look at the institutions that support our healthcare providers, such as the coroners and the police and DCJ, and the involvement and paramedics and the involvement they have in facilitating this kind of normalised culture. And I'll wait for you to ask me questions about the definition of obstetric violence, but let me stop there and just say that Australia does have an obligation under CEDAW to prevent gender-based violence against women, and I'm hoping there are certainly a lot of specific recommendations that have been made by the committee, and I'm hoping that this inquiry will consider them in some detail.
Thank you. I might start with a couple of questions, if that's all right. In New South Wales, we don't have a Human Rights Act, while other states in Queensland do. And I'm just wondering if that limits the protections afforded to women in New South Wales who are given birth, and what sort of model or legislative changes do we need in New South Wales to ensure that women are protected here in the same way as they are in other states?
Sure. So let me start by talking about the Queensland Human Rights Act. There's a tiny little provision in the Queensland Human Rights Act under Section 17C of the Act which states that a person cannot perform any or provide any medical treatment to someone without true and proper informed consent. So informed consent has now been enshrined in law. And whilst there are very limited teeth associated with the Human Rights Act in Queensland, what it has done is it's starting to make a cultural shift in our facilities. So women have an avenue to go to someone like the Ombudsman or the Human Rights Commissioner and say, I was denied informed consent, or my right to informed consent was not duly protected by this health facility. And if the Commissioner gets enough complaints along that front, they will put it all together and provide it to the government. The government has to consider it and take it seriously. The government also gives it to the Queensland Health Ombudsman, who has to take it seriously. So what it has done is driven a bit of cultural change. Now that's not to say that it isn't a slow process. We see the same sort of resistance in Queensland to that cultural change as we may see here.
And you talk about them being able to go to the Ombudsman, for example. What are the legal avenues here? Does it just require somebody to take on their own legal case? Like, what's the difference?
So what I do is I sort of break that down under part 3 of my submission, but the avenues for women here are limited. So in terms of complaining, women can only complain to the HCCC. Unfortunately, access to getting the HCCC to take these complaints seriously, it requires 2 things. One, there has to be injury to the infant. And the second is that if there's injury to the woman, it has to be permanent and or enduring. PTSD doesn't count. under those kinds of categories. So unless a complaint accompanies those kinds of elements, it's not taken seriously. Informed consent is considered a soft skill. We have made, I would say, in the last 11 years of doing this work, I would probably have made on average about 120 complaints a year. And without doubt, I can almost anticipate the answer if the claim is about a violation of informed consent. It will be, thank you, we'll let the practitioner know.
And it's interesting, I mean, you talked about true and proper informed consent, and most of the submissions talk about communication and consent in some form or another. And one of the questions that's come up quite a bit is, what if there's an emergency and it's a doctor that the woman hasn't met before, or they're in a different emergency service? I mean, what is true and proper informed consent, and how do you build legislation around that without it becoming too difficult in an emergency situation?
So informed consent in and of itself has a lot of law behind it. In order to be informed, it obviously has to be, the right information has to be given, it has to be freely obtained, so the practitioner has the obligation to give that information and give the woman choices and to give her time. So it has to be timely. She has to have time to think about it, free from any kind of constraints or coercion, and she can change her mind at any time. That's just not how our system is structured. That can, obviously, it is, whilst the phrase is in legislation, it's open to the courts to interpret it. It also is informed by international law. So we've got the International Instrument for Bioethics Principles, we've got the Convention on the Elimination of Violence Against Women, we've got the Convention on all forms of elimination of all forms of discrimination against women. All of them define what informed consent looks like, and it's very carefully preserved as a fundamental human right. Within healthcare, maternity healthcare facilities, we need to start distinguishing between what is called an emergency and what is essentially standardised processes. So standardised processes is more common in maternity healthcare than we think. A woman at the point of admission, when she comes into hospital, we can almost predict now, just from getting their files, what the process is going to be. On admission, she'll be checked. We'll probably take her vitals. Somebody will come in and assess her. The midwife will review, her file or her antenatal reports. They'll do a vaginal examination. There is at least about 4 or 5 routine processes that are already, implemented in place. Now the woman doesn't know that any of these are routine and that she has a choice in relation to it. She's rarely counselled about it. She's just told it's going to happen. Those things actually build up into quite an intense period. So as the labour progresses, a woman becomes more and more distressed and more a feeling of, loss of control and violation. At the very end, and we do concede that there are times of genuine emergency, and there are, but for the most part, certainly for the hundreds of complaints that we see, what constitutes a genuine emergency is not necessarily there. What is seen as an emergency in the facility is that they're short-staffed, the doctor is running out of time, they've only got a few minutes and they're bolting from room to room, and they need to get things done. They need to sort out one woman before they get to the next. And so there is a sense of urgency and immediacy that's pushed on her. She doesn't know that this is the context in which she's, trying to sort of navigate her labour and birth. So, and this is not actually something that we're making up. In the Special Rapporteur's report on violence against women in the context of facility-based childbirth, so the obstetric violence report, the Special Rapporteur said that there is quite a significant abuse of the doctrine of medical necessity. This is medical necessity being emergency procedures. And that, because providers get to decide what constitutes an emergency, they tend to pretty much declare, as much as possible. And that's not intentional. They're responding to a system that's under pressure. Usually they're the only ones, or it's the middle of the night, they're short-staffed. They will treat it as an emergency because in their minds, they're running out of time and they can't negotiate. They will not be able to give woman-centred care.
And sorry, is that due to staff shortages predominantly?
Well, staff shortages, and obviously we do think that there is an element of interpersonal issues. I think, compassion fatigue really affects staff who are under a lot of constraints. It's not just staff shortages, it's the policies and the protocols. It's the fact that nobody quite knows who's in charge. Nobody quite knows that the woman who's under their care, so this woman has seen probably about, 10 to 15 different providers before she turns up in labour. And it's a big ask. It's a big ask for whoever's looking after her to can't get on top of all of those needs.
The Honourable Susan Carter.
Thank you, Chair, and thank you, Dr. Kumar
Aptly
Hazard.
named Hazard, yes.
Yeah, sorry, I was scrabbling for my notes. You spoke about the Queensland Human Rights Act. So Victoria, the Commonwealth and the ACT also have legislation in this area. Does any of that legislation include a right to informed consent?
No, they don't specifically refer to the right to informed consent, and also they don't really have the kind of... So there is an obligation on, say, the courts to take into consideration that legislation, but there is no opportunity for women to get, complaints lodged on the basis of those violations. So no, and informed consent, I think, has only started to rise as prominently as it has, because we're trying as a society to encourage patient autonomy, and patient autonomy can't progress without some measure of respect for informed consent.
And you said that informed consent is very well defined and understood as a concept internationally. In the context of an unplanned forceps delivery, what would informed consent look like?
So one of the examples that I give is that women will be told probably in the 5 minutes before they're due to give birth.
Sorry, I don't mean to stop you, and I understand the examples that you've given, but not what's happening now. But
okay.
If there was going to be informed consent in an unplanned forceps delivery, what would that look like? So we know what we're trying to achieve, perhaps.
So we know that repetition helps. So I would say that antenatal preparation would be, unfortunately, to hold up those giant tongs and say, this is what a pair of forceps looks like. And it could be that if your labour is not progressing to a certain point, or you're not pushing the baby out at a certain point, then we may have to use this, or you show them an image of the ventouse, and then you have to explain what the risks will be, including 3rd and 4th degree tears, or injuries to the baby's scalp. Those are the realities that women need to know, because that's the thing that they're most concerned about, is that whilst they're there in a very vulnerable position, somebody whips out these instruments and proceeds to use it on them. So they need time to consider that. But even during the labour, I would say that she needs someone to come in 10 or 15 minutes beforehand and say, this is something that we need to do, or the alternative is that we would recommend that you have a C-section, and then you step out and give her the 5 minutes to think about it and talk with her partner about what she would prefer. Ultimately, if we're talking about informed choice, we need to be quite realistic and not push one agenda over the other. We do tend to see that happening a bit in this space.
So in a Rogers and Whittaker context, why aren't these warnings about possible side effects being given currently? Because that surely exposes healthcare providers to action.
It does. Unfortunately, though, we have a Civil Liability Act and particularly the legislation here in New South Wales, that means that none of these cases are coming to court because the level of injury. So if it is a 3rd or 4th degree tear, yes, it will end up in court, and there's a failure to warn kind of element that will be thrown in. Unfortunately, what the courts would see as failure to warn would not actually translate back into practice. So there are some aspects that matter to women in terms of the failure to warn. So it's got to be material risks. And it takes time. The courts have to sort of say 3rd and 4th degree tears are a material risk. But nicks to the baby's scalp arguably won't be considered a material risk because they're not significant enough. The other aspect is that if the women have PTSD, unless it falls under Section 16, which is 15% of the worst kind of injury or the most extreme kind of injury, so there has to be some kind of physical injury attached to it, they won't even get past first base in terms of filing a claim.
Can I just ask a question to follow on from that? as a non-lawyer, unlike my colleague, I just wanted to understand, so say in that scenario that you just played out where, you know, the recommendation from the doctor is to have a forceps delivery, the woman has time to consider and decides, no, I don't want to do that. If something then happens to either the mother or the child, and it goes into that area of medical liability, which you do talk a little bit about in your submission, but I guess just in like layperson's terms, if the worst happens and the child is either injured or doesn't survive childbirth, where does that liability come in terms of the decision that was made? Is that something that midwives or doctors would be nervous about, that process? Because that's the part that I really struggle to grapple with, because I can see the importance of women making informed decisions, but then if they're not also medical professionals, where's that balance lie?
So there's two aspects to that. I think you're absolutely right. We have a situation in medical liability laws where, and I have to be very frank and say that I'm not a fan of medical liability laws. I think they put doctors and midwives on the back foot, and it means that they can practice defensively, and in many cases we see them do that. And it's not just the medical liability laws. It is the fact that it's unpredictable. You don't know whether the court's going to go in your favour or not. You don't know whether, I was talking to a GP who said, we look at the cases every week and we keep saying that could be us. So there is a problem there with the medical liability laws, and nowhere is it more felt in this space, partly because the women aren't really getting access to justice, so there's no balance. And it is the case that when it goes to, and I'm sure my colleagues are not going to be happy with me saying this, but when it goes to a plaintiff lawyer, they will be saying to the woman, well, we're going to run this case on the basis that you were helpless and you didn't know what was happening and that the doctor should have taken over. Now, that is a cultural kind of clash with all of the policies we have of pushing towards patient autonomy. So it is holding us back in that sense. That said, most, if not all, the medical liability cases I've seen, the primary defence will be that consent was appropriately obtained, and in many cases the courts will find that. So obtaining proper consent is a defence in medical liability claims.
Okay.
So it is worthwhile.
So just one more follow-up question. You speak in your submission extensively about the role that the guidelines play in hospitals. Is there an opportunity to amend those guidelines to put in sort of timelines for seeking consent, and would that help in terms of improving information in the consent process?
Absolutely. I think those guidelines could be amended. When I read them, I too just think, oh, well, obviously this is why the staff would do what they do. If the guideline says you have to perform a vaginal examination every 4 hours, I have seen midwives being disciplined and losing their jobs because they didn't do that because a woman refused. Now, the guidelines should be drafted in a way that specifies that consent needs to be obtained and allow for the documentation of the refusal of that consent, so that it literally respects both the woman's and the midwives or the doctor's sort of boundaries. The other thing, of course, is that the first thing that we do, or the woman does, when she's about to lodge a complaint, is she gets her files first and she looks at her medical records, and if she remembers accurately that is what she said, often it diffuses the amount of frustration and pain that they feel. What is more concerning for them is when it's retrospectively added, or that she refused something and they know that didn't happen. Then it becomes a battleground.
Does the Honourable Natasha McLaren-Jones have questions? No. Dr. Amanda Conn?
I'm going to a completely different topic. Early in your introduction, you mentioned the coroner, and that the current coronial processes are part of the problem, and I'm interested in exploring that a bit further.
Sure. You want me to answer that? So we have been monitoring what the coroners have been doing, in particular for those women that we consider to be very much outside the system. So I know that Hannah mentioned before that there was a book published on birthing outside the system, and I was one of the co-authors for that. And what one of the chapters that we contributed is about how the coroners across the country approach investigations into infant deaths. And over time, I think what's happened is, of course, and it's a bigger social issue as well. I think there is an assumption that women relinquish their bodily rights or their reproductive rights as soon as they've gone past that first trimester. So we have coroners saying things like, you know, you don't have a right, hospital has a right to tell you what to do. They don't really, and that's not the law. And, you know, we also see coroners like openly criticising women for having political interests, and, you know, we don't see that kind of a public attack on men who have political interests. That is the very definition of discrimination.
The Honourable Emily Savard.
Thanks so much, Chair. Thanks so much for your time today. I was wondering, just looking at your submission, which I acknowledge isn't up online yet, there are some quite serious allegations in the submission. I was just wondering where the evidence is for these examples and if you can provide us with some specifics.
Would you tell me which ones? Because some of them would be privileged.
When you're, so in the opening point 1, in terms of the prevalence, goes through to list a number of different types of abuse.
Yes.
And non-confidential care and non-consented care, etc. There's quite a number of different examples.
Yes, so many of them, we do keep a register of all the complaints that we receive. And we will get permission from the women to use extracts of whatever it is that they're saying, and a lot of that is based on either the complaints or the matters that we have pursued on behalf of women who've come to us.
And are they women in New South Wales, women internationally, women in Australia?
The ones that I picked out are from New South Wales, bearing in mind that it's over the last 10 years, but yes.
Thanks for clarifying. The other question I had was around the BEST study. So it's true that you were involved in the co-design and funding of the BEST study. Could you describe what your role was in that?
Okay, so when the survey was finally put together by the authors, they released it to all the consumer groups and said, you know, we'd like your feedback. From my perspective, we just needed to make sure that none of the questions were at odds with the human rights obligations that we have. But otherwise, I kind of, you know, it's not my area of specialty, so I sort of left it to them. And the other aspect, of course, is actually when the authors came back to us and said they would like to extend the survey to women from non-English speaking backgrounds. That is exactly the kind of thing that Human Rights in Childbirth would certainly like to see a lot more of. And so the board agreed to give $500 to the University of Western Sydney, which matched it with another $500 in order to get interpreters to interpret the survey. So that's where our funds went.
Thank you.
The Honourable Griffin.
Thank you, Chair. Can I just return to our earlier discussion, and then very helpfully you made reference to the Human Rights Acts, and specifically the Queensland Human Rights Act. And I'm just looking at the provision here. I'll just read it out, then I'll ask you a question. So, Section 17 of the Queensland legislation says that the title, Protection from Torture and Cruel, Inhumane and Degrading Treatment. Then it's got a person must not be, it's got A, B and C is the relevant one. C, subjected to medical or scientific experimentation or treatment without the person's full, free and informed consent. Would you be able to explain, for the benefit of myself and maybe other committee members, what you understand to be the meaning of full, free and informed consent under that legislation?
Sure. So that definition is actually based on the human rights instruments that you know explain what full, free and informed consent means. So it's enshrined in international law, and there's a couple of cases that have since been sort of examining the definition in its full scope, particularly in the context of maternity care. It's actually not unlike the education that we've rolled out for sexual consent. So consent in relationships. Yeah. So it needs to be full in the sense that it needs to be fully informed. It needs to be free in the sense that it is, the information is given and the woman is left to her own devices basically to consider it, come back and ask questions. There needs to be an information exchange, but ultimately it's the right of the woman to say yes or no. It can be refused, and it needs to be timely. I think a big problem is that we don't give people enough time to consider their options. It's sort of a hurried process, even when it's routine care. And then, of course, it can be reversed. It must always be reversed. And I think that is something that women are not told in our health systems, is that often they know they're being sort of pushed in a particular direction, but they're too afraid to stand their ground, or they're too afraid after they've said something to turn around and say, well, actually, I've changed my mind. I don't want to go down that path.
But thank you for that. But in practical terms, that might be difficult to reverse. I can relatively envisage circumstances where if they have consented and a procedure or part thereof has commenced, it may not be possible to reverse it. It might be possible to stop it perhaps, but not reverse it.
Oh, I think the assumption is that the reversing happens before the procedure, obviously.
Right, okay.
Yep.
No, thank you for that. My next question, sorry.
I've just got one.
Can we just go back to your example, because I think it was an interesting one of the forceps and showing the woman the forceps prior to what might be a very short period of time before the actual need for the birth. Forgive me, I was obviously ignorant and unaware of this. I would have thought that, for example, that may have been discussed with women in those various courses they do. They're not, as I understand, the courses are not mandated, but a number of women enrol in them, and I think some of them are even paid courses or workshops to explain to them what's ahead of them. Is there not some of this done already, just for my edification? I mean,
so it depends on where you go. I think in the public sector, it is actually an additional cost and a constraint, and so antenatal education is thin on the ground. The best way...
It's thin on the ground.
It's thin on the ground, yeah.
Yeah.
The best way, obviously, is when it comes from the primary care providers. So the person who's doing the antenatal appointments with the woman would be the one who would be tailoring that information to suit her. And I can guarantee you that most care providers can already reasonably anticipate whether a woman is going to end up in that situation, particularly if she's got gestational diabetes, because the baby's more likely to be large, or if she's a particular age, or she has a history of very slow labours. Those are the kinds of things that would often be already something that's anticipated. I've had the privilege of visiting midwives who work in very regional areas, very rural areas, particularly in Indigenous areas, and their skill set in terms of anticipating what is going to happen to every woman in their care is extraordinary. And I do think that it's a skill set that we have really failed to capture and utilise to our best abilities as a health service. Most midwives providing that kind of antenatal care, if they are given the time and the means, will actually be providing much more in terms of that kind of education than really antenatal classes or generic antenatal classes.
And is it your submission that actual obstetrician gynecologists in their rooms with women who are going to have a baby, that isn't discussed or considered or raised?
It's not necessarily discussed, no. I think, and by that you mean the private sector, because in the public sector, the women may get one visit with an obstetrician beforehand, and it's probably more about deciding which path, whether she's high risk, low risk, or she's going to go in for a C-section or not. We call that a screening appointment, but generally speaking, they're dealing with the doctor in labour, at the pointy end of things. In the private sector, generally speaking, they don't. They do. Some hospitals actually private hospitals have antenatal education in place. And I mean, I haven't sat through any of them, but from what the women tell me, it's not really something that's discussed. It's considered too frightening, but I tell you what, for my clients, when those forceps are coming towards them and they're strapped to a bed, it's pretty frightening.
Thank you.
The Honourable Sarah Mitchell.
Thanks, Chair. I just wanted to ask about, I think it's page 14 of your submission, and I don't want to seem critical, and I'm sorry if it comes across that way, but just about routine interventions, and you talk about how the Department of Health guidelines mandate routine interventions, invasive procedures, and one of the dot points that's called out is screening for diabetes. But I guess I just wanted to put to you, and you just mentioned before, if someone has gestational diabetes, they're probably more likely to have a larger baby and you might need sort of intervention with delivery. So in here it sort of indicates that doing those screenings is a bit of or has an impact on the women's human rights. But I guess I would counter that by saying, if you want to make an informed choice as a woman giving birth, don't you also need to know if your risk factors have increased? And so things like having, your screening for diabetes or drug and alcohol test or whatever it is actually helping you make more of an informed choice when you're in that position, if that makes sense?
Absolutely.
Yeah. So can you explain a bit more why you put that as a concern,
Yes.
I guess?
So what we find is that it's not that the screening opportunities are there.
Yeah.
It's the fact that when women refuse that screening because they've been through it before, because they know that it's not going to make any difference to the choices they make,
Right.
they're usually risked out of certain models of care. So if you're in an MGP program or in a birth centre and you refuse the screening for diabetes, you can be sent back to the maternity ward. So it's almost like a punitive reaction to exercising a choice. And these are probably women who've been through it before and didn't see that it made any difference. And there are women who just don't want that level of, they don't want to know. There are women who refuse ultrasounds as well.
Yeah.
And, the problem is not that they get the information or offer their choice and they refuse. The problem is that they're penalised.
But then wouldn't they have to go back to that model because that risk is there that's unknown? Does that make sense? Because if you know you're low risk, you're probably better to be able to, or you might have more options available to you. Because I think what's coming through, certainly for me in the course of today, has been that information for women is really important so that they are making those choices with their consent, knowing what their risks or options are.
Yeah.
I'm
probably getting out of my lane a little bit, but from what we understand with the BMI and certainly for screening for diabetes, will be that it is going to end up being that the baby is bigger or that, that the labour is slower. But that too can be managed. I mean, that can be managed without it being labelled as a high-risk situation.
Yeah.
The problem is that once the classifications come in, and this is also part of a bigger issue that we have, is that just because someone is labelled high risk doesn't mean that they need to go back to fragmented care. In fact, our argument would be that those women are more vulnerable and they probably need continuity of care than anybody else. They're probably more likely to be either readmitted or having all these incidental problems because on top of those, underlying issues, they will have some kind of emotional or physical trauma associated with the birth. So we think, there are different ways to do it. And forcing the process or imposing penalties so that it doesn't seem like a choice would not be the way to go. I could probably, if you gave me as homework, 10 pieces of guidelines, I could probably rewrite them in a way that respects women's human rights within maybe a couple of hours.
Yeah, and that was just a little example that was there, but as I said, it's just about trying to understand the risk, the information, the informed choice, and how we can make that whole system sort of work maybe in a better way. But that just stood out to me a little bit. But yeah, thank you.
Does the Honourable Mark Benasiak have any questions on the
No,
The Honourable Anthony Diado?
Yeah, I just wanted to ask, so in the previous session, Professor Dallin made some observations about what I would probably describe as sort of system obstruction to private practicing midwives. I know you touch on that in your submission. Perhaps you might be able to elaborate on some of the systemic obstruction that's occurring in terms of the ability of private practicing midwives to operate in the system.
Sure. I did a PhD on that, which I just handed in.
I
guess it's in my. Is it in my covering letter? Did I make a reference to that?
No, it's on page 24. You actually referred to it.
Oh, okay.
Not to the PhD, but in terms of this
Oh,
issue.
okay. So yes, there are three areas that we have identified, and in my research, I found that there are three areas, one of which is that, and this is largely a federal government issue, but one of that is that a refusal to refer women. So in order to access Medicare through for the services rendered by a private midwife, women need to get referrals from GPs, and we frequently hear from women who say that they cannot find a GP who is willing to write a referral. And as I say in the submission, this is not to say that the woman won't access a private midwife. She can, but she will pay a lot more fees for that. So that's a lot of out of pocket. None of it is recoverable from Medicare. The second issue has to be with the refusal to collaborate. So anecdotally, because it's all very sort of, no one wants to come out and tell the truth about it, we know that there's probably about 20 obstetricians across the country who've agreed to enter into collaborative arrangements with private midwives, which means that generally speaking, private midwives who need a collaborative arrangement with a doctor in order to practice will shut down their practice. And this is especially a problem in rural and regional areas where there's usually one or two private obstetricians in practice. And the third is access to public tertiary maternity wards. So private midwives are entitled to make applications for visiting rights to public tertiary maternity hospitals. They have to make the applications to the LHD, so the local health district. The local health district will have a medical committee, although that has changed in New South Wales. They have a more generalised committee where the nursing unit manager or the nursing manager will sit with the medical providers. But it used to be the case, and it still is the case, that the LHDs will consult with the hospital for which the midwife has made that application. And if the hospital staff do not see it as feasible, then chances are the application will be rejected. And really, from a competition law perspective, what you would like to see is parity. So you would like to see at least matching numbers of private midwives as with visiting medical officers or private obstetricians, failing which you're really looking at a competition issue.
Thank you. Well, thank you so much for attending today's hearing. Unfortunately, our time has expired. If committee members have additional questions for you after the hearing, we've resolved that the answers to these, along with any answers to questions taken on notice today, be returned within 21 days, and the Secretariat will be in contact with you in regards to those questions. And thank you again.
Thank you, Chair.
Thanks very much.
Thank you.
Thanks for a great submission.
We're now stopping again for a short afternoon tea break. With us Mr. Waits, Mrs. Deng, Dr. Scarf and Ms. Weatherstone. Could each witness, starting at my left, please state their name and position title and swear either an oath or an affirmation?
Hi, I'm Gemma Deng, a midwife and a professional officer at the New South Wales Nurses and Midwives Association. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. Thank you.
Thank you.
Michael Waits, Assistant General Secretary of the New South Wales Nurses and Midwives Association. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. Thank you.
Thank you.
Hi, I'm Alison Weatherstone, the Chief Midwife for the Australian College of Midwives. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Hello, I'm Vanessa Scarf. I'm the Chair of the New South Wales branch of the Australian College of Midwives. I'm also a Senior Lecturer at the University of Technology in midwifery. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Wonderful, thank you. I might start by asking if somebody from the New South Wales Nurses and Midwives Association wants to give a short 2-minute statement.
Yeah, thank you.
Thank
I'll take
you.
that opportunity. So we thank you for the invitation to give evidence at this inquiry. The New South Wales Nurses and Midwives Association represents the industrial and professional interests of over 76,000 nurses and midwives in New South Wales. The association collectively advocates for our members on industrial and professional issues and also advocates on behalf of our members on human rights and social justice issues. Over 87% of nurses and midwives registered in New South Wales are women, and birth trauma is an issue that affects our membership professionally and personally. Both myself and Ms. Deng are midwives. Birth trauma is a significant physical and mental health issue for women and their families. It also affects the mental health and well-being of midwives who care for those women. This inquiry will be, and in some instances already has been, difficult for our members. People who strive to provide the best care possible, whose work exposes them to what can be the most positive experience in another person's life, but that can also become a traumatic experience, and sometimes the line between the two is a matter of moments. It will be difficult because they may have been involved in cases where they know more or perhaps less could have been done, and it will be difficult because of their professional and personal lived experiences. We hope this inquiry will lead to positive change and not simply lead to further trauma. Our recommendations to this inquiry are focused on 4 main areas: the need for universal access to midwifery-led continuity of care, improved workforce planning and design, and this includes the need for higher rates of pay and improved working conditions for midwives, improved access to education, and a review of the policies that impact on care provided. Our midwifery members strive to advocate for women in the care every day, but are often constrained by workforce shortages, which are at times extreme, and they can be constrained by the existing policies and, sadly, medicalised decisions that are based on a fear of litigation or complaints. Our recommendations are aimed at providing solutions that would address those constraints and ensure that our midwifery members are able to provide the highest standard of care. Our state and federal governments must act urgently to ensure that measures are implemented to prevent the physical and mental harm associated with birth trauma. Finally, we want to acknowledge the experiences of our members and the women who have come forward to bravely share their experiences. Their advocacy will be the catalyst for the changes that need to occur.
Thank you. Is one of our witnesses from the Australian College of Midwives wanting to give an opening statement?
Thank you. Yes,
Thank
we
you.
will. Thank you. Thank you for having us today to make a submission. The Australian College of Midwives is the peak professional body representing midwives in Australia. Midwives are primary maternity care providers whose scope includes the provision of women's health support, education and advice before conception, during pregnancy, labour, birth and for the postnatal period. Midwives are also experts in sexual and reproductive health. This means that midwives' scope of practice holistically encompasses the needs of childbearing women and their families through their life course. The Australian College of Midwives welcomes the New South Wales Select Committee inquiry into birth trauma. The college asserts that the recognition that birth trauma exists, indeed as research indicates it affects 1 in 3 women, is the first step towards addressing this critical issue affecting so many women in our community. It is also important to acknowledge that birth trauma and witnessing or being party to instances of birth trauma has a significant impact on midwives also. ACM surveyed its members with regard to midwives' responses to the inquiry questions and received over 200 responses. Some of the frankly distressing stories that midwives have provided are outlined in our submission. As one midwife said, people do not start their day planning how they will cause birth trauma. The key themes relating to birth trauma occurrence identified in our survey are 1. Poor communication and sharing of information with the woman. 2. Consent, lack of informed consent and coercion in the face of active refusal. 3. Management of emergencies such as postpartum hemorrhage, medical interventions, induction of labour, episiotomy for example, and workforce challenges, stress, time constraints, burnout, low staffing levels. Whilst midwifery education focuses on woman-centred continuity of care, many midwives indicated that they are unable to provide this in the existing system. It is compounded by workforce and cultural issues that can further impact on their care provision. Respectful maternity care is a fundamental right of all birthing women.
In our submission, the college has provided 6 priority recommendations for maternity service reform in New South Wales to improve outcomes for birthing women and their families. Number 1 is the New South Wales Ministry of Health to commit to fully funding all 10 goals and associated objectives of the 2023 Blueprint for Action, Maternity Care in New South Wales, with a completed implementation plan including benchmark targets, actualised, and further ACM would seek to be included in the key stakeholders for this implementation plan. The New South Wales Ministry of Health to review and implement service level agreements with local health districts to ensure the required structural and system level reform in maternity care as per the Blueprint objectives is included, funded and actioned. That every woman in New South Wales to have a known midwife and access to full continuity of midwifery models of care with targets as a matter of priority as per Blueprint objectives number 4 and 6. And the expansion of First Nations-led midwifery models of care in New South Wales. The development of obligatory multidisciplinary trauma-informed obstetric emergency and consent training, and the priority integration of privately practising midwives into New South Wales maternity services, including authority to practice within the hospital setting and enable hospital admitting rights New South Wales-wide for privately practising midwives. Evidence shows us that midwifery continuity of care with a known midwife, and for clarity, this is not the same model of care as the MAPS model currently utilised in New South Wales but across the full spectrum provides better outcomes for women, including improved perinatal mental health, minimised birth trauma, reduced intervention at birth and increased breastfeeding rates. It also reduces preterm birth by 24%, extending to 50% for our First Nations women. It is 20% cheaper than standard fragmented care. ACM asserts that structural reform of the New South Wales maternity services prioritising midwifery leadership and midwifery models of care with a known midwife working to full scope, such as midwifery group practice, will have a positive impact on a woman's birth experience and importantly give New South Wales babies the best start to life. On behalf of the Australian College of Midwives, we'd like to thank you for the opportunity to present today.
Wonderful, thank you. Did a member of the government want to start? Ms. Emily, the Honourable Emily Saval.
Thanks so much. Thank you to you all for attending here today. I just wanted to clarify, if I could, you are all midwives, is that correct? Wonderful. And back, going back to a comment from Dr. Scarf, which I had noted in your submission about, one of the quotes from your members about people do not start their day planning how they will cause trauma. I wondered if you could comment on the midwives that you have worked with in your clinical settings, collectively, and the type of people that it would be fair to say these are, in that, it extends to obstetricians. In particular, in light of this comment about people not wanting to start their day intending to cause harm.
I think all staff who work in maternity care certainly have the best interests of the women at heart. I think that there are a number of systemic and cultural and organisational challenges that present huge barriers to midwives, particularly practicing in a way that they would prefer and that they see would be in the best interests of the woman and their families. This would include enormous workforce shortages, but also a prioritisation of intervention, a lack of recognition of physiology in labour and birth, for example. But also there are systems around antenatal care or antenatal clinics, for example, where midwives are not able to give the woman the full, a satisfactory appointment because of time constraints, for example. So it's a multi-layered issue. And I think in regard to, I can't really speak on behalf of the medical staff, except just to, in observing them in my own practice. They're often overstretched. They're called to situations that, that may be deviating from normal. I think that medical staff would benefit, particularly in their early practicing years, to understand better the physiology of labour and birth rather than only being exposed to emergencies.
Yeah, I wonder if I can add to that. Excuse me. When you undertake a Bachelor of Midwifery or a Bachelor of Nursing in Midwifery, one of the first things you learn is the concept of beneficence and non-maleficence. So that is to do good, but above all, to do no harm. So as students in midwifery come through, especially now with their continuity of care experiences, they are looking to come into a model of care where they can work to their full scope of practice, but also protect that normal physiology of birth. And I think where you see midwives are the experts in normal birth physiology, and because of their skill adaptation for that, they have the ability to then consult and refer when anything deviates from normal. So I know in my experience in recent times as the Chief Midwife for the College of Midwives, we as a member organisation represent clinical all the way up through to advocating for policy with government. And so we have just recently made our student membership free for the Australian College of Midwives, and that was a really important strategy for us because our students are our future workforce. And when I see their submissions to engage with us at the college, you can see in their first, second, third year of study, they are so keen to go out into the workplace and put into practice what they're learning in continuity. Unfortunately, the way the systems are at the moment, these midwives are not able to practice how they're learning. And also we see that midwives are leaving within 5 years, but also in that 5 to 10 year middle career workforce bracket. So I think that concept of holistic care for women is definitely there from the beginning, and then it is shaped based on personal experiences and system structures.
I think, each and every one of our members turns up every day to try and provide the best possible care that they can. But the constraints within the system at the moment, particularly for the midwifery workforce, are real. We know that there is increasing shortages. You can turn up on your shift and not necessarily have midwives around you. You might have replacement staff working around you. But also when we look at the experience of the midwives within the system, point you to a report in Victoria, the Fuchsia report, that showed that the majority of midwives have less than 10 years experience. The association routinely does a request for government information, the GIPA Act, and we see through those figures that the numbers of midwives with more than 7 or 8 years experience has significantly decreased since 2017. In fact, nearly a 10% decrease in that. So you have this atmosphere at the moment where you go on to shift as a midwife, you're short-staffed, you're looking for the experience around you, and increasingly that experience is not there.
Sorry, Gemma, did you have
No, I'm nothing to add. Thank you.
Sorry, thank you. Excuse me, Mr. Waits, just further to your comments with that regard, there's been recent announcements of the MOU that the government has come to with the Nurses and Midwives Association in terms of the Safe Staffing Task Force, which I understand extends to midwifery. Do you have any comments on how that, how you see that as having a role in addressing some of these issues?
So we welcome the current government's commitment to implementing their safe staffing policy, part of which includes a review of Birth Rate Plus, which is the tool used by New South Wales Health to ascertain the staffing levels needed, and a commitment to deliver 1 to 3 in the postnatal wards, which will provide a significant workforce boost. I think the component that we are still needing to have further robust discussion with the government about is the quantum of the pay, because we know that rebuilding the workloads, making sure that the midwives understand that there is coming a better workload tool and hopefully their working conditions will be improved, that requires us to recruit and retain midwives. And we know that when you, as a midwife, the remuneration both in Queensland and in Victoria is better, particularly around caseload midwifery and the pay that is received for those midwives. So there's still some movement to go, but we're pleased that the government's made that initial step.
Thank you. No further questions, Chair. Thanks.
Thank you. The Honourable Mark Manasiak.
Yeah, thank you, Chair. Just a couple of questions. One that to you, Michael or Gemma, just in your submission you talked about a lack of adequate training in trauma-informed care based on a survey of your membership. Can you talk about what is available at the moment in terms of that trauma-informed care through the midwifery courses or CPD? Is there anything in that space?
My understanding is at the moment there is an online package that is available to the staff to do.
So that's not mandatory, that's just...
That's correct.
Optional?
That's correct.
Would you like to see something mandatory put in place as part of CPD or as part of the midwifery course?
I think it needs to be core of their ongoing training, absolutely, but another mandatory online package, quite frankly, isn't going to cut it. Actually, what we need is experienced staff that can train the skills and can provide midwives who are practicing the opportunity to is what we call reflective practice. So, you know, have someone with you when you're carrying out the function and to be able to sit down with you and debrief afterwards to help you improve your practice.
Yeah, I think we'd all, anyone that's been through online training would definitely attest to the benefit of face-to-face. In terms of the continuity of care model, we heard evidence this morning that there is actually not a declining midwife numbers in New South Wales, that it's actually the fragmentation of the workforce that is causing this perceived shortage. First, I just want to get some comments on that evidence, but also, do we have enough midwives at the moment to appropriately adopt this model of continuity of care, or do we need to go on a mass recruitment drive to actually get those figures up? And what would be those figures, I guess?
Can I talk to that one?
Yeah, sure.
So I think from the Australian College of Midwives perspective, there is definitely a maldistribution of the workforce across Australia. So they're predominantly in metropolitan areas, so that can provide challenges to rural and remote areas, but also there's differences across jurisdictions and states and territories in Australia. I believe if you look at your maternity service reform and strengthen your midwifery leadership, that will have a flow-on effect to the maternity models of care, and so the midwifery continuity rollout, because you need midwifery leadership from middle management all the way up to executive. We heard previously about the request for a chief midwife, but alongside that, you really need to bolster the leadership across all levels, because they understand the models, they can roll them out and they make them sustainable. When you've got a workforce that is attractive to work in, the midwives will want to work in it. So I think it's a awareness and an education piece, but also looking at how you can better utilise the workforce you've got now, and part of that is actually increasing the scope of practice of a midwife.
Mr. Waits or Mrs. Dean?
the figures that we have available says that New South Wales dropped from 9,533 midwives with practicing registration in 2021 to 8,669 in 2023. I know that there was a federal government workforce planning document that said, paraphrasing badly here, that our workforce planning is great, will be okay for the number of midwives into the future. At the same time that came out, there was literature saying, looking at the midwifery workforce, those who are going to retire, and looking at the burnout rate, we're in trouble. And actually that 2019 document was absolutely right. We are seeing experienced midwives, as I said, there's been a massive decrease in those numbers, corresponding increase as a percentage, obviously, in the junior workforce. But we also know that the senior midwives are reducing their hours to part-time, and that is a coping mechanism. And that means that you need more people to come in and fill those full-time equivalent positions if people are working part-time in order to cope with the workloads and the things that they're experiencing whilst they're at work.
Have you done any workforce modelling in terms of factoring in that burnout rate and that attrition rate, what you would need to recruit and what you would need to retain to reach that optimal level? Obviously, we're accepting that 8,669 isn't the optimal level of midwives, I'm assuming. Have you done any workforce modelling?
We don't have the access to the data that would help us or allow us to do that modelling. We're very keen to work with both the state and federal governments in doing that modelling, however. I think, to expand on my answer, so encouraging models of care that put the midwife at the centre of that model of care, midwifery-led models of care, allowing midwives to work to their full scope of practice are absolutely essential in helping us rebuild the nursing and the midwifery workforce into the future. But that alone won't be enough. We'll also need to look at the workloads, we also need to look at the remuneration, and we also need to look at work-life balance for midwives who are working in those group practice processes.
Thank you.
The Honourable Sarah Mitchell.
Thank you, Chair. Thank you to both organisations for your submissions and for coming today. I just wanted to ask, I think it might have been you, Ms Weatherstone, in your opening remarks, you said something about not supporting, I think it was the MAPS model, or can you just explain? I have no idea, just as a layperson, what does that mean?
So definitely do support the MAPS model.
Okay.
So that is continuity through antenatal and postnatal period. It's a version of providing continuity of care to the woman. However, they have a different midwife for the labour and birth.
Right.
So when we look at the data that we're presenting in terms of midwifery continuity of care, those outcomes and percentages are related to the full spectrum of antenatal, labour and birth and postnatal care.
Okay, thank you. I just wasn't quite sure about that one, so I just wanted to have that clarity. And also, I guess, just going on from that, I think both submissions talk, and I think you've been very passionate in your evidence today about the importance of having that continuity of care model. I want to speak briefly about, particularly for rural and regional communities, because obviously someone who lives in a regional town, but those workforce challenges are particularly acute, the further west you go from the capital city. And I just was wondering, are there any examples? I know New South Wales Health in their submission talk about a midwifery-led practice, I think, down in Leeton, but are there things that you know from your experience, and this goes across both organisations, where there have been some really good models in rural and regional communities, either here in New South Wales, in other places across the country, that we should look to emulate, that has been in place in the past that we could go back to? I'm just curious from that sort of rural, regional, remote perspective, what your insights are.
I could start with that.
Mm-hmm.
I know that Broken Hill had moved to a completely midwifery continuity of care model in a multidisciplinary team approach.
Mm-hmm.
So all women, Broken Hill has a reasonably small birth rate, but all women saw a known midwife for their pregnancy. I think that they have had the usual challenges of the younger workforce of midwives, having to take time off to have a baby themselves, etc. But that is a model that was established a number of years ago that was very successful.
Mm-hmm.
We have a couple of rural midwives in the New South Wales branch committee for the college, and the reports that they give us at our meetings are the same, and they ask me every time, has there been anything moving this forward? And generally they are that the midwives are not permitted to work to their full scope of practice in rural areas. And this is not only is it a frustration for the midwives who are there, but it's certainly a detractor for midwives who would consider going out to rural areas. One of the reasons for that would be that the leadership in that particular health service is generally a nurse without midwifery training.
Yeah.
So midwives understand midwives' work. The other thing is that it is very difficult to get obstetric services in some rural areas, and even to the point where it's difficult to get a locum to go out there to work with them. There are some services that have GP obstetricians, and I think that there could be more of a multidisciplinary approach to that. But rural areas are also a perfect place for an endorsed midwifery to be able to be, or an endorsed midwife to be able to provide midwifery care to women in a multidisciplinary team.
Thank you. Did anyone else?
Yeah, I think it's really important to expand birthing on country and birthing in our community models of care. In Queensland, they have a growing deadly families strategy, and we also had a national rural maternity workforce forum just in Canberra last week, where we discussed the challenges of rural and remote maternity care provision. And so looking at local co-design of what the community's needs are, so that you don't just have a one-size-fits-all approach to the models that are being implemented in these communities, but that being underpinned by the continuity of midwifery care. And so we also see there's hub and spoke models in South Australia that work very effectively, and I think one of the drivers would be that you need to have continuity of care targets, because there needs to be either incentive for the local health district to implement these continuity of care targets, or a disincentive if they don't.
Yeah, okay. Do you want to add anything? It's fine if not, but if you do.
Nothing to add.
Okay. Just a different question, but in the submission from the association, I think it's on page 18, you talk about the personalised alternative care and treatment framework that's in place in Queensland, just in relation to, I guess, women having, consent and be fully informed about their choices. I just wondered whether you could tell us a little bit more about that model, that if you know much more about it, and if you think it's working and effective and something that we should look at doing here.
Yeah, it's something that that goes further than just signing a form to say, I don't consent to having something that we have here in New South Wales. Something that's documented, that the women can write down their reasons for what they want within their birth, and so they can have that done at any time in the pregnancy, and they then don't have to repeat themselves if they're in that fractured care, or even if they're with the same care provider and everything changes. It's a living document, and it can also be documentation from the medical staff as to what they've been informed of. So we have, evidence of what the women want, and the reasons that they want that, what the doctors have explained to them, and what they've come to, to arrange together, and that lives within their notes. And then if they come in at any point in their pregnancy, labour, birth, it's there for everyone to see, because at the moment what we have is decisions being made in clinic that when they come in on a weekend and that doctor's not available, then that's not always upheld. So I think it is it's one trial that we've seen there. I think it needs further investigation, but I think it would be something to help respect women's choices, and make them feel valued in their decision making, because that's not something that's always reflected in practice at the moment.
Yeah. Do you know how long that's been available in Queensland? It's
I
fine
don't.
if not, but
No, I don't. I'd have to take that on notice.
Okay. Thank you.
Thank you. Dr. Amanda Cobb.
Thanks. We've heard from every witness so far today about the importance of continuity of care, and in the submission from New South Wales Health, they cite two barriers to implementing continuity of care more broadly, one being the midwifery workforce shortage, but the second one being difficulty with sort of the inflexibility of working models and working conditions, that the midwifery workforce is largely women, often with dependents, that on-call requirements are difficult difficult. So my question is to all of you in terms of suggestions that you would have for how New South Wales Health could offer that kind of arrangement in a way that would be attractive to midwives to work in.
I'm happy to give my point of view. I worked in continuity of care for 7 years, I midwifery the full with labour and birth, and I stopped having to work in that model of care because I had babies, and I don't have family here that can, you know, drop everything and look after my children for me. So I think childcare is a really big thing, as you mentioned. You know, women, mostly women in that model of care, so needing more flexible childcare, even just more flexibility with terms of part-time roles. So that wasn't something that was supported in the large hospital that I worked in, as they felt that that would not provide women with good enough continuity if we weren't there for them and if we were working in, say, a job share type role. But what that meant was that groups dissolved and there was no continuity for those women. So actually, you know, enabling people to trial part-time would be important. Remuneration, as we've heard earlier, you know, better pay for women in New South Wales Health. I mean, they might be able to afford more childcare, or they might be able to afford flexible childcare nannies as such, and so they might then be able to actually work in that space, and just greater acceptance and understanding of the role that we do, as there was sometimes a disconnect between what people thought you were doing in that role. It's very flexible. We may be in the hospital, we may be at a home visit, we may be doing admin, you know, heaven forbid, and so you weren't always visible, and there was an understanding that, you know, of what were those people actually doing, and appreciation for the work. So the short-staffed, when they were short-staffed in the hospital, often we were pulled into work in that framework, and then obviously our model was you know, being diminished there. So I think it's just having improved staffing and models for you know, escalation, so that there's better escalation models within the hospital, so that the group practice are not being fallen back on, and as I said, remuneration and perhaps childcare and more flexible hours work time. Yeah. Thanks.
Yeah. So I'll just add to that. I think sufficient numbers in the model, so that particularly if you're leaning into more of a team approach, but sufficient numbers in the model so that the midwife's caseload is manageable, so that they can take time off, they can have days off, they do get that downtime through that team-based approach.
So I think, again, going back to midwifery leadership, when your midwifery unit manager or your MGP manager understands the model, there's actually quite a lot of flexibility within it for the people working in that model of care. And I do agree that there needs to be flexible working arrangements within that model of care. I think you need to be innovative in looking at how you can incorporate graduate midwives and early career midwives to be working in these models. They want to work and they're workforce ready for continuity. So looking at how you can best support that. And there's some midwifery group practices in Australia that are purely run by early career midwives with the right support. And also, I think I have to agree with Gemma with this is an out-of-hospital setting. It's a community-based model of care. And so the knee-jerk reaction currently is to want to take from MGP to prop up rosters in hospitals. It needs to be the other way around. Yeah.
I think respect for the work that the midwives are doing in midwifery group practices particularly. If they're not seen, then there's an anxiety that they're perhaps not working. But in fact, as Ali and Gemma have said, community-based midwifery is actually definitely the way that we need to go. Women like to be seen in their own community.
Thank you. The Honourable Susan Carter.
Thank you, Chair. We've heard from a number of submissions that birth trauma is not something that just affects the women giving birth, that affects families, but it also affects healthcare workers. What sort of access do midwives have to vicarious trauma counselling or support?
Minimal in my experience. We as a midwife, we do a whole load of things, from wonderful, happy occasion births to really sad moments where people lose babies, and we try to be there the best we can for all those women. We can be delivering a stillbirth and hopping next door to then deliver the woman's live birth, and you're having to switch, the way you feel from one way to another, and that's really difficult, and it doesn't always allow time for counselling or discussion. And so it's really important that there's an effort placed on that. Clinical supervision, so there's lots of trials about clinical supervision at the moment, and it's mandated for some professions, but it's not mandated in midwifery. And that is protected time for midwives to be off the ward or aside from the ward, to actually be able to, talk to a professional about how they're feeling in a group situation, and doing other things to help them feel more positive about how they can best cope with their workplace issues. And midwives need to know that they can go to that and that can be valued, because at the moment sometimes if we are able time we get pulled back, same with education, so that you can have that protected time, and just having debriefs that are about the midwife and what the midwife wants to talk about, and not just to be assigned when something awful has happened to say, well, now we need to talk about that. It's actually what was happening for that midwife at the time, because right now there's not a whole lot. And we had a lot of comments, and we wrote probably some through our submission, of midwives who, have suffered this vicarious trauma, and this has been 20 years, 30 years, driving to work terrified of what might happen, blaming themselves for something that probably drilled down wasn't their fault, and just not having the opportunity to talk about it. And this is another reason why people are leaving the profession, where we really need to keep them in. It's something we need to look after our midwives so that we can look after our women.
If I could, sorry, interrupt. Just whilst the New South Wales Health has the employee assistance program available to staff, recently we've had criticism from members about the availability and literally stories of hanging on the phone for hours waiting for someone to pick it up. The amount of debriefing that they are able to access through that not being sufficient. And also examples where if a social worker is provided to the team, they're not someone who is specialised in this area. And so the midwives can actually be re-traumatised because they have to explain everything to the person that's meant to be there to help them with their trauma. So certainly the recommendations that Gemma just touched on, we would also say that the need for dedicated support staff within the public health system is greatly needed.
Just to add to that, I think there's an opportunity here to strengthen mentorship and mentoring in midwifery. I know there is a program in New South Wales, but I believe you should have mentoring throughout your whole career, and that should be structured from early entry all the way through to challenging you through to midwifery leadership roles. And also, I think we need to recognise that as midwives, we are impacted by birth trauma and vicarious birth trauma differently, so our needs will also be slightly different. So while we look at individualised care for the women, I think we need to look at what supports we're providing for midwives, and that is individualised, because we also at the Australian College of Midwives had member surveys come back to say that they've lacked support in this area.
I have a colleague who's doing a randomised controlled trial at the moment on clinical supervision in midwifery, and I think that's another way of supporting midwives in hospital settings and outside hospital settings. But to go to Gemma's point about having time quarantined, often, clinical supervision is on paper available to midwives. However, it's very difficult to quarantine the time.
So just so that I'm clear, clinical supervision, it's akin to what psychologists have as part of their requirement. And so subject to the results of the trial, perhaps that's something that could be mandated as required part of practice and time available for it. Certainly.
Yeah, in some states and territories, the midwifery group practice has that part of their localised agreement, so that's something that New South Wales could look at.
Mm-hmm. Sorry, quite a different question now. We've talked a lot about consent and the need for women to understand what it is that they are being asked to give consent to. Are you able to give us any idea of what type of antenatal education is available to women, who delivers it, when it's delivered, and what women might be told about in that process?
What women are told about in antenatal classes can be tricky and sometimes hard to facilitate, as women as individuals or families want different things from that education. Some women come in wanting to know everything and therefore may be able to give more informed consent. Some women and families come in and don't want to hear about what could go wrong, or that negative side of it as it affects perhaps their preparation for birth. And so it can be hard to standardise what type of information women can get through that period of the antenatal period. It's definitely one thing that came through in a recommendation that we made, that more antenatal education needs to be available for all, and some standardising within that, whether that's free antenatal education, if that's possible. I think through COVID we lost a little bit of that face-to-face, where online seems to be easier but not always as personable and as individualised. So it's something, and even just longer times in clinic. I know different hospitals can facilitate different amounts of time for their antenatal appointments, but that can be the time where women, if we can't capture them in antenatal classes, we can capture them in their antenatal appointments, and just having specific moments set aside for that extra education so that they do have more chance of being able to give informed consent is important.
Can I just add to that, please? That's absolutely right, and I think that, going back to, again, continuity of care models where midwives can work to their full scope of practice, the antenatal appointment, which is usually extended, also involves talking about labour and birth over the course of the pregnancy. It may also discuss those things like interventions. Even if interventions are only touched on in this period, if that known midwife is with the woman during the birth, they have a close professional relationship, and the woman trusts the midwife to talk through with her what's happening to her in that moment. Often emergencies unfold over a period of time. It's very unusual for there to be a catastrophic event occur without any sort of warning. So, and that's obviously a big part of labour surveillance. So a woman will trust a midwife who is caring for her in labour, and then, they can talk through, or do you remember when we spoke about this? Or, they can talk through what's happening in the moment.
I'm just exploring whether there might be an issue with antenatal education being available, not everybody either taking that opportunity up or not wanting to engage with some aspects of it, and then because they haven't engaged, not having the information that allows them to make an informed decision. Is that something that might be happening?
I think so. Yeah, I think expectations, again, was a big thing that came up through our survey, and that's just talking through members and how they're viewing what they're, what's happening in practice is sometimes unmet expectations can be a big part of birth trauma. It's not only the physical, as I'm sure you've heard and read through all the submissions, it's not just the physical side of birth trauma, it can just be there's unmet expectations. And if they're unable to access education, that leads to those expectations not being met, as they may be able to be discussed, as Vanessa's mentioned. If you have that partnership, that trust between you and the woman, you're then able to provide more education and discuss their expectations and give them more of an idea of what might happen for them in an individualised way to help lessen the trauma of what perhaps might happen.
Thank you.
The Honourable Greg Donnelly.
Thank you, Chair. Thank you for coming on this afternoon. I've got a copy of the New South Wales Government submission, the inquiry, which is submission 862. Just ask the Secretary, please. Thank you. Pass it up. You may well have had a look at the submission from the government. I've just got a couple of questions for the Nurses and Midwives Association, if I could first, please. So, could I take you to, please, page 11, and I think it's open on page 11, excuse me, and it's section 3.3. which says New South Wales Maternity Care Survey. I'll just give you just a few moments to read it. It's not very long. So that's now a few years old. It's a 2019 survey, so I made that concession. But in terms of those figures there, and without trying to look through things through rose-coloured glasses, because there are many issues that have come up over the course of the day, and I'm sure will in the following hearing days and submissions, does not those percentages indicate that there is in New South Wales currently operating, from the point of view of women and birthing, quite a reasonable level of satisfaction with the way in which it's occurring in New South Wales?
Well, the statistics that New South Wales Health put there may indicate that the majority of women are having positive experiences, but I would still be very concerned that 10% of women looking at that dot point are not treated with respect and dignity during labour and birth. And I would say 10% is a significant number that we should be paying attention to.
No, please, I'm not dismissing or discounting the percentage there at all. I guess what I've been challenged a little bit over the course of the hearing thus far is trying to understand, in my mind, what the level of birth trauma is. What is, first of all, what is birth trauma as specifically defined, that people can clearly understand what it means, and then apply that to New South Wales and have a clear understanding that that's the challenge we face in New South Wales. And also we have this added matter of the reference to the term obstetric violence, which is mentioned, of course, in the submission. And trying to make a distinction between those two, and when engaging women who are going to give birth about one or the other, is there a clear distinction between the two? And because trying to define something is really important. I think to be able to measure what the issue is, that can then lead to the steps taken to resolve the issue, or at least discuss what the resolution might be. Do you agree with that statement?
I think it would be, of course, useful to be able to measure the rates of birth trauma or obstetric violence occurring in New South Wales Health, so that we can set targets to then reduce them.
Do you have any thoughts about how that might be done, or how that could be done?
Well, I think you could ask women in the first instance what their experience was like, and if it was unsatisfactory, why. I think the system could be open to listening to the detail of that, and not being. I'm concerned that there may be a culture of being overly defensive and fearful of the litigation, rather than listening to what is being said and learning from what is being said. So, of course, these are processes that could be explored.
So, in terms of the New South Wales Nurses and Midwives Association, what definition do you use as the definition that you believe is the most accurate to describe birth trauma?
I don't know that there's lots of big organisations that have tried to define birth trauma, and it's self-defined. And I think that's what Michael's touching on there, is that it's self-defined. And I don't know that I can look after a lady that comes in, has a beautiful water birth, goes home, and she's traumatised by that because it was more painful than she thought. And that doesn't mean that the midwife caused the problem. That doesn't mean that she had, any other physical issues. That just means, wow, that was huge, and that's something I wasn't expecting. So that's one birth trauma. There could be birth trauma where there's physical, whether it's a forceps, an episiotomy, something, whatever will happen down that track. Birth trauma is so huge, and that's why I think to this point it's not been quantified. And by birth trauma's been around. Every time you tell someone you're a midwife, a mum, a grandma has a story.
Yeah.
You know, this happened to me, that happened to me. Birth trauma's not new. You know, birth trauma's just, women just have a voice now, you know, and that's why, you know, women are coming and saying, this has happened to me, not, well, isn't that meant to happen when you have a baby? Aren't I meant to be incontinent? You know?
Yeah.
So it's one of those things that now women have a voice, and we different organisations, as I said, are trying to put a definition to it. I don't know that we're going to be able to, because it's an individual, it's about you, and I don't think that we can capture that. But we can certainly have points, we can have groupings of themes, of things that we've all seen in our submissions. But I don't know that we are going to come to just one definition, because it's...
No, it may be challenging, but without discounting anything of what you've said, no, I think that's my thinking as well. If you take that example you've given of the birthing, and it seems to have gone prima facie okay, and that's been the feedback, but then a woman gets home, and then there's a subsequent sense of, well, this was a traumatic experience or what have you. If we are to establish the size and the level of trauma in New South Wales with birthing, that would have to be discounted or included in the count. Now, I know people think that why am I pushing the detail to this level, but quantifying the dimension of it is pretty important, because that then leads to, I think, questions of resourcing to deal with it. So do you say it's an individual experience and take that as the answer, but then do we accept that anyone who says I've had trauma, that simply gets placed into the trauma subset? Is that how we address it?
I think so, and I can only talk as personal experience of what I bring to this.
Sure.
I believe that if you say you have trauma, you have trauma.
Okay.
I don't believe anyone can tell you that you don't.
Right.
And I think we should then have whether we're talking about debriefing clinics or whether we're talking about associations that can provide support to every single woman that wants to have that support, because I can't tell you that you've not had it, and I'm not going to put you in a basket and say that you don't.
Sure.
So I think it does have to be individualised, and therefore, systems set up to support every single woman and husband even that is there, or family member present at a birth. Yeah.
Okay. And just for final question...
Sorry, could I just add to that? I think, too, that the response to birth trauma needs to be specific to the person who has experienced it. What we don't have at the moment, is sufficient staff on hand to provide a debrief for a woman in the postnatal period. It may well be that in the circumstance that Gemma just described and that you're using for your case study there, that the ability to sit down and spend time with a midwife and to talk through those issues is sufficient for that trauma to be resolved, or at least to be coped with. If you don't have the staff on of an evening to debrief women, or don't know why I said evening, but if you don't have the staff on to do that debriefing, whether that's in the hospital setting or whether that's in the home setting, then that trauma is going to remain. So some of the solutions to this are not overly complicated. It's providing sufficient midwives with sufficient skills in sufficient numbers.
And just a paragraph in your submission on page 6, just take you to it. Just trying to understand its full meaning. So on page 6, what is the paragraph below the first blue part at the top, which is in blueprint? It says the prevalence of birth trauma is inexorably linked to the patriarchal medical model in which the majority of women in New South Wales birth. Can you explain that to the committee?
I think there's been perhaps a too slow transition within how birth services are offered to women in New South Wales or Australia. It has traditionally been a very medical approach, and that medical approach has been dominated by men. An approach that says that the doctor knows best, the doctor will tell you what to do, you will be subservient to that doctor's advice. We would like to think that we're no longer in that sort of system, but there's certainly a long way to go.
And just going on.
Oh, sorry, Mr. Donnelly. Just recognise there's only 5 minutes left. Perhaps could you put some of those questions on notice?
Sure.
Thank you. Thank you all for coming today. We've already talked a lot about the continuity of care model, but both of your organisations specifically advocate for midwifery continuity of care, whereas some of the other submissions we've heard say that it could be, anyone, a GP or an obstetrician. Could I ask from both of you why midwifery continuity of care is what you specifically advocate for?
So I think in terms of, we've got really good evidence in Australia and internationally that midwifery continuity of care has demonstrated outcomes for women and babies. And that goes from breastfeeding rates, a baby's more likely to be healthy and born at term, lower likelihood of stillbirth and preterm birth. And this applies even to our First Nations women and families. And so I think if we're really committed to looking at the impacts that prioritising maternity care has across the lifespan and on the chronic burden of disease and well into aged care, we really do need to prioritise maternity care. And we have a primary maternity care workforce that this is their core business. And I think utilising each skill set in the interdisciplinary, multidisciplinary team to their full scope of practice will go a long way in addressing the maternity care needs across Australia.
Thank you.
I'm biased because I'm a midwife. And I've worked, in a midwifery continuity-led care model. And I believe too that birthing is women's business. And, there was a time when men weren't there and it was just us, not to say that was a better time, but I think that it's important to, and I think Vanessa touched on this earlier, is the midwives know normal, and that's what we want to try and keep as best we can, is to keep women as normal, midwifery as possible. Obviously there's going to be deviations and a lot more comorbidities, and I think we need to work in models where we consult and refer, and we've got guidelines around that and very, very clear guidelines that we can follow. But when it comes to women, coming towards us as we talk about the research, there's plenty of research to say that midwifery continuity-led care has great outcomes, and I think we want to try and promote and keep that women's business and keep that special, and use the obstetric team to refer to when things are outside of the norm, rather than making it the norm that we need to see doctors, because we need to step back and learn to trust in our bodies again, and to go down that midwifery-led model, I guess.
Thank you.
Could I just add to that from a budgetary view alone, it is more efficient, more effective to run midwifery-led models of care. Mm-hmm. So it just seems, given what my colleagues have just said, just a no-brainer.
Thank you. I note in the submission from the New South Wales Nurses and Midwives, you talked about a reoccurring theme in the feedback from your members, the use of coercive language. And I quote you, the submission says, implied or express consent given under extreme duress is not consent. How did we get to this point? And is there... where this is really, the way that women are being treated in hospitals, and it seems like quite a systemic issue. Are there certain pressures in hospital policies that are causing this, and what recommendations in this inquiry can we use to deal with this?
I think litigation is a really big issue, and lots of things are happening because we're worried about litigation, rather than perhaps, and I know Hannah Darla mentioned it earlier about, just having a live baby is the flaw, and it's just, we want to have more than that, and I think litigation is stopping us from doing that, and definitely policies. There's again a drive with policies, and a lot of, as Michael mentioned, medical models through our policies that are pushing. I've lost my train of thought. What was your question? push intervention. Yeah, exactly. Yeah, sorry, I've lost my train now, Michael. You might want to take over. Or if you could repeat the question, maybe. Sorry.
Yeah, sorry. And my question was quite long. I was talking about the coercive language, and that express consent under extreme duress is not consent. And how did we get there, and what recommendations really do we need to put forward as part of this inquiry to deal with this?
So I think a review of policy approaches that are they creating too many opportunities for intervention to be required where intervention is perhaps not required? Once you intervene, you start a cascade, which will lead to periods where consent was not provided, but you've wound up in that situation. But I think also getting the staffing numbers right, rebuilding the midwifery workforce, making sure that there are enough doctors on the shift that they can refer to each other, that they have that mentoring support available, so that, as my colleague said earlier, typically these things don't happen in an instant. So where is that advice and support in the build-up to the circumstances? Where is that communication with the woman early on?
Yeah, thank you. And just one last question. The submission from the Australian College of Midwives mentions reduced intervention targets, and this is something that's sort of come up a little bit because there's been a recognition that more interventions and certain interventions are linked with higher rates of birth trauma. And yet at the same time, it's quite difficult to have a target because you don't necessarily want emergencies not to have those kind of interventions. So how do we deal with that, where we're seeing that certain procedures are more likely to be related to birth trauma, and how do we, I guess there's sort of that grey space within it where there's the emergencies, and then what's coming into question now is that there's this grey space where these interventions are happening where it's not an emergency, and how do we deal with that?
Thanks for that question. I think you need to look at all of the barriers to these high intervention rates. So there are international targets. So for example, caesarean section rates. The World Health Organization has a benchmark for what is considered an acceptable rate for a caesarean section. Australia is almost more than double that. So I think when you look at all of the contributing factors to rising intervention, it could be workforce, it could be service capability of a health service, it could be time constraints and staffing, lack of access to certain models of care. So I think what needs to happen is that you need to tie in with some of the significant national pieces of work. There's a national scope of practice review, there's a woman-centred care strategy, there needs to be a national maternity workforce piece of work completed, but all of these need implementation strategies. So I think if you look at, for the college, it's midwifery leadership and continuity of care for access for women, then these are going to address these intervention targets, but also you're looking at a reduced access to vaginal breech birth, or there's less confidence around performing forceps, so that's going to affect the rates of instrumental births. So I think if you've got midwives making decisions for midwives, you've got consumers involved in each layer of consultation, and they're designing the model of care that they're wanting for their community, then I think that's going to be a step in the right direction.
Wonderful. Thank you all. And thank you for attending this hearing. We have gone slightly over time. Committee members may have additional questions for you after the hearing. The committee has also resolved that the answers to those, along with any answers to questions that may have been taken on notice, be returned within 21 days, and the Secretariat will contact you in relation to those questions. Thank you again.
Thank you.
Thank you. I now welcome our next witnesses. We have Ms. Deb Wilcox, AM, and we have Adjunct Professor Michael Nicol joining us as well. Could I ask each witness, starting from my left, to please state their name and position title and swear either an oath or an affirmation?
Thank you, Chair. Deborah Wilcox, Deputy Secretary, Health System Strategy and Patient Experience, and I'll take the affirmation. Thank you. I solemnly, sincerely and truly declare and affirm that the evidence I'm now about to given by me shall be the truth, the whole truth and nothing but the truth. Thank you.
Thank you.
I'm Michael Nicol. I am the Chief Executive for the Clinical Excellence Commission at New South Wales Health, and I'll take the oath. I swear the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God. Thank you.
Thank you. Would either of you like to start by making a short statement of a few minutes to the committee?
Thank you, Chair. I'd appreciate that. Thank you. Thank you. Can I just thank the committee for the opportunity to appear today? I would have liked to acknowledge the traditional owners of the land where we are here, the Gamaragal people of the Eora Nation, and pay my respects to elders past and present, and acknowledge any Aboriginal people here in the meeting. Thank you. I'd also like to acknowledge the bravery of the women who have shared their stories, and I want to acknowledge the distress that many of them have described. We are sorry this has been their experience, and New South Wales Health commits to listening and learning from what they are telling us. I thank the committee and the Secretariat for their sensitivity in response to the submissions. I would like to make a comment in relation to our staff in New South Wales Health. I've worked in and around health for about 4 decades, starting my career as a nurse, and I've had the privilege of working alongside and observing literally hundreds, probably thousands of staff in different parts of our public health system. There are around 170,000 staff who come to work every day to provide the very best care to their patients. As a system manager, it's our job to make sure they have the resources to do that. I think it's important to say that they would never want a patient in their care to experience harm or to have a bad experience. But sadly, we know things do go wrong, and there are times when we don't meet the expectations of an individual and certainly our community. But we do have a very strong culture of listening and learning to enable us to continually improve care. Our staff drive this very strongly. Every day, more than 200 women give birth in the system here in New South Wales, and there are expectant women in our care right now or soon to come into our care. It is important that they feel safe and not fearful in light of some of the information that's appeared in response to the inquiry. So again, I thank the committee for their sensitivity to this, and I urge any women with questions or concerns arising from the inquiry to contact their maternity service or the health professional taking care of them. Across New South Wales, almost 100,000 women give birth every year. Maternity care in New South Wales is safe. Maternal deaths are rare, and the number of stillbirths and newborn infants' death rates are low. We had a Bureau of Health Information survey in 2019. 4,446 women who have given birth in New South Wales contributed. 94% rated their care during labour and birth as very good or good. 90% of women felt they were always treated with respect and dignity, with 9% saying sometimes. 97% of women said a midwife or nurse asked how they were doing emotionally during a postnatal visit. And 283 Aboriginal women participated in the survey, and 7 in 10 said they had confidence and trust in their care. Now, these are obviously encouraging results, but we know that these experiences aren't uniform, and we have to listen and learn from the things that don't go so well as the positive. Listening to, connecting with and responding to women is key to our work. This is in fact the cornerstone of the consultation that's been taken across New South Wales for our Blueprint for Action maternity care in New South Wales. In fact, its headline is Connecting, Listening and Responding. Over 18,000 women and partners responded to 2 online surveys. 1,000 individuals participated in face-to-face consultation, and we received more than 500 public submissions. And this feedback is already helping us reframe and reshape our maternity services. There were some things that were very clear, and I think listening to some of the evidence today, there's a lot of alignment and consistency, which is pleasing to some extent. It is clear that it's not okay to simply measure maternity outcomes by physical outcomes alone, but also to include a woman's experience, and to use this as a way of improving maternity care at an individual, service and system level. The initial areas of focus that we want to concentrate on that seem to be resonating strongly is developing a way that we can routinely capture the experiences and feedback from women, ensuring access of consistent information during the course of their pregnancy, strengthening guidance for clinicians on how to obtain valid consent, recognising the importance of women being adequately informed to consider their options, make their own preferences and choices, and how we better support women who may decline recommended care. Trauma-informed care is recognised by the New South Wales Health System. We acknowledge the core trauma-informed principles of safety, trust, choice, collaboration, empowerment and respect for diversity. Earlier this year, we released an integrated trauma care framework, My Story, My Health, My Future, and it has 4 key assumptions that underpin trauma-informed care. Realising that our staff realise the impact of trauma, they recognise signs of trauma, they respond using the principles of trauma-informed care, and they seek to work to prevent re-traumatisation for patients. Trauma-informed training is available for our clinicians across the system, and there are a number of online guides for staff that are pretty busy, and it gives them a quick resource. In recognition of the need for trauma-informed care, we do undertake psychosocial screening of women during pregnancy and after birth, understanding if a woman's experienced domestic violence, migration-related trauma, previous abuses of any nature, and enables a midwife or the team caring for them to really make sure that care is appropriate and they're alert for signs of distress. In New South Wales, over 95% of women attending our maternity services are screened during pregnancy and after birth as part of Safe Start, enabling us to provide the right care. In relation to our services, New South Wales birthing services are networked. Our smaller hospitals are connected with tertiary maternal and neonatal services to ensure that all women and their babies are able to receive the right care. Our teams are made up of multidisciplinary teams who work together to aim to provide woman-centred care. And let me reiterate, we want women to have choice and access to the care when and if they need it. We understand that continuity of care, especially with a midwife, is important to women, and we're working to expand the number of different types of midwifery models of care available. But like all jurisdictions around the world, and particularly following COVID, recruitment of all staff has proved a difficult issue that governments at all levels are very focused on, and unfortunately midwifery staff are no different. We have rural incentive packages to attract and retain staff in rural health districts, and we've had considerable success. And we continue to work with local communities, the professions and the Commonwealth to see how we can better strengthen our workforce collectively. In the past 7 years, we've recruited an additional 500 midwives. That's full-time equivalent, so some may be working part-time, and we have a retention rate of around 95%. In closing, I just want to say that we are committed to listening and learning from women who have experienced birth trauma, whether physical, psychological or both. We work with over 700 consumers and clinicians actively across the system to build continuous improvement in the delivery of maternity services, and Professor Nicol will talk more around quality and safety. All of us in New South Wales Health, no matter our role in maternity care, are committed to ensuring women have a positive birth experience and receive safe, high-quality care. I look forward to receiving questions from the committee. Thank you.
Thank you. I too wish to begin by acknowledging the women, their partners, support people and clinicians who have bravely shared their lived experience of birth trauma. To all those who have experienced or witnessed birth trauma, we acknowledge and respect your feelings and experience. My name's Michael Nicol. I'm the Chief Executive of the Clinical Excellence Commission for New South Wales Health. Prior to this, I was the Senior Obstetric Advisor for New South Wales Health for over a decade. I've been a clinician for 40 years now, and 30 years of that as a specialist obstetrician and gynaecologist in New South Wales. I've been a long-time advocate for improving the safety and quality of maternity care in New South Wales. I'm also a fellow of the Australasian Association for Quality in Healthcare. At the CEC, we're committed to learning from the experiences that have been shared with us. We are dedicated to working collaboratively with all stakeholders to improve the quality and safety of all clinical care, including maternity care in New South Wales. The role of the CEC is to lead, support and promote improved safety and quality in clinical care across the New South Wales health system. We set standards for safety and monitor clinical safety and quality processes and improve performance of individuals, teams and systems in prioritising safety. We also have a role to play in developing workforce safety culture and their capability. Whilst there have been systems and processes in place for many years to support the delivery of safe, high-quality maternity care in New South Wales, the CEC recognises that there is a need to continually review, adapt, innovate and invest in safety and quality to ensure the provision of contemporary evidence-based, safe and respectful clinical care, including maternity care. At the CEC, we've invested in a range of safety and quality education programs, have a current focus on reflective clinical practice and just and restorative learning culture to foster a skilled, informed and competent workforce. We've invested in technology to ensure clinicians, managers and policymakers have access to near real-time data to inform strategic and operational decision making, to drive continuous quality improvement initiatives and to be able to benchmark performance against peers. We're committed to learning from adverse clinical events and near misses. We actively monitor adverse clinical events and provide system-wide advice, support and guidance to maternity services through our incident management system and processes. Whilst most clinical care is delivered safely, we're all humans and capable of making mistakes. Whilst we cannot eliminate human fallibility, we can act to optimise best practice and to moderate and limit the risks. Effective performance and efficiency are optimised when system factors are designed to accommodate the capabilities, limits and goals of people rather than simply requiring them to adapt. Nobody in the health system comes to work to do a bad job. Nobody comes to work to do a bad job. Human factors training that we're heavily promoting at the moment places the emphasis on considering what makes things go right, which includes ensuring staff are enabled to do their work in ways that work best for the patient. The CEC has an active maternity and neonatal safety program with a focus on human factors training. We're also involved in supporting maternity services on the ground through initiatives such as QUID's MatIQ, which is our near real-time data collection system, and maternity resilience assessments. These assessments are unique to New South Wales and assess the ability of maternity services to adapt following adverse events. At the CEC, we look forward to the future opportunities to further improve safety and quality in the maternity space in New South Wales, and I hope that we can contribute to positive outcomes from this inquiry.
Thank you. The committee resolved earlier to have free flow questions. The Honourable Sarah Mitchell.
Thank you, Chair. Thank you to both of you for your opening statements. I just had a couple of questions. Firstly, around the collection of data, and that's something that has come up today. Obviously, we've been speaking to various groups, and particularly we talked, I think, about the BEST survey that had been done, which I'm sure you're familiar with. And I know my colleague Greg Donnelly's been talking about some of the BHI data as well. But is there a need to have a better data capture of women who do experience birth trauma, and are there any suggested ways as to how we could better quantify exactly what's happening and how often?
Yep, thank you. I'm happy to take that question.
Sure.
And Michael may wish to add.
Yeah.
I think that's definitely right. Patient experience really is relatively new in terms of our focus in the health system. In 2020, we established our first Elevating Human Experience framework, which really started to give a system-wide approach to how we understand the experiences of our patients in much more detail. We've got a number of experience surveys that are routinely produced. Local health districts will do modest experience surveys in their wards and units trying to capture information when people are leaving hospital to see how it was, following up with them. So there is a variety of survey mechanisms going across the state. The Bureau of Health Information is an independent part of the health system that is, has very rigorous and methodology around its survey collection, and we've been relying on the Bureau of Health Information for independent advice around performance and experience and a range of other measures in the system for some time now. The next iteration for us, and it's evolved over time, and it certainly came out in the discussions with consumers and staff while we're developing the blueprint, is this area of experience measure called PREMS, patient reported experience measures. And these are questions that can be asked of patients in real time by the clinicians caring for them that will then go into the electronic medical record. So what patients are feeling and experience can be captured. The next clinician that's caring for them can see the sort of issues that are emergent. But also as a system, we can collate and theme up these issues at a sort of an individual level to a unit issue up into a statewide collection. So it will give us very, very rich information to understand what our patients are feeling, what they're experiencing, and what sorts of things we need to put in place. There's a number of disease areas, for want of a better term, where we have patient-reported measures currently running. And as I said, the intention is for our maternity services to be one of the next rollout because it came out loud and clear in our consultation.
Just in relation to midwifery-led sort of models of care, and again throughout the day there's been some evidence in relation to that and outcomes for women. I guess, and I know in your submission you talked about, I think, the example in Leeton where the local council, particularly in the community, were really behind it. So there's two parts to my question. The first is, what are some of the barriers or challenges for that midwifery-led practice, and particularly in rural and regional communities? And I suspect it will lead into workforce challenges. And interestingly, in the evidence given before by the Nurses and Midwives Association, they also spoke about access to childcare and how that can be a challenge as well. So in, I guess, the experience from New South Wales Health, what are some of the barriers to having midwifery-led practice? What are some recommendations that we could make to help make that more accessible, particularly to women in rural areas, because often it's not an option? And is it the sort of workforce challenges that are the main impediment to seeing expansion of that sort of model?
Yeah. Thank you. Look, as I said in my opening statement, the challenges with recruitment across the health system are pretty difficult at the moment, and it's getting a lot of attention with the Commonwealth and the states. There's a health workforce task force that the Secretary of Health is actually chairing, and there's a whole lot of work going with the Commonwealth Minister and with Immigration and Border Affairs and or manner to see what we can do to accelerate recruitment into the system. It would be fair to say in rural and regional communities that is difficult. We've had a number of strategies in place over many years in health to attract clinicians to rural areas. We have a rural incentive scheme at the moment where there are bonus payments and the like, and assistance with housing and various things to try and attract staff into rural communities, and that's had relative success. I think the last count, there was probably just over 1,000 additional staff in the last couple of years that have gone into rural communities off the back of that scheme. The variety of different models, and you're obviously right to say that women really do like these midwifery models of care. I mean, people want to have choice, but we get really positive feedback. Midwifery group practice does occur across the system, but I mean, Michael may wish to comment on this as well. Having a on-call roster is one of the limiting factors, and that's around having enough workforce and time out for people as well, because if you're on call and it's going to be continuous care with a mum, there's some logistical issues there, which is one of the reasons why the midwifery antenatal postnatal model, the MAPS model, became quite popular as well, and we get really positive feedback from women about that. You get continuity around your antenatal and your postnatal care, and there's a core group of midwives that would be available for when you delivered. Now, it may be that the midwife you've been dealing with antenatally is the one that delivered, but it does allow a bit more flexibility for our staff in terms of being on call. So I think we've got to target this recruitment issue from continue the work with the Commonwealth, because we've got a broader, employment recruitment issues. We have to really target our rural and regionals, because that's where we have, trying to encourage people to come, not so much in the city. And we need to keep working with the professions around what are some models that we can optimise, because this consistency and continuity of care is such an important part. And again, we hear that all the time, and I've heard it through some of the evidence given here this morning.
Did you want to add?
Yes, thank you. Look, one of my previous roles was managing a network of maternity hospitals, and even though that was in a metropolitan setting, the issue of sustainability is a real challenge. I've been a supporter of continuity of care models for over 20 years now, and I think I have a very strong track record with respect to that. However, in putting my manager hat on, sustaining services is really quite difficult. I'm not sure the perspectives that have been shared with the inquiry, but generally in the continuity of care models, we've traditionally had two groups of midwives: those that are early on in their career and those that are towards their more mature years in their career. Those that are in mid-career are having a family and often do not participate in these models. Whilst we've got a reasonable pipeline at that earlier end, we don't have that same guarantee at the other end of a midwife's career, and sustaining a workforce is really, really difficult. And I think that was the greatest challenge that I had in co-leading a service across 5 maternity services.
Thank you. I'm happy to wait.
Thank you. The Honourable Emily Savell.
Thanks, Chair. Thanks for appearing today. My question is to Ms Deb Wilcox. You talked about the maternity blueprint and other policies and plans in your opening statements and remarks. Can you tell me what New South Wales has actually been doing over the years to strengthen and improve maternity services in New South Wales?
Yeah, thank you. Certainly the blueprints, because we're about to kick off with our implementation, has really been the focus in the last little while, and obviously the pandemic has sort of hampered a lot of innovation in the system outside of work for the pandemic. But it's important for the community to know we're never stationary when it comes to the continuous improvement in the health system, and maternity care no different. We have a network of services across the state, as I flagged in my opening statement, where more hospitals that can do more complex care are connected to smaller services, and we continue to refine those referral pathways between those smaller hospitals with the larger ones. Connection with staff virtual care through COVID has actually been a bit of a boon, and it's created greater connectivity across the system. So if you're a rural clinician in a small hospital, having that virtual connection to someone in a metropolitan teaching hospital has really been strengthened. We've done a bit of work around what we call the maternal transfer redesign, and one of the things that we do know that does cause distress and trauma for women is if you have to have your baby away from home, and sometimes that's not going to be possible, but where we can keep you close to your family and your community is obviously what we try to do. And this transfer redesign initiative was really to look at a systematic approach to the consultation and the referral pathways with clinicians, and what we've been able to do is strengthen relationships, as I flagged, between the larger hospitals and the rural hospitals. We've helped clinicians with it's a decision-making tool that they can use to help make a better or a stronger clinical decision around whether a woman may need to move or whether that care can be managed locally. And they've implemented a test, and Professor Nick will be far more versed in this, that assists with predicting the risk of premature birth. So all of these things, your connection with your larger centres, understanding some of the decision-making and the risk management of a woman, and having some tools that help you predict how a woman's pregnancy is going to carry through, all helps to make good decisions of whether you can stay or whether you have to go. The initiative's been evaluated, and the good news was that we found that less women are being transferred for non-birthing clinical indications, so that local decision making certainly been stronger. And as I said, keeping people close to home is really important to us. More recently, we've built on that work with an initiative called Pregnancy Connect, and each LHD, local health district I should say, has had some funding to recruit an obstetrician and a midwifery lead to help coordinate the care of a woman. So again, it's about getting your access to your antenatal care for those women who are greater at risk, timely access to especially consultation, and increased support for those rural and regional clinicians through mechanisms such as virtual care. We've done a lot of work on our resources, and I know we need to do more. If you look at our website, there are quite a vast array of information on website in many languages, and that's a constant bit of work we do to update that. And the famous Blue Book is to be digital and well known to mums right around the state. We have fact sheets that you can see what sort of services your local hospital provides, so that women get a bit of an idea of what they can expect, and parenting guides in many languages, and some really lovely innovations around working with Aboriginal communities. And I don't know if the committee members had benefit to see the Finding Our Way, which is a piece of work that's been done with Aboriginal communities, for Aboriginal communities, to help with decision making around maternal care, and it's apparently one of the first in the world in terms of the model and how it's been constructed. We continued working with our staff on a range of culture and safety initiatives. As I mentioned earlier, the human experience work. There's a lot of activity in that regard, and that's all about our staff feeling valued in the workplace, so they have more resilience and empathy to care for women. And again, this is just ongoing work in the system. And as I mentioned, working to build on our workforce and looking at new schemes and opportunities that we can to encourage people to come into the midwifery space, and certainly to work in rural areas. So that's, again, an ongoing body of work. Thank you.
Sorry, did you have...
No.
Oh, I was just going to ask a few questions. We've heard a lot today about the Queensland model and things that are being implemented in Queensland, and I was wondering if we've been looking at those aspects in Queensland and what that are being quite sort of strongly supported, and if we are looking at implementing any of those in New South Wales.
I might refer to Professor Nicol, if I may, on that one. The one area that I could comment, and I'm aware of the Chief Midwifery Officer appointment. I'm also aware the Commonwealth, I think it sort of late September 2022, created a senior midwifery advisor. We do have a Chief Nurse and Midwifery Officer in the Ministry of Health, and we do have a Principal Midwifery lead as well in the division, and a deputy to the Chief Nurse, who happens to be midwife as well.
Yeah, and that was mentioned today, and the concern was that they are two enormous portfolios. So, like nursing is enormous, and then midwifery is enormous. And I think that's why it was advocated that there be a separate chief midwife. Is there any movement in New South Wales to do the same as what they've done in Queensland?
We haven't started to test that question. We do have, as I said, with the senior leadership we have in the nursing and midwifery branch, good representation, but we also have a large network of clinicians around the system that work on these matters too. It just doesn't come from the Ministry of Health. And I think there's nearly 700 clinicians, which include a large number of midwives, that advise on various clinical policy and models of care through the Agency of Clinical Innovation, and provide advice and support into the ministry. So the nursing and midwifery branch do a lot of work around the profession and development, look at things like the mid-start and mentoring and workforce-related things, working in concert with the workforce branch in the ministry. But we do have a very large number of midwives that are actively engaged with the ministry and the local health districts when it comes to designing models of care and looking at innovation.
Sorry to interrupt, but are they involved through that chief nurse and midwife? Like, how is that coordinated if there's no chief midwife?
Look, they'll engage at different levels. A lot of them will work directly with their local health districts, and within that there will be the directors of people and culture, where they'll be looking at their own workforce pressures and things that they might do bespoke to attract staff, for improved training, how you retain staff. They'll connect in through the Agency of Clinical Innovation, where, as I said, we do a lot of work around designing models of care and providing guidelines and policy, and they'll also input into the ministry in various parts of the ministry, depending on the nature of the work they're undertaking, and connection with workforce within the ministry would be part of that. So I think it's a devolved and diffuse collection of clinicians that we have working on various parts.
Thank you. And I think more generally about the model that's been introduced in Queensland, as well as the legislation, and getting your thoughts on that. It came up today that in Queensland, under the Human Rights Act, there's an informed consent law that doesn't exist in New South Wales. Again, is that something that is being looked into, and as well as the general model of maternity care that's now being put through in Queensland, and the support that is being put forward to the committee around that model?
Look, I think from my perspective, over the last decade or so, we've continually been scanning what's been happening in other jurisdictions to see if there's a better way of service delivery. As you've already alluded to, there are structural and legislative differences across the jurisdictions, which make some things easier, some things more difficult. Queensland historically has had a very different approach to the issue of consent, with very specific consent for individualised procedures, whereas in New South Wales we take a more holistic approach that consent is individual to an individual situation. So there are considerable differences across jurisdictions, but certainly we're watching what's happening in Queensland, and if there's best practice to be learnt from, we will.
Okay, so you're going to be looking at some of the results from this new Queensland model and any sort of data that comes through that?
Yeah, we're continually scanning what's going on both across Australia.
Can I just confirm what scanning means?
We have meetings between jurisdictions, particularly on the East Coast. There's a formal process. Queensland, Victoria, New South Wales meet quite regularly on safety and quality issues, for example, and a variety of clinical services are included in those discussions, including maternity services.
Mm-hmm. Okay, yeah, I just wanted to double check because scanning sounds sort of, we're just having a quick look around to see what's happening.
I should add too, Chair, that the Agency for Clinical Innovation, which is where, as I mentioned, develops a lot of the clinical policy and models of care, have a very, well-regarded evidentiary section where they actually look at literature, look at research, look at models around other jurisdictions to inform practice. And certainly clinicians are always connecting with their colleagues around the country and internationally and bringing some of those ideas back to the table as well.
Thank you. We've talked a little bit about some of the reasons why a midwifery continuity of care model is difficult to implement right now in New South Wales. And we've talked about workplace shortages and all sorts of different factors. I'm just wondering what's actually being done to address those factors, including any sort of shortage in midwives, so we can move towards some of these models which are going to provide that better care.
So the work with the Commonwealth, as I've flagged, is critically important because some of these recruitment issues aren't issues for us alone, and we need assistance, across the country in order to, in terms of the border issues and immigration and getting workforce into the country that COVID obviously had a significant impact on. And the Secretary, Susan Pearce, is chairing our health task force, workforce task force, to look at some of the barriers to recruitment and things that we can do to strengthen that. The work that we do in the ministry is around trying to support local health districts and to incentivise staff to come and work, particularly in the rural areas and our regional areas. And metropolitan colleagues, while there are difficulties there at the moment as well, it'd be fair to say, but probably not of the same nature that you see in the rural and regional communities. So incentive schemes, things we can do to attract people, accommodation, childcare, all of the things that the member formerly mentioned are all really relevant if you're going to make a decision to leave where you live to go and work in a country town. So we're very mindful of those, and those things are an active part of our recruitment and retention strategy.
Sorry to interrupt again.
Yeah, no.
When you say that they're a part of the strategy, you mean that all of those aspects are currently being implemented in New South Wales?
Not active, but we have a rural incentive program that's a funded program where we can provide incentives by the way of bonuses. It might be to find accommodation for a staff member. So it's really it's not a sort of a standard fit. It will be if we can recruit some people, here are a suite of things we have on offer to support you if you come, and that enables, so if it is childcare, it's accommodation, whatever it might be, then we can look and see whether we can support that requirement that they have to order to get them to come and work in a rural community. And those sort of incentive packages aren't new. There's been things that have been going on for quite some time, but it's making sure you tailor them to suit individuals. We also need to work with our universities. Clearly, the pipeline of students coming through. A student can study, midwifery at university straight out of school, or you can do your nursing and then do your midwifery training afterwards. So we want to make sure there's a strong pipeline. So our Chief Nursing and Midwifery Officer works closely with the universities. I think some of the other strategies that we have around mentoring, I think you've heard about the Mid-Start scholarships. What are the sorts of things we can do to encourage people into midwifery practice, and once they come, how can we keep them there to make it a supportive learning environment so they stay and it becomes their career of choice?
And so do you think with some of these strategies we could get to a place where we can implement technically that midwifery continuity of care model?
I mean, certainly we'll continue to optimise our recruitment of midwives across the state. Decisions around what the right or the preferred model of care might be in a local health district really has to come from the local health district in consultation with their community and their clinicians to understand what meets their needs and to still give women choice. So I wouldn't like to say with blanket wide we will be, this is what we're going to do, but I can give a commitment to the committee that recruitment of midwives is a priority for us, and optimising choice for women no matter where they live too is a priority. And we need that local consultation with community and with our clinical staff on the ground to work out what are the best models.
Thank you. I'm going to throw to Dr. Amanda Conn.
Thank you. I'm interested in talking about what you've called human factors in your submission, such as fatigue and stress. We've received an avalanche of submissions from healthcare workers who've talked about stress, fatigue, burnout, and the impact that has on things like communication, their ability to properly obtain informed consent, and the impact that has on birth trauma. Just before you, we heard from the College of Midwives and the Nurses and Midwives Association, and we had a good discussion around some of the initiatives or recommendations to support midwives in particular and nurses. So my question is relating to medical staff, and particularly junior medical staff. In the submission from the Nurses and Midwives Association, they posited or suggested that one of the reasons for poor communication and poorly obtained consent is that junior doctors are rushed and inadequately supported. I know that New South Wales Health is facing a class action from junior doctors for unpaid overtime, and that makes me concerned that the department may not be aware of the number of hours actually being worked by junior doctors if they're not being paid for those hours. So what is New South Wales Health doing to better support particularly junior medical staff?
Well, I'll defer to the Deputy Secretary around the question to New South Wales Health, but from a Clinical Excellence Commission perspective, we're very supportive currently of encouraging reflective practice, not just after events, but at the beginning of days, for people to express how they're feeling, whether they're feeling overwhelmed, whether they're feeling anxious, so that their colleagues are aware of their individual circumstances so that they can work better together as a team. But also reflection after and during the course of their shift. We're encouraging that as well. Clinical supervision is something that intersects with this a little bit, but clinical supervision generally has been applied to certain sectors of the workforce rather than all sectors of the health workforce. We see reflective practice, though, as being more holistic across the entire workforce, and that would be inclusive of junior medical staff. Supervision is in maternity services is always a difficult issue. Working in maternity is complex. It's a very dynamic situation with clinicians, whether they're junior or senior, whether they're medical or midwifery, being pulled in multiple directions. But at the CEC, we're hopeful that introducing training, particularly with respect to reflective practice, allows clinicians to see where they might be vulnerable and then being able to act on that with their colleagues. But the workforce issues that you allude to are not the purview of the Clinical Excellence Commission.
I didn't mean to bump the microphone, and maybe perhaps a supplementary as we move to New South Wales Health. In the process of this inquiry, I've become aware of a base hospital where obstetric registrars are working 1 in 2 on call. So literally every second night on call. I don't think any of us would expect that someone could provide their best quality care with that kind of roster. This is the type of thing I'm concerned about and would like to know what New South Wales Health is doing to address those kind of unsafe rosters.
Sure. If there's any specific examples that you would like to bring forward, we're happy to take those and look into it. I'm not in a position to talk to industrial matters or specific workforce as it relates to the ward and conditions for junior medical officers, so I'd have to take part of your question on notice. In general terms, though, I would say the issues around staff wellbeing have really been front and centre for some time, but no more so than during and following COVID. I would be fair to say almost every local health district would have a JMO wellbeing committee. In many cases, they're a subcommittee of the board or board members of the local health districts participate in that. And that is specifically designed for JMOs from across the local health district to come and raise their particular issues and talk through the things that are concerning them, enable a district to respond. And I think that local connection is incredibly important. There will always be the sort of industrial flavour of things or pay or conditions and all of those things. But in terms of actually hearing about the things on the ground that are actually troubling staff, impacting on them, providing care, these mechanisms are very powerful. And if I can speak from my previous hat as a Chief Executive of a local health district, one of the very simple things that the JMOs came forward with was that every trolley in the hospital was different in terms of where the IVs, the intravenous cannulas were and the equipment to take blood and the like. It sounds like a modest thing, and in some respects it is, but if you're very busy working nights and going from ward to ward, something simple like that can actually decompress a lot of stress for you. So those committees are incredibly important. And in general terms, the work that we are doing around elevating the human experience, again, it's not just about the patient, it is about staff, because we know if staff are feeling supported and valued, their resilience increases, their empathy increases, and that a patient's experience too is positive. You put those two things together and you actually have outstanding outcomes, both by experience and physical outcomes for patients. So we're very focused on a lot of things coming out of that work, and connected to what Michael was talking about with reflective practice. One of the things that staff have been very engaged with, and there's about 20 hospitals I think now across the state with more to come out this year, is around the Schwartz rounds, which are an evidence-based debriefing structure for all staff, not just medical, not just clinical, but all staff who are involved, to enable them to talk about their experience in relation to, might be a particular day was pretty difficult around a particular person. It's a very structured debriefing mechanism which allows them to reflect on that and to talk through their stresses. And with that, information comes from those sessions that can go back into the hospital executive teams or line management to better support staff. So it's sort of a learning process as well as a decompressing setting for staff involved in something difficult.
And just to follow up those sessions that you've just mentioned, is that provided on protected time?
It's provided within the working day, is my understanding, but I can check if there are ability to provide that outside of the work day.
I appreciate that being taken on notice, and my
there may be some
industrial
variability across the districts and how they actually run it, so I'll follow that up. Thank you.
The Honourable Mark Banasiak.
Thank you. We heard from the Nurses and Midwives Association about the, lack of knowledge of trauma-informed care, that they'd surveyed their members, and I note that you published a framework in February this year, which sort of details the how, the where, the why, but probably leaves out a crucial point, which is the when. So you have strategic priorities listed there, but no indication as to when you plan to achieve them or when you think you'll intend to achieve them. So I'm wondering on notice, can you go back on those strategic priorities and give an indication as to when you may achieve some of them, particularly things around providing education to hospital staff or health staff around this? I think it's probably a crucial starting point. If you want people to deliver informed care or trauma-informed care, they should actually be educated on it. So if you could provide some timelines as to when you plan to implement this framework.
Certainly, I'd be very happy to take that on notice. I can tell you the work is underway, and there are already a number of training programs through our Education Centre Against Violence and through our Prevention of Violent Respect and Neglect services as well. So there's a lot of activity underway, and I'm happy to report back to the committee.
Thank you. And just probably my final question, we obviously heard a lot about informed consent and education for women and their partners through the whole pregnancy process. And you've mentioned the Blue Book and other information publications. But my concern is if you look at some of these publications you provide, like the first one, Having a Baby, and while you provide it in all these different languages, I'm concerned that you're not catering for the 44% of the adults in Australia that have low literacy. And putting my 18 years of teaching hat on, I look at that 172-page document and I tell you now, someone with a low literacy is not going to read that document. They'll see the first page and just go, oh. So my question to you is, what are you actually providing in terms of information and guidance for those adults that have poor literacy, regardless of the language they speak? Because, 172 pages is just... Most kids or adults with that low literacy would just freeze and just go, I can't handle that, and just give up. So...
Yeah. Look, I'll take that if that's okay. Look, I think that particular book just perhaps needs to be considered more a reference book than anything else for women, just to go back to. Antenatal education is it's a dynamic thing, and it will change during the course of a pregnancy based on particular risk factors that develop or particular needs that develop during a pregnancy, and it really becomes quite individualised as you work through a pregnancy. So somebody who has identified needs such as low literacy, or if English is not their first language, then the system would certainly be using interpreter services or tailoring the information that is available to that particular woman and her family. So,
is there simplified versions of this information available that doctors or midwives can quickly grab and provide to provide patients?
There is at local levels. Do we have it at a state level? The answer to that is probably no.
Is it standardised across those local levels, or is it just up to the individual?
Well, again, context is everything. And, again, if I just draw on my previous experience, when I was working in northern Sydney, 1/3 of our women are from North Asia. So that's a very different situation to, say, Murrumbidgee Local Health District or Far West. We had to tailor the information locally with the consumers to address that particular population. So context is everything. Would I be confident? I'd be reasonably confident, though, that maternity services would use those source documents that are produced by the ministry as the sort of guide to what should be included in any local information development. But it's all about context for me. The context across each of our LHDs is so different.
Member, I could happy to come back with some more detail around that. Just at a statewide level, the issue of health literacy, to your point, won't be surprising that it's a very significant issue, and one of our priorities under our future health strategy is just that. And the University of Sydney with Western Sydney Local Health District have an outstanding health literacy hub that's been established, and we're about to use that organisation or that partnership to improve the nature of the communication and the health literacy needs of the community. So that's a work in progress, but I'm sure we can get you some feedback from
that would be great.
local health districts.
Health literacy becomes infinitely harder when you're starting from a starting point where someone's got low general literacy.
Yeah,
so,
thank you.
Thank you.
Thank you. The Honourable Emily Savall.
Thanks, Chair. Just further to my previous question, we have heard a lot through the submissions from women in Wollongong, where we'll be later this week, and also Wagga. Was New South Wales Health aware of the issues? And if you could let us know what you've been doing to improve the situation in that case.
Yeah, thank you. Look, obviously, we were deeply concerned as the experiences started to emerge, and I want to reassure the committee and obviously those local communities that the ministry and the local leadership leadership teams, taking this very, very seriously. I might just begin with Wagga. Clearly, the chair and members of the committee were familiar with the issues down there, and I think it's important if the committee would indulge me just to step through some of the things that have occurred over the ensuing months. The district and the Wagga Base Hospital are deeply committed to improving the experience there for women. In Michael's role at the Clinical Excellence Commission, a resilience assessment was undertaken, and perhaps I should ask Michael to speak a little bit to those, but that was done at Wagga Base Hospital with a range of recommendations to strengthen the capability and the policy and the work environment for the team down in Wagga Base. Some of the things that have emerged out of that is there's been a new clinical director of obstetrics and gynaecology has been appointed at Wagga Base, who started in the role just in April this year. They're working very closely with the consumer groups down there. I think that relationship is actually all the stronger for this, and there's a lot of alignment around what they both think is important. And they've started work together with them, co-designing with the consumers on a woman-centred model of care. They've established a 4 to 6 week postnatal follow-up service, so women can discuss the sort of support that might be required. Goes to this concept of the postnatal debriefing that you will have heard, I'm sure, a lot about during the course of today. And they're participating, Wagga Hospital itself is participating in a national preterm birth prevention collaborative, which is all focused on looking at improved outcomes for women and babies. They've introduced their early pregnancy assessment service and a hyperemesis gravidarum clinic in their maternity day assessment unit. An endocrinologist has just commenced to enhance their pregnancy diabetes service, and they've set up a senior steering group with members of the district, senior clinicians and consumers to oversee the implementation of all of the work that's come out of that resilience assessment. And then the Healthcare Complaints Commission too has finalised its report, and they've accepted those recommendations. They will form part of the body of work. In relation to Wollongong, I think the local health district down there is really working very hard with the local community down there. Again, I think strong alignment. Sometimes out of these difficult experiences, good things come, and I think the district and the chief executive have been working very closely with Better Births in Illawarra. They're working on how they can improve their continuity of care model, so the MGP and the MAPs that we've talked about here this afternoon. They're doing some more streamlining around their feedback and complaints processes so that women can more easily respond. There's formal survey mechanisms, but there's also very simple things that you can do for people just on an iPad as they're leaving, just to document their experience, and it gives the midwifery unit manager an opportunity to call a woman after they've gone home and talk through things. It's just about that ongoing connection. They're continuing to roll out their training and their recruitment campaigns to try and attract more staff, and I think just fair to say that they remain very focused on all the improvements that they want to see, and they'll do that in lockstep with Better Births and with their clinical teams there at Wollongong and Shoalhaven. Thank you.
Thank you. Well, that concludes our time today, so thank you both for attending the hearing. Committee members may have additional questions for you after the hearing, and the committee has resolved that the answers to these, along with any answers to questions taken on notice today, be returned within 21 days. And the Secretariat will contact you in relation to those questions. Thank you again for your time. That actually concludes our inquiry for today, and I thank all of our witnesses and yourselves as well. Thank you.
Thank you very much, Chair. Is it okay if I table
Yes,
our
absolutely.
connecting, listening and responding framework for members?
Yes,
thank
absolutely.
You. Thank you
Yeah.
very much, and thank you for your time and for your questions.
Thank you.
Thank you.